let me go through my topic.
Posterior polar cataracts are a unique subfield with its tight adherence to the polar lens opacity, leading to posterior capsule rupture and even nucleus droop. The reported incidence of PCR during surgery varies, with older studies reporting an incidence of 36% to recent studies saying 7%. Several modifications have been suggested to enhance safety during surgery. Most of these are variations in hydro procedures during phacoemulsification. Hydrodissection should be avoided. Hydrodelineation can be done to create a mechanical cushion of epinucleus. Inside out delineation and even pars plana lensectomy have been described. But in India, with its huge cataract burden, SICS plays a significant role, mainly due to low cost, easier access, wider applicability in high volume setups. Most residents are taught only SICS during their course. As budding ophthalmologists, it is ideal to be prepared to deal with posterior polar cataracts using SICS. Careful preoperative slit lamp examination should be done to rule out a pre-existing posterior capsule defect. After securing the superior rectus, initially, a side port entry is made to perform the rexus. We prefer to do rexus initially in an intact globe before creating sclerocorneal tunnel in case of compromised entry. While injecting viscoelastic substance, we need to be careful to inject only the optimal amount to fill the anterior chamber. Overfilling may increase the pressure on the capsule. Rexus should be of adequate size so as to prolapse the nucleus into the anterior chamber. It should not be too large so that if the posterior capsule gets compromised, enough rim is present to implant the lens in the sulcus. Next, peritomy is done, followed by creation of the sclerocorneal tunnel. The size of the tunnel depends on the size of the nucleus and the grade of associated nuclear sclerosis. Hydrodissection should be avoided. Instead, Simcoe cannula can be used to gently hydrate and remove the loose cortex. This should be avoided in cases of pseudoexfoliation and cataracts with weak bag. Simcoe cannula is advanced beneath the capsular rim so that the cortex is loosened from the capsule without pressure on the capsule. This gives an effect similar to gentle multiple quadrant hydrodissection. The nucleus is then gently tilted and prolapsed into the anterior chamber while injecting viscoelastic. Visco is injected during each turn of the nucleus and thus brought into the anterior chamber. Alternatively, gentle hydrodelineation can be done. Fluid is injected in multiple sites in a controlled manner. The endonucleus is thus detached, creating an epinuclear cushion. Again, Simcoe cannula can be used to prolapse the nucleus into the anterior chamber. Now, the nucleus is delivered using vectors, taking utmost care not to injure the capsule or the iris. This is the step most associated with posterior capsule rupture while doing SICS. The remaining epinuclear bits can be cleared using visco expression itself. The next step is cortex wash. The cortex is held at the tip and brought from the periphery to the center in a pattern similar to the reverse blooming of a flower. Sometimes a pseudo hole may be seen at the center, which may be mistaken for a PC rent. If a central plug remains, it will be prudent not to touch it and cause a PC rent at this stage. Instead, a YAG capsulotomy can be planned post-operatively. The IOL is inserted after careful inflation of the bag. Even minimal trauma by the IOL edge can cause a tear in the thin posterior capsule. Avoid excessive manipulation of the IOL in the bag. After washing out excess visco, wound is hydrated, main wound is sutured if required. Posterior polar cataract is a true challenge for cataract surgeons, but SICS is also a safe option to be kept in mind for those surgeons who are not yet well versed in phaco emulsification. We need not get intimidated, but be well prepared.
Great presentation. Well done surgery, even better documentation. So I just wanted to ask, is this your preferred approach for polar cataract, or is it just that you wanted to demonstrate how it is done?
Yeah, it's not a preferred, I do fake only, but there are junior residents and also fellows in our center. So if you want to teach SICS in all these cases, I should demonstrate somehow they should be treated. So it's a demonstration video. So.
The second thing is, if it's a very soft cataract with almost no nucleus, then how would you prolapse it into the anterior chamber? Would you still take the Simcoe cannula and go below, or would it be some other technique? Many polar cataracts don't have a nucleus.
Yeah, I have shown that I'll be using a hydro delineation also. By hydro delineation mostly if it's a soft type of cataract. So I won't be using a Simcoe in that case.
Okay.
In that case, multiple hydrodelineations can be done.
Yeah. Yeah.
Have you thought of using a bimanual technique when you're using a SICS now? Because when you use your Simcoe, the EC fluctuations are not. Even for your resident training, you can always use a bimanual irrigation.
Yeah, in a
chamber gets maintained.
yeah.
You can also use a dialer to manipulate the software.
Yeah. But my centers and all in Kerala, they are not much well versed with the bimanual. They are still using the Simcoe. So I need to teach them in that way. So it's a technique. Okay, thank you.
I request Dr. Ronak to come and present his video.
Good morning, everyone, and good morning and thank you to YOSI. So this is just an educative training video for corneal surgeons who are usually transitioning to endothelial keratoplasty and from DSEC to DMEC. It was one of the biggest challenges for a corneal surgeon. So let's just see the video. Training video for DMEC graft preparation, highlighting some of the important steps in the DMEC graft preparation so that there is no need for a backup tissue. Some of the important steps are as follows. The mounting of the rim, make sure the block is dry. Then you move on to a partial 9.5 mm trephine. Then scoring of the Descemet membranes, avoiding radial tags. Coming on to the peeling of the Descemet membrane, which should be partial. Then moving on to the F stamp, which is an important step for identification. Then a full peel, and then loading in the glass tube, and finally ready for orientation and insertion. So we'll describe each step in detail. Starting with the mounting of the rim, make sure the back of the cornea and the Teflon block are dry so that it's easy to handle it. A light partial 9.5 mm trephine so that you can demarcate the margin where you have to start peeling again. Stain the margin so that it aids in visualization. Mark the start point of your peeling and scoring of the Descemet membrane. Identify problem areas. Start with small radial peels in clock hours. Look for any radial tears. Make sure that you're doing all this under saline and not dry. peeling the descent membranes by identifying an area and pull towards the center, keeping in mind that the periphery and center should be under equal tension. You can just pull 70 to 80% and not completely, and leave it. Make the bed dry. Take just slightly away from the center, but well incorporated during the final graft. Float back the peeled descent membrane. You now need to flip over the corneal pinch, which is also a good sign because it helps to put it back. Dry the surface using a sponge so that the F stamp does not smudge. Proceed with your stamp and put the button back. Make sure you're gentle so that there is no puckering of the graft in the cap, which creates a problem during the final trephination. Stained and the unstained area of the graft. The unstained is the non-peeled area. Take a 8 mm trephine and make your final punch. Make sure it's full thickness. You free the edges and lift it gently. And then you will tags so that it helps in the final peeling. Now from the peeled area under saline, you can proceed with the final peeling again with your blunt forceps, keeping in mind the central and the peripheral tension on the graft. Lift it and put it back in the saline bath. And now you're ready to transfer it to a dish for loading in the tube. At this time, you can proceed with a deep staining so that it helps in visualization during surgery. Make sure it's for 45 to 60 seconds. Remove the excess stain using Merosil sponges in opposite direction so that the graft does not float towards any one side and gets manipulated. Now the stained graft, you can transfer it into a petri dish, glass tube, and try to load it on the open larger end from behind. You can connect a IV tube structure on the front side along with a 5cc syringe for easy loading. Once you've loaded it, you can check for its orientation, and at times you can push it back and forth to try to get it into a double scroll orientation. Some of the take-home points are: makes transition easy if you practiced in the wet lab, avoids the need for a backup graft, and it is not justified to waste precious tissue which could have been used for another patient. Okay, thank you. Thank you.
It's an excellent teaching video.
Yeah.
So you've not shown the part afterwards putting it into the eye. This is only half.
This is part of 2 videos, but because of time constraint, I wanted to show it a more detailed training video because every step is very critical. Because the challenges surgeons face are, there's always that need of a backup graft, and which is not always available. So mastering at least all the finer steps, like even holding 1 or 2 Merosil sponge, because the DMEC graft is very easy to dislodge, or you can lose the graft or have excess manipulation, loss of endothelial cell tissue. So this is just for the graft video.
Okay, and so you've shown everything done very perfectly. At what stage is the most likely chance of a problem happening here?
So the chances of problems are during the peeling of the graft when you have radial tears. So once you have radial tears, and then when you do a final peeling, the graft will definitely have tears. So how to tackle those radial tears are also important, like how you do a rexis and there's a runaway, you'll do a Little's maneuver. So in this also something similar, you can at the edges do a radial tear, because it depends on the age of the graft also. If it's a young donor, if it's a pediatric case, sometimes scoring of that early descents and to initiate that start point is very difficult. It's like that.
And when you are retrefining it
Yes.
finally, at that time, if there is a big tear or something,
Correct.
do you have to discard it, or is there any way of using it?
No, so you can. It depends on how big the tear is. Sometimes there are surgeons who have done a hemi DMEC also with that. But it depends on your skill and technique, how to load it, and then again when it goes into anterior chamber, to reorient it in the double scroll fashion all is important. Finite minor tears can be managed once you have refined it, because then you don't need to manipulate and peel it off, which the radial tears won't extend so much. So you can eventually load the graft into the eye.
And I think one part which you skipped was while once it is rolled up.
Yes.
You know, whether it is rolled in the right direction or no, I think that part was skipped. You just showed it getting
Correct.
loaded in.
So there are techniques to identify it. There's a V sign depending on the staining of the graft. Eventually, sometimes you need to make it into a double scroll technique by pushing it back and forth, so that once you load it in the eye, and there's always an F stamp. The stamp is the most important part for visualization, because at least in Indian population, when the irises are darker in color, not like the Western population or the Caucasian where the iris is light and there's a good contrast, you need that F stamp to be very visible, and you can eventually identify it with the orientation of your stamp.
But when you load it into the
yes, so the loading, it usually scrolls up on its own,
okay.
and then it can be loaded. You can see the dark and the light side.
Okay, fine. Okay,
Yeah,
thank you, doctor. I think Dr. Sonam, you're ready? Yeah, we'll go with you.
Good morning, everyone, and thank you, YOSI organizers, for this opportunity.
In severe kyphoscoliosis. There are no financial disclosures. A 65-year-old female was referred for cataract surgery to our institute. On examination, her best corrected visual acuity was 612 in the right eye and 618 in the left eye, with normal intraocular pressures. She was a known case of severe kyphoscoliosis and was unable to lie flat on her back for the past 15 years. This is the CT of her spine showing diffuse ankylosis with severe kyphotic deformity of the lumbar spine. There are various challenges in cataract surgery in kyphoscoliosis. The first being inability to recline. Most of the patients have a stiff neck, which makes it tough for the patient to lie down for long. The OR logistics requires modifications, and the surgeon and patient positioning needs to be tackled. Literature review shows standing phacoemulsification as one of the earliest techniques described in 1994. Here, the surgeons use a loop to perform the surgery. Other techniques include use of orthopedic chairs in treadle-level position. This technique increases the risk of positive vitreous pressure. Techniques such as face-to-face seated position or phaco-sit has been described, where the surgeon and the patient face each other. Here, the patient is quite comfortable, but the surgeon acquires quite an unhandy and awkward posture, and the microscope requires to be tilted. Our initial plan was phacoemulsification in standing position. Due to our experience with the same, the following changes were made in the operating room. First, the table was brought down to the lowest possible level. The head end of the table was bent up to 90 degrees. We added a few pillows for the neck, head and leg support of the patient. But to our disappointment, the height of the table was still too high and surgeon could not obtain a good posture to operate. Now we had to think of an alternative solution. We took two small stools, one for the operating surgeon to stand on and the other for the foot pedal. So, with these 4 modifications, we were confident enough to go ahead with surgery. Phacoemulsification with IOL implantation from an elevated platform. We performed the surgery under topical anesthesia with intraoperative mydriatic agent. Topical anesthesia gave us an advantage, as even though the patient's head was vertical in position, we could ask the patient to move her eye upwards for better field of view. Secondly, we stood in the temporal position, as temporal phaco also gives us better surgical field. Most of the steps were similar to that of standard phacoemulsification, except for the fact that one foot, that's the right foot, was on the top of the stool, so it needed a little practice but was not cumbersome or awkward. We implanted a trifocal IOL inside the bag. Intraoperative course of the surgery was uneventful. Patient was comfortable during as well as after surgery. In the post-operative course at 6 weeks, her best corrected visual acuity for near, intermediate as well as distance vision was good with hardly any aberrations. Using the same technique, she subsequently underwent right eye surgery with good results. To conclude, despite advanced technology and design, our surgical ingenuity may face challenges. Creative approaches, modifications and innovations are essential for success in kyphotic patients. Recomulsification from an elevated platform ensures optimum patient comfort. Thank you.
Thank you.
It's a very nice demonstration and you did very well. It requires a very experienced person to do such kind of surgeries because these patients are not very cooperative. They may face pain and they say we have to get up and all. So you did a good job. It was a nice presentation.
Thank you.
Dr. Sonam, is this your surgery?
Yes.
And how many such patients you have operated?
Yeah, so starting from my residency, I remember the first patient of mine was a transscleral IOL. So the patient again had kyphotic deformity, but over there at that time only just by doing a standing TSF was possible. But in this case, because of the severity, the sheer severity of her deformity, just standing was not comfortable. So overall, if I count, starting from a residency, this one would be my 4th patient. Yeah.
Okay.
This one being bilateral, so the fifth eye, yeah.
So I would, by seeing the video, I would think one of the biggest challenges would be to weigh yourself on one leg while using the, other leg on the phaco foot pedal.
Yeah.
That could be quite challenging, especially because you're standing on a stool. And the other thing is, it looked, the exposure looked quite less. In the sense, I felt a block probably would have made things slightly easier, little more exposure.
Yes.
And especially when, you need your other leg to control the microscope movement as well.
Yeah.
So how did you take care of that? I mean, how was your other leg using the microscope, or did you not move the microscope
Yes.
at all?
So again, like in any other, like in standing phaco also, initially we need to focus the microscope well, because again in standing position, using your left leg to left foot to focus and defocus is little cumbersome. And of course, with the standing thing, the microscope control is not with us. So first and foremost, making sure that we are focused well, and and then we do ensure the patient is not moving much. Otherwise, we will have to again refocus with the microscope. That's one limitation of the surgery. But pre-operative counseling of the patient, if you know that the patient is has understood the procedure and she knows what she's getting into, so she was quite confident and that she's going to cooperate under topical anesthesia. So pre-operative counseling is extremely important for any topical surgery for that matter. And our patient was quite motivated and she understood clearly what and the instructions. So yes, in the patient who may not cooperate, who is too anxious, a block and with maybe a stay suture to pull the eye up that has been described in literature would definitely work. But in her case, she was able to follow our commands. So,
how comfortable were you while operating, and what was the surgical time?
Surgical time was around 20 minutes, phaco time, apart from the other logistic changes that we did. But yes, it does take some time to prepare ourselves for the surgery. Surgery itself may take less, but the preparation for the surgery requires help from the nursing staff and the OR team.
But during the surgery, how comfortable were you while operating? Because whatever said and done, I think surgeon comfort is also as important as patient comfort.
Yes, yes.
So how comfortable were you in this position?
Apart from just, I guess the only thing that I mentioned in the video as well, that the foot pedal control, just because I feel that apart for any other surgery also, if you are standing, it is little challenging, yes, but I did not feel much of a challenge in that. But yes, it does require a lot of only an experienced surgeon should perform this, but not a new surgeon. But yes, it is, I think, compared to other techniques where you have to sit and face the patient, your hand is outstretched totally. So that outstretched phacoemulsification may be more awkward and uncomfortable for the surgeon. So you have to weigh in what's going to be more challenging for you, whether you're standing or whether you're sitting. Kyphotic surgeries are anyways a challenge. Yeah.
Good job.
Thank you. Thank you so much.
Who do we have next? Priyadarshini and Kanchan, your Kanchan.
Yeah. Niche, last.
I invite Dr. Aditya.
Wrestling.
Sorry.
Strength, determination,
Hi,
and
how are you?
resilience are the cornerstones
So,
of success.
only
But
financial
what happens
interest
when
is
these
of
qualities
Sylvester
are
Stallone's in
tested
this?
to their limits in the realm of ocular trauma? Our story unveils a champion's journey through repeated ocular injuries, surgical interventions, and an ultimate transformation. 6 years ago, a national wrestling champion stepped into a boxing ring to represent his nation. The clash of titans left him with a subluxated traumatic cataract, threatening not only his vision but his very career. Guided by skilled hands, the champion's story entered the operating theatre. Slow and steady hydrodissection was meticulously performed, and the soft nucleus was cart-healed with delicate finesse. Phacoemulsification followed an intricate dance, ensuring no stress or further zonal damage to the weakened zonules. The stage was set for a transformative moment. Capsular tension ring was introduced, which is a gradient of stability, lending the strength to the ocular complex. Followed by an intraocular lens, which was placed with precision, like a key fitting into a lock. But life's arena isn't confined to a ring. Years later, a formidable punch left the champion with a dangling IOL, casting a shadow over his journey. It was a challenge that demanded innovation. The spotlight turned to the operation theatre again. A corneoscleral incision was meticulously crafted, revealing the intricate puzzle of the dangling IOL bag complex. With the grace of an artist and the use of fixation forceps, delicate maneuvers removed the complex in toto. Iris Claw IOL with retropupil fixation held the promise of renewed vision, reigniting the champion spirit. But the true climax was yet to come. A devastating blow, more forceful than any before, ripped open the corneoscleral wound, exposing the upper iris. The champions were plunged into darkness as flashes of light flickered. The surgical symphony unfolded as the champion's journey reached its end. The Yamane technique emerged as the star, a delicate dance to implant a new IOL with unparalleled precision. Simultaneously, the exposed iris was lovingly reconstructed with the photoplasty method, each step a brushstroke to the canvas of his vision. Today, the wrestling champion's identity has transformed. No longer the fighter in the ring, he stands as a beacon of resilience, guiding a new generation towards their own victories. His story is more the sum of its parts.
It's a testament to the indomitable human spirit.
I hope that woke everybody up.
Good morning, Dr. Aditya.
Good morning.
It was a nice presentation. Didn't you ask the person to stop boxing?
Yeah. This is the last surgery I'm ever operating in your life, so please quit. So he's become a coach now.
Acha, you put CTR after phacoemulsification
Yeah.
on the surgery.
Yeah.
Would it be better to put it prior to after hydrodissection?
Yeah, so we do it at whatever stage we feel deemed necessary. But as surgeons, we try to avoid, or you would decide based on when you're comfortable putting it. So we've done both. I prefer to do it in this fashion, so I generally do that.
Have you ever tried to, the back was, IOL back complex was dislocated. Have you ever tried to reposition the IOL back with any type of suture?
Yeah, so we thought about that. Retrospectively, I feel it was a great thing we didn't use a suture, because if we'd got punched with the suture on, he would have got the retina with it free. So that was the thought process, which retrospectively I thought was a great idea of not putting a suture. But at that moment, I was very happy with the CTR. I didn't think of a CTS or a suture.
Oh.
Yeah.
Aditya, very well managed. So I just wanted to know, between the second and third surgery, what exactly had happened?
So he got into a national match, and this was probably his last match. And he got smacked right across, and I think the blow was on the side. There was a little orbital fracture as well, but what had happened was, because we made every surgery made his eye weaker, so we had a scleral tunnel, and through the scleral tunnel the iris had come out, and half of the iris claw had broken. So there was no situation of putting it back. And that's when we decided, because the iris tissue was already sparse, that if we take a suture, do a good pupilloplasty, putting another iris claw may not be a good idea. So we decided to do a Yamane.
So I think one of the challenging aspects of this surgery you did not show, that is de-enclaving the other iris clip. So how did you do that? Can you explain?
So half of the job was done for us. The other half we pushed and turned. So it was easier that way. But I find it very challenging generally in a good case to take it out. Here the iris tissue was already in a bad shape, so it was easier for us. But yeah, otherwise we can cut it out also on one side. In this case, it was easy to take out. It was just sheer luck, let me put it this way. But generally de-inclination I find it difficult. I've done it once, it was very difficult.
And in retrospect, would you think putting more number of sutures in your second surgery would have helped in this case? Considering
for
the
tunnel?
Yeah, for the tunnel. You
Maybe.
put one suture, right?
Yeah.
Since he's a boxer and...
yeah, retrospectively, yes.
Okay.
Yeah.
Thank you.
All right.
Yeah, please. She has a question.
No, not really. Yeah.
Dr. Kanchan? Is Dr. Priyadarshini here?
So, good morning everyone. Myself Dr. Kanchan, and I am a first year ophthalmology resident at Eye Care Hospital. And my topic is technique of corneal scraping. So, superficial keratectomy is a procedure to remove the diseased cells on the surface of cornea, and it usually takes about 15 to 30 minutes. The aim is to identify the pathogenic organism in the infected tissue to make a diagnosis and to plan the course of the treatment. Prerequisites include a wire speculum, proparacaine, Kimura spatula or surgical blade number 15, 2 glass slides, one for gram stain, one for KOH wet mount, and one optional glass slide and cover slips. Followed by culture plates like blood and chocolate agar, Sabrod's dextrose agar, and optional plates include non-nutrient agar with E. coli overlay, Thayer-Martin medium, and thioglycolate agar. The order of specimen preparation is a slide for gram stain and slide for alternative staining processes, solid phase followed by liquid phase. Coming to the steps of scraping. First, we apply the wire speculum, like the Barriquer wire speculum, to separate the lids properly and making sure the lashes are not touching the cornea. Then anesthesia, we usually prefer topical 0.5% proparacaine, and general anesthesia may be used for children and uncooperative patients. For taking a scrape, we need to identify the infected corneal tissue, and with the help of a 21 gauge needle or surgical blade 15, we scrape it carefully. In this, we are using a Kimura spatula to do the same. So we need to make sure that the sharp edge of the instrument is tangential to the surface and is moved unidirectionally, and we need to scrape around the leading edges and the base of the ulcer, as in the edge pneumococcus is commonly found and base Moraxella. So as we can see in the video, how gently we are scraping unidirectionally, first from the base and then the leading edges of the ulcer. Then specimen collection, we put it on the center and make a circle around it with a marker and make the patient write the patient details on one end of the slide. We need to prepare 2 slides, one for gram staining, one for KOH. Now, as we can see in the video, we are making a thin, we are putting it on the glass slide, we make a thin smear. We will be putting 1 drop of KOH and cover slide on one, and we will send one for the gram staining. Then inoculating culture media. We gently smear on the surface of the agar in C streaks, taking care not to puncture the surface of the agar, as we can see in the picture. The left one showing the blood agar and the right one showing chocolate agar with typical C streaks. This is the blood agar where we are making the streaks and not puncturing the agar and then closing the lid. Followed by chocolate agar. We use one side of the blade to scrape in C shapes and then the other side of the blade. Now we sellotape the lid of the plate to the base around the perimeter, incubate inoculated culture media as soon as possible. Then Lowenstein-Jensen media in suspected cases of tuberculosis, where we find typical rough, buff and tough colonies. Here we can see, we gently poke and then we close the lid. So coming to making a diagnosis, in microscopy or gram staining, gram-positive cocci can be seen like Streptococcus and Staphylococcus, and gram-negative like Pseudomonas. Gram-positive taking the blue stain and Pseudomonas the saffronin stain. A definitive diagnosis of nocardia may be possible, and yeast cells will also stain positively, as we can see in the image. The first one showing yeast, followed by pseudohyphae and fungal hyphae. For non-nutrient agar, Acanthamoeba species trophozoite forms can also be seen. LJ media, as discussed earlier, is a selective egg-based medium typically used for Mycobacterium species. So finally, we apply a lid speculum, and any mucus or debris in or around the ulcer is carefully cleaned with sterile swab stick. Leading edges and base of the ulcers are carefully scraped. The first sample is applied on a glass slide, and multiple slides may be used for higher yield, and 1 drop 1% KOH is put, followed by cover slip. Another slide is stained with gram staining. Next sample inoculated into blood and chocolate agar in typical C-streak manner. Next sample on Sabrud's dextrozagar, and the last sample in Lowenstein-Jensen media. So for that, I would like to thank Dr. Shreya ma'am and Nupur ma'am for helping me with the video. Thank you.
So Dr. Kanchan,
Yes, good morning,
thank
sir.
you for that educative video. I mean,
Thank you, sir.
we learnt a lot. It's very classroom-like, teaching for us. So I just wanted to ask you, do you do all your scrapings in the operation theater, or is it done in slit lamp?
So I have done it once in OPD. So just once as of now, sir.
So
I've seen
generally
many.
at your hospital it is done on in the operation theater?
Sir, yes, sir, it depends. If it looks very infected, few are done in the operation theater and some are done in OPD basis also on slit lamp.
I want to ask the audience, how many of you do corneal scrapings regularly? Good. So please go ahead and ask questions because I don't do it.
Yes, sir. Yes, sir. Yes, sir. Sure, sir. Sure, sir. Thank you.
Anyone else? Any comments?
Do you use a speculum?
Not every time, ma'am. Not every time.
Do you use paracaine before you
Yes, ma'am. Paracaine is used, ma'am. Yes, ma'am.
Then you put paracaine. I think it's the other way around. First we put paracaine, then we apply the speculum, then the patient gets comfortable.
Yes, ma'am. It reduces the discomfort. Yes, ma'am.
Nice video.
Thank you, Dr. Kanchan.
Thank you, sir.
Do we have Dr. Priyadarshini? Okay, so we have one dropout. Thank you all the presenters for coming early morning on Sunday. I know how difficult it is. We can all come up for a group photo. And please don't go anywhere. As you all are aware, the next session on secrets of the industry is there. We'll, hello? We'll wait for another 3 to 4 minutes and then we'll start this session. So this session will be recorded and we'll be putting it up on our YOTube channel and we'll be marketing it everywhere through YOSI.
So this will be recorded and kept for 15,000 young ophthalmologists globally. So I request Nikhil and other industry leaders to be addressing them and inspiring them and making sure that all of us as young ophthalmologists learn so much how to be entrepreneurs, how to get it out there and be part of the evolution you guys have created. Want to call it?
Yeah, I'll just wait for another 2 minutes. We'll start. Meanwhile, I request Mr. Nikhil, Mr. Dave, Mr. Anuj, Mr. Sanjay to just come in front so that we can start it in some time. Okay, so good morning to one and all. This is one of a kind session. First time such a session has been conducted, and we at Young Ophthalmology Society of India are very proud, of our associations which we are having with the industry. And we thought that we should extend it beyond just having, the stalls and interaction at the stalls. We want to have a one-on-one interaction with our beloved industry people and know about a lot of things that generally are not spoken about. So this session called Secrets of the Industry is a session which is trying to bridge that gap between the industry and the doctors. And we have, I'm very honored to have 4 very distinguished guests as panelists for this session. And let us introduce all of them. Can we please have the video? So welcome all to Secrets of the Industry. We have Mr. Nikhil Masurkar, CEO of Entod. Can you please come, sir, on stage? Mr. Dave Maritz, Marketing Manager of Rainer. Mr. Anuj Kumar, Marketing Head of Southeast Asia, Hoya. And finally, Mr. Sanjay Argal, Research and Marketing Head of Care Group. A big round of applause to our 4 distinguished faculty here. So basically what we are going to do is we are going to have a few questions that we want to ask these people, and at any point if the audience feels that they want to ask some questions, they want to know more about more details about this, we can always stop in the middle and we can have audience questions. It's totally informal, and I request the panelists also to be as informal as possible and try to answer questions with utmost honesty and to benefit the doctors. So can we have the presentation? Right, so we'll start with the pharma industry first, and we are pleased to have a very young, dynamic CEO of Entod, Mr. Nikhil Masurkar. So my question to you is, you have done so much in terms of innovation and so much of support to young doctors everywhere. You are being known as the Elon Musk of the pharma industry. So you earned this title. We've read it at quite a few places. So I want to know what goes into getting this title.
Yeah, firstly, wish you all a very good morning, and thanks for inviting me here to talk on this panel. The word Elon Musk, actually it came from some doctors from Tamil Nadu who I invited once to our R&D center, and I showed them my plans for innovation in Indian ophthalmology. And they were so zapped and shocked that they said, this is like, you're like the Indian Elon Musk. At that time, I didn't even know who the man was. I think it was around in 2016. But I think you could say that because I'm as crazy and bold in innovation as him, probably. I have these out-of-the-box ideas which I make sure end up being materialized in some way or the other. And also, I think, when we first launched the concept of intracameral moxifloxacin, everyone thought it's not going to work, it's a crazy idea, and we made it work. When we first came out with the concept of low-dose atropine for myopia management, everyone thought, well, you know what, it's almost like a homeopathic dose, it's not going to do anything. It got commercialized and it worked. When we came out with the concept of intracameral mydriatic plus anesthetic for cataract surgery use, everyone said, you know what, it's not going to be popular in India. We not only made it work, we did phase 4 clinical trials, and it was the only intracameral product approved in India by the DCGI. So I think these out-of-the-box ideas and the boldness that we have for innovation, and the more crazy you are, the more things work. And one of the things throughout this journey I've learned is that whenever you have a good idea, which in many cases comes from doctors for patients, 9 out of 10 people will tell you it is not going to work. And that is when I know that it is going to work, and that's how I make it possible. So I think that that innovative spirit, I think, is very important, not just for me and for my company Entod, but I think for the entire industry. And I think in about 10 years' time, we want to make India into an innovation and value-driven market rather than just a volume-driven market, what it is today. So I hope that answers the question. Thank you.
Yeah, so we also, as doctors, we try to be as innovative as possible in our approaches. But what we see is that, a lot of our innovations, crazy thoughts, they sometimes fall flat. You may have an innovation which may not always work. So how do you deal with this sort of failure? I mean, I'm sure that, everything that you must have thought of or done may not have, reached the level of success that you expected it to do. So how do you deal with that?
Well, it's to have the right innovation ecosystem within your organization. You need the right research people with you. You need a good regulatory team. You need the will to do it. Obviously, we need funds to, for research and all of that, but that is not the problem now. The problem is to really kind of break all the, get over all the obstacles that are there in research. Luckily, in India now, the research space is much more, it's much more simpler than what it was. I think India is probably the best place in the world to do clinical trials. We have enough patients, we have enough data that we can generate from India. So I think it is possible now. I think what didn't seem possible 10 years ago is possible now. And in fact, now we were used to bringing molecules from the US, launching it in India and thinking that we've reached the world. But now we can develop products indigenously in India and out-license it to the US. That is also possible, and that is going to happen. So I think the belief of what we can do, I think, is very strong now.
Great. Thank you. So let's move on to the next slide. Yeah. So my next question is directed towards Mr. Anuj from Hoya and Mr. Dave from Reina. So, both these companies are really, you all have the most refined preloaded IOL systems, and I'm sure the doctors who are here would definitely agree on that. So I want to know how difficult or how easy it is to make this preloaded IOL system, to make a good preloaded IOL system, because IOLs are something that we doctors, we surgeons are obsessed about. Most of our conference discussions are related to IOLs. And we have seen, companies making preloaded systems or making injector systems that are really, not good. And that really spoils the whole effect of the IOL. So being two systems which have very good preloaded systems, what goes into making this? Like, how difficult is it? Why are all companies not making good preloaded IOL systems? Yeah.
Thanks, and thanks for the invite. I'm having a great time in India and been very well looked after by everyone, so really happy to be here, so thank you for that. It's a great question, and I think you've certainly got two of the best preloaded injectors up on the slide over there. I had the privilege in a previous role working for a distributor in Australia where, crazily enough, we distributed both Hoya and Rayner, so I had experience with both of these injector systems, and you're right, it is actually quite difficult, and I think the proof of that is that you've seen companies who've been for probably 20 years when they launched their first preloaded injector, and they still haven't potentially got a very good injector. So it's not easy. I'm not an expert in the R&D field, but I think the ability to store an IOL in a safe environment in that injector for long periods of time with long expiries, and have all those mechanisms work to have a good delivery of the IOL is important. I think preloaded IOLs should be standard across, particularly across premium lens platforms and any international lens company. The development in the future, I think, should be going more into the effectiveness and how good the preloaded system is. So I think the key things are consistency of delivery. Incision size is obviously important, and I think foolproofing that system, as you alluded to make it easy for the doctors and the nurses to use. And these are the key criteria. We've had the Ray 1 injector now for a number of years, and we think it's very good, but we acknowledge that it can be even better. And our R&D team are actually right at this moment are working on the next version of this injector. So I'd actually encourage any of the surgeons listening to this or in the audience, Rayner are a company that work with surgeons to develop our technology. This is how we've come up with most of our IOLs and products, is collaborating with surgeons. You said you guys have a lot of good ideas. You see these things in theatre. You work with them on a day-to-day basis, and you really you feel exactly what could be a little bit better, what could be fixed, what could be improved. You guys are the men and women are the true innovators, so we want to work with you. So reach out to your local Rayner India team if you're an injector guru or it's something that you have a bit of a passion about, and we'd love to incorporate feedback because we're working on a new version at the moment. And I'd say the one last thing in terms of development, I think another important thing that we're working on is to reduce the amount of plastic and medical waste with all of our products. And these injectors, they come in a big plastic thing in a big plastic box, and it's important for us to minimize that as much as we can. So there's a lot of work going into that side of things.
Thank you for your answer.
Thank you, Dave, and thank you, everyone. So as Dave said, and you all, of course, would agree that industry is moving towards the preloaded category of the IOLs. So having said that, it looks easy, but yes, it is a dynamic game altogether. Making the consistent delivery system, wherein you being surgeon can believe while you are implanting the IOL that every time when you implant the IOL, it is going to get easy for you, because industries and companies, every company is making the optical property of the IOL good, but then when it comes to the implantation, I think it is the surgeon who is facing in the OR, right? If it is best of the optical property, if it does not get inside the eye properly, probably doesn't make any sense for the surgeons and clinicians. So it takes a lot, behind these the preloaded delivery system, making it the best in the clinician's hand. So as I said, it is a dynamic game. It looks easy, and things are evolving day by day. If you see the Hoya preloaded system, we had initially the ICER delivery system, but then we ourselves make it into the R&D setup, wherein we thought that how we can make it little more better for the clinicians. And then we come out with the multi-site delivery system, wherein you have both the options available in the OT. You can screw and you can push based on your comfort level. So choice is in your hand, basically. And that's how I think every company should look forward. Going further, they should make preloaded as a standard care as far as the delivery system is concerned. And talking about the best delivery system available, and you can see on the slide both the delivery system available. But then, if I talk about the multi-site delivery system, how it is different than the other other delivery system which are in the preloaded category, is that we make it in a way where it is unique in its features. Like we have the insert shields available. As I was talking to Dr. Jain yesterday, that he has that habit to implant the IOL in the wound rather than going into the bag, right? But we as a company always recommend go into the into the bag rather than getting into the wound. But then for you especially, sir, you can choose with the multi-site delivery system, having the insert seal little advanced, which makes your job easy, and you can implant the IOL in the wound. So that is the only property which I think makes Hoya multi-site delivery system different than the others, right? You have the choice if you want to get into the wound or get into the bag directly. You have a choice in your hand. On top of that, how you can make it best consistent delivery system is that every time when you use the IOL, you are at peace in the OR. And behind these preloaded category of the IOL, when I talk about the multi-site delivery system, every time, every single time you use, you have the repeatability, the reproducibility, because you have the O-rings available, you have the insert shield available, and the kind of the jerk you feel in other delivery system, you won't find in these category of the preloaded system. And that's how it makes, the different category of the preloaded. And each company, I think, should work towards such delivery system.
So do you think in the next 5 to 6 years, we can see more companies coming up with good quality preloaded systems? Do you think?
I can't say, because the company, I think, should think about this. As far as
but is there R&D going on in the companies to focus on making good preloaded systems?
Yes, I'm sure. I think every company should look forward in, and I think companies like J&J, companies like Alcon, they have already tried making good delivery system. There are little improvement required, of course, and I think they should be working upon it to make it the best delivery system available.
So I'm going to ask a similar question to both of you. Does sales, or does the cost of a good delivery system drive your IOL market? What I am asking is that a factor you see that other companies may compromise on so that they can sell it for a lower cost and get more sales? Or is it a non-negotiable thing and you expect that this costing, or is just a research that you got that others don't have that's cutting you apart? Or I just want to know, so as a person, just to understand the market.
So if you ask me, I mean, of course, Dev will share his experience, but then as far as making these preloaded category, the best preloaded category of the delivery system available for you, it takes, of course, the cost, making into the R&D and everything, but then it is up to the organization if they want to charge for the delivery system. As far as Hoya goes, I mean, we don't charge for the delivery system. We believe in providing the best of the quality as far as the IOL, and best of the quality and the ease to the surgeons as far as when it comes to the delivery system. So we don't charge the premium for the delivery system, but again, it is the choice on the organization if they want to charge. As far as the commercial goes, they should charge, of course, providing the good delivery system. But then Hoya doesn't charge as far as the delivery system is concerned. We don't charge the premium.
So I just want the question directed to Hoya, because the Hoya multi-site is one of the best injector system, actually the best injector system that I have used till now. And the question that I want to ask is there a possibility of a universal preloaded injectors, like if Hoya can provide to other countries, other companies on a chargeable basis, of course? and all other IOLs will fit into that system, or do you have to devise a preloaded system for each and every kind of platform separately?
Thanks for the question, sir. But then I agree. I mean, as far as the delivery system goes, this is the best delivery system available. I mean, of course, the Rainer has also the best delivery system available. And your question is like, we can provide to the other companies to make it as standard, yeah. But then again, there are a lot of commercials and a lot of things goes into this. Sir, the biomechanics part plays a very important role as far as IOL making is concerned. So when it comes to Hoya, so we have a different biomechanics than the other IOLs available, and that's how I think make one optic different than the others. So I'm not sure that it can fit into the same category of the delivery system, but yes, I think it can goes into the. Sanjay sir can I think answer this question because he looks after the research also. So I think, but as far as eye goes, I mean the delivery system and the IOL biomechanics plays the important role when it comes to the fitment of the IOL into the delivery system.
Yeah. Mr. Dave, you just can answer Aditya's question on, do you feel that the preloaded system, the companies would focus on that aspect for, is it non-negotiable in terms of increasing the cost and
yeah, look, I think it is non-negotiable. From Rainer's side, it's certainly a non-negotiable. We would never launch an IOL without a preloaded system. I understand that there are in different markets, there's different tiers, obviously in different segments, so there might be a lower tier where cost absolutely has to be kept to a minimum, and you're going to use an unpreloaded system because with a much cheaper version of an IOL. But in terms of the international companies and the top quality IOLs, it's non-negotiable. I don't think it drives price up from our side, but it certainly does drive sales, which I think was part of your question, because an example I had was I was talking to a surgeon the other day who tried a competitor lens. He said the lens visual acuity, outcomes, etc. was favorable. It was similar to what he was experiencing with all the other EDOFs, yet the injector let him down, and that was the sole reason for him to not continue using that lens. So it's crucial.
Yeah. So just for all the company representatives out here, I think we as doctors can collectively say, I can speak on behalf of all, for us injector system is extremely important. We don't want our blood to boil in the OR, Forget about what the patient gets post-op. In the OR, we don't want our blood to boil. So this definitely is a very important aspect of our operating system. Just move on to the next slide. How many of us here use, next slide. How many of us here use IPCL phakic lenses? Okay. So IPCL is, I would say, it has revolutionized the Indian market and of course outside India also. But the man behind IPCL, Mr. Sanjay Argal, is here. He's seen the journey right from the beginning, from the version 1 to the version 2. And it's a fantastic lens. I mean, I've used it. In fact, now it's formed a maximum part of my phakic lens practice. So he's been in the research, he's been in the development, he's seen it through its ups and downs. So he'll just share a bit about his journey of this IPCL to where it is today.
Good morning, everyone. It is a pleasure to be here, and thanks for invite. First, I want to say what we are and how we could broken the monopoly. So we started our journey when the first IOL implanted by late Dr. Daljit Singh in 1987. And after that, we are the second company who came out with this PMA rigid lens in 1991. Then again, we are the first company who came out for the foldable hydrophilic lenses in 1987. We are the first company who came out with this AS spheric hydrophilic foldable lenses in 2003. But we were not aware about the patent and all. Otherwise, we could have held the patent for the AS sphericity. We are the first company who came out with this hydrophobic lens in India in 2010. And before it, we are the first company who broke on the monopoly of these big MNCs that are sitting here for this bifocal or trifocal lenses in 2009. And the person who seeded the concept of the phakic lenses in our mind is the great Dr. K.P. Reddy sir from Hyderabad, Max Vision now. So he is the person who asked us to, can we do something for the posterior chamber phakic lens? And earlier we were manufacturing this iris clip and iris claw lenses for obviously the phakic lenses for the anterior chamber implantation. So he said anything put in the posterior chamber to minimize the reflective error. The person who cannot avail the luxury of the LASIK procedure because of the abnormal corneal anatomy or the axial length. So this kind of device can fit behind the iris and can be there for till the cataract sets in. So then we took this task and read all available material started from the Fedorov. He is the father of phakic device, and he introduced this concept in 1980. Then this idea took by this Star, and they converted in ICL. And this company created a myth about the material because polymer-based material is better for eye and minimize the issue of ASC. So we took about 4 years time to do all permutation combination. It was like a roller coaster to someday some achievement, someday some failure. So in our day we found this myth is totally a myth. This coating of this collagen, it is only about a 2.2% coating, and it is a scattered coating, not the uniform coating. So whole material is a acrylic material. And the only issue to avoid the cataract, intra-subcapsular cataract, is the gap. If there is a gap between the lens and the natural lens, then the minimal chance of any kind of cataract. Then we read about what are the flaws in the current scenario with the current lenses. So we found the first is the IOP. After putting a device, IOP can go up because it's reduced this angle size sometime, and the second issue is the ASC, which I discussed, and third is the loss of ECD with respect to time. So again, the aqueous flow was the reason, and the sizing. So the current option was at that time, still they have the same, the only 4 sizing. But we have a different eye anatomies, different axial length, different curvature. So we understood what the sizing can be. So instead of 4 sizing, we offered a 0.25 millimeter steps. So first. Second, we also introduced a lot of holes in the optic, which control the aqueous flow from posterior to anterior chamber, and the material, the thickness of the material. So we chosen about 80 micron thickness of the optic, so which can like a paper, which can be there for the years behind the iris. And the next thing, the haptics profile is very important, because when every point of time, when you iris adopt, it presses the lens. So if there is any rigidity in the haptics, it can go in the ciliary body. So these are 4 or 5 parameters. And the power range, obviously, those are not fit for LASIK procedure. They opt for the phakic lenses. So power range, we chosen the power ranges. It goes up to -30 from -0.5. And the cylindrical power. All these big MNCs, they work only for normal eyes, because they make more money with these kind of lenses. If they make any odd lenses, the cost of production go up, and they cannot charge from you people. So same the cylindrical power, we can go from +1 to +10, customized, but normally we provide +6 diopter. Sizing can be customized, and the optic is very, very important. The optic size can be customized. So optic size with the current lenses only 5.5 first, then 5.8, and now they have a 6.6. But in such myopic people, sometimes this pupil size becomes so large. So if the optic diameter is less than the scotopic pupil, sometimes it causes a lot of irritation. When the ramp on the lens body, it causes the iris pigmentation. So we can customize the optic size up to 7.25 millimeter based on the scotopic pupil size. So all these permutation combination possibly with our lenses. Sizing, they provide only 13.7, and we have provided only up to 15 mm size. So this is the journey. Then we started officially with first lens implanted by Dr. Jaldibar. He is the father of figure device. If Fedorov is the pioneer, so he is the person who implanted in 2012, and we took 2 years time to launch these lenses commercially in 2014. And after that, gradually the Europe, the Latin America, the Middle East, Southeast countries like Malaysia, Korea, Singapore, Japan, and now we are almost having a 15% market share worldwide. And obviously, we are giving good options to all of you in India. So this is a brief about the IPCL journey.
Thank you, sir. So we all know, what IPCLs are capable of. We'll come back to the sizing part of phakic lens. Second part. Okay, so can we go on to the next slide? Yeah. So this question is directed to Mr. Nikhil. So this is something I can, confidently speak on from behalf of all the ophthalmologists. We see 50 representatives who tell us about different lubricating eye drops, all having the same content with 1 or 2 changes here and there. And how are we expected to remember so many eye drops in this sort of a saturated market? And why are pharma companies focusing so much on lubricating eye drops when there are so many options available? Why is pharma not going towards medicines which are less common and just focusing on the lubricant? I understand there may be profit, but it's a saturation kind of has been reached. We cannot remember so many lubricating eye drops. So what is the opinion on this?
Yeah, I think I would like to answer this as a formulation researcher rather than the CEO of a company. I think basically when it comes to dry eyes in India, it's become a Me Too market. You have 100 formulations of the same molecule. I mean, you go outside and you'll see the same thing again and again. So that's getting a bit boring. And I think we need genuine innovation when it comes to formulation science. And that is why I think instead of remembering all these 100, 200 brands, I think what is important for doctors to know especially is that the 2 elements of things. One aspect is the manufacturing quality, where you're talking about sterility and all of that, which is fine, and 99% adhere to that. And on the other hand, you have the formulation quality, which I think is not quite up to the mark. As a formulation scientist, when we were the first ones to develop sodium hyaluronate eye drops in the market, we went through every length to make sure, right from the grade of material to the rheology, to the viscosity, to the osmolarity, everything is formulated to the highest international standards. So we can sell up products in every single country, right from Europe to the global south. That was what the intention was and is. But unfortunately, now it's become a copy-paste market. Everyone is getting into it. Unfortunately, a few doctors are also getting into it. Everyone wants to make a quick buck, and I think that is diluting the innovation strength of the industry. If we want to move towards an innovation-driven market, we need to focus on newer formulations, newer drug delivery systems, newer molecules for dry eyes, and that is why we are also so focused on the R&D. If any doctor wants to visit our R&D center in New Bombay, you will see the kind of work we are doing, right from using generative AI for formulation development, which no one has done. In fact, a lot of US companies have shown interest to partner with us because of the work in formulation development. This is not just restricted to dry eyes, but through various other therapeutic segments as well.
Yeah, but Mr. Nikhil, I want to know that how do we, so every company will come up with some, kind of trademark that this is something that we do which they do not do. So how are we doctors, like as you as pharma people, how do you expect us doctors to, now for example, you said you've used generative AI for development. Now, it's not like, we actually come to the plant and see, but every company uses this strategy to try to lure doctors to. So how are we going to, make that decision that, okay, this is being done, we want to prescribe this eye drop?
I think
we want the pharma company to think that to be in doctor's position, that how are we going to, how do you sell that point to the doctor?
I think in a nutshell, from a doctor's perspective, you need to look at what the company is actually doing when it comes to academics in dry eyes. Like for example, for us, we are quite actively involved with the Cornea Society of India. for Cornea Society, with the TFOS. So all the academics that were actually, actually doing, the work that the actual formulations that we are coming out with that are DCGI approved, and these things can be verified and checked. You don't have to believe the medical reps for this. You just go online, you check what the company is genuinely doing in the area of dry eyes, and you will get all the answers there. So I think now, because it's open information, you'll know exactly what companies are doing in the dry eye space. We are developing androgenic steroids for dry eyes. We're developing JAK inhibitors for dry. These are all new concepts, indigenous, which are not even in the US now, and we'll be launching it first in the world. So I think that is more exciting to me than all the Me Too work that's happening in the industry. So I think over a period of time, doctors will also, it'll be easier for doctors to understand who's doing genuine work and who's just doing good medical marketing. I think that will show. So yeah, that's what.
So as a doctor who is getting visited by like 20 reps every week, what they tell, like you are telling that you'll go on Google or you go on PubMed index journals and search which company is sponsoring more of the research. But what they do, simply they come and tell that, say Entod is getting this drug manufactured from this plant, and we have contracted that plant only, and we have got the exact formulation, this is this, whatever, and after that they go into the commercial. So how a company like say Entod or Ajanta or Mankind's, how you can prevent this this kind of budding practice, that is using the same contract manufacturer and getting the same product out in the market?
See, a contract manufacturer is simply like, if you want to give an analogy, it's like a kitchen. The recipe, the chef is the innovator. So I can get an iPhone manufactured in a factory, and the same factory will manufacture another version of it. There is a huge difference. The difference is what in our industry? The difference is the specification, is the grade of material. I can get a sodium hyaluronate eye drop manufactured in a factory where 20 other brands are being manufactured, and I can guarantee you that the formulation quality of that will be far superior, because of the tech transfer agreement we have with that particular contract manufacturer, because our team will be there to monitor every single batch and to make sure that our own specifications are followed, not their kind of industry accepted recipe. So the recipe is what is important. The same chef in the same the different chefs in the same kitchen can do two different kinds of meals. So I think it's about that, and that I think something which I think sometimes doctors don't understand. It's manufactured in the same place. It must be the same thing. I'm telling you, with our overall collective 47 years of experience, it makes a huge difference. And we know, because we can analyze these things. We can check the viscosity, the osmolarity, all the kind of parameters that you would check. So the contract manufacturer is just a place where you make the product, where you design, research the product is your lab. How strong is your lab? How strong is your R&D is what is going to take this market forward in the next 10 years.
So a spin-off of the same question to involve everybody. How do you tackle the two, I would say, the most important markets which are going to happen in the future, already are happening rather, in India especially, because everybody in India is on the phone. So one is your dry eye, because you have a lot of new innovative, I'm not just saying lubricants, other products, but they are generally so highly priced because there are 2 or 3 companies which do them, that make it unfair for a regular person or I would say a rural background or somebody who earns a basic salary to spend so much on his treatment. Or another part to it is presbyopia. So presbyopia is going to be an important factor for IOLs as well, and you're doing presbyopia medication as well. So why is there still a cost difference? Because the demand is going to go up and up and up, and it should be affordable for a larger population of who are out there. So why is it that it's still called premium when it may be the only vision they'll be using? Because if you ask me, a regular person, whether he drives an auto rickshaw or he is a farmer, phone has become more important than anything else. So why not think of bridging the gap between and calling it premium and making it a regular IOL? and medications as well.
So let's go on to Mr. Dave and Mr. Anuj, because our next question is also directed towards presbyopia correction IOL. So in combination with Aditya's question, what we are trying to find out is at what stage are you in terms of normalizing the presbyopia correction as a regular lens as compared to calling it premium. So what he's trying to ask is, in your R&D for your near lenses, how are you? Yeah, what is the cost difference, and how much can you normalize it to make it into a normal IOL?
Yeah, it's a great question. I think there's an evolution. It's a process. I think if we look back, we've seen, spherical IOLs that were the standard of care, and then when aspheric IOLs were launched, then the spheric IOLs became a lot cheaper, and then you've added torics, we've added multifocals, trifocals, and each step that you make, I think the technology behind that becomes available and cheaper for everyone. I mean, it would be fantastic. I agree. It would be wonderful if every patient could have access to the same standard of care and get the same results. I'm fortunate enough to live in Australia where 70% of patients get a toric IOL because it's part of the healthcare funding. So I think there's probably a lot of political, government, reimbursement kind of things that come into that as well. From a company perspective, in terms of development, obviously the cost of R&D, and I'm sure Mr. Nikhil will agree, when you're putting all that research and effort and resources into developing something new, there's a significant cost, and I think that's what hampers the companies from making that new premium IOL, at the same price. You need to recuperate those costs. So in terms of Rayner, I mean, and presbyopia correcting, I know we're running short of time, so I won't talk too long, but our R&D started with our EDOF lens, which is our current, we have our trifocal and our EDOF EMB, was through collaborating with Professor Graham Barrett. So, that's another part. We collaborate with surgeons, which, as I said earlier, is, I think, the best strategy, because that's you're the smart guys who have the ideas. This obviously does also sometimes incur additional costs. But that's the way we've gone, and in fact we have something quite exciting coming up if any of you are attending ESCRS later this year, pending CE mark that we're expecting in a couple of months. We'll have something brand new in the space that is it's in the multifocal space, that will actually give a full range of vision as a trifocal does, but with early testing has shown with significantly less side effects, dysphotopsias and glares. So yes, we're this is obviously it's the golden goose. It's what every company is aiming for. It's what you as ophthalmologists are aiming for. If we can correct presbyopia successfully without side effects, it's what we're all aiming for. And I think that evolution, we're moving one step closer at the moment.
Mr. Anuj, also could you shed light on your new Vivinex Impress lens, as that is the new kid on the block in terms of extended monofocal?
I'll just extend what they've said, that we have different technologies available. So presbyopia is one. I think it's the widely we can see that people are accepting it in terms of having the IOLs, and of course you have a lot of diagnosis also available which can support now putting the premium technology IOLs. So it has become easy now, but at the same time, you would agree that technology comes at cost, irrespective the presbyopia correction or a enhanced monofocal, or for EDOF for that matter. So yes, we should also keep in mind that how we can make it the cheaper. I mean, so that everyone can afford it. That is something which we all should look into. But then, having said that, yes, as far as the multinational companies are concerned, they put a lot of efforts in terms of the research and everything. Because if you say the Hoya perspective, still we are not having the EDOF category of the IOL. It does not say that yes, we don't want to come with, but then yes, it takes a lot of research and things in place, so that we can provide the best of the optical property to you when it comes to the technology. Now coming to the Vivinex Impress platform, of course this is the optical property which we are offering in terms of giving you the enhanced monofocal vision. We do not call it as a EDOF lens or a true presbyopia correcting IOL, but then it is something which can improve your patient's lifestyle in terms of giving the one-line improvement what he is or she is getting from the monofocal lenses. So this is about the Vivinex Impress. How it is different than the other enhanced monofocal, or for that matter, an EDOF category of the IOL, is that it gives you the best of the intermediate which the optical property can provide at not at the cost of the the deteriorating your distance vision. So that is something which goes behind the Vivinex Impress.
So basically, we have a session on Reina just after this. So Reina's technology is quite evident. We'll be speaking on that. But Hoya's technology for the extended monofocal is also very, very interesting. I heard it in detail yesterday. I encourage those doctors interested to just go meet them and just understand how they have designed that optic edge in a very unique way to give that extended monofocal. So we'll just move ahead. Since we are short of time, we'll go to the last question. Can we have the next slide? So the last question will be directed to Mr. Sanjay. So for those implanting IPCL lenses, just to tell you that if you have ordered an IPCL lens and you have done your measurements, the final calculation sheet goes to Mr. Sanjay, who finally signs it off that this is the sizing of the lens, and then it comes back to you. So I want to know from you that ICL has been there FDA approved since so many years. It has just 4 sizes and it's working well. What is the need to have so many sizes in IPCL, and how do you decide based on, every person has a different way of measuring. Everyone may not do digital measuring. So how do you know what measurement it has come from, and then based on those different machines, do you change your kind of final calculation when you give the doctor? Just share some thoughts on this.
Yeah, so sizing is very, very important for this kind of device, because undersize may cause the ASC, the oversize may cause the glaucoma or IOP rise. So we optimize our nomogram for white to white, measured by the digital caliper, then IOL master, pentacam is the any optical device, the OBScan, the UBM, and the A2A. So we have a nomogram, this in-house nomogram. So based on your keratometry, the power, the chamber depth, we estimate the S2S, because ultimately lens is going to rest in the S2S. So now we have experience of more than 400,000 lenses. So based on these past record which we have, so once we receive the data from you, we calculate everything, and sometimes we ask to remeasure your white to white or the S2S or the A2A. And second, very important parameter now, the CLR, crystalline lens rise. If any machine can provide the CLR, then we can provide the excellent vaulting, predictable vaulting for the year and year till the cataract.
So just to clarify, ICL is doing a lot of work with CLR, but has IPCL also taken that into consideration?
Yes.
From an anterior segment OCT image, we can send you.
See on the right. I think this is the old. Which is on the right, on the top, the CLR is there.
Okay. So you consider that as well?
Yes.
Okay. See, there are many machines outside the ones that you have mentioned, that is OBScan and all, which also give white to white accurately. For example, I'm using a Tomy OA 2000 to measure white to white, and Topolizer, Alcon's wavelight Topolizer. These give accurate white to white. So do you have nomograms taking these machines also, or your nomograms are only based on the OBScan and IOL master?
They're based on the digital caliper. The optical means the pentacam, IOL master, the OBScan, the UBM, and the A2A. So all 4 or 5 systems.
So just a note for the doctors. I mean, these machines may not be similar to the machines which all of us are using. So you should just know that whenever you are putting it into the calculator, it may be different from what their nomograms are. And ultimately, I think what you suggest, digital white to white, is most accurate, or do you have?
Because the 95% lens sizings in past, based on the digital, the white to white measured by the digital or the manual caliper. And I hope almost 95% of patients are satisfied. So, but those are having a couple of more equipments. They can cross check, and also you measure for both eyes, left and right. If there is a difference of more than 0.5 millimeter, then you must recheck. If there is any confusion, then also measure white to white on the X and Y axis. And always the Y axis is slightly lesser than the X axis. It is just to make sure whatever you are measuring, it is spot on. Because slight difference may cause this ASC or the IOP rise.
So I have a question. We have a lot of innovators who are young ophthalmologists. They have ideas, like Zen said, they fall flat. How open would you guys be to have an innovative cell where you allow these discussions to happen with credits to them whenever possible? Because I know Nikhil does work with ophthalmologists, Reina does work with ophthalmologists, but how open would you be to have a safe cell where they can come, or maybe have a Shark Tank sort of a situation where we can get everybody to get their innovations in front of you guys, and you help them make it a success? Because young minds in the end, and doctors who are actually in the OR doing all these things, are dealing with patients, can actually produce the results that we may need tomorrow. So how open would you guys be? I'm sure Zen can look after that.
So this session is a start of this sort of session. Yeah, let's hear it from the panelists.
Yeah, we are very much open for any kind of idea which we can discuss. We can have an NDA, and if convert in a product, we can discuss about the royalty also.
So I think I goes with Sanjay sir. Of course, we would be happy to have such sessions in future also, and it is actually indeed a pleasure, for us to interact with you guys, so that we can get feedback timely and can improve upon things what we want to produce actually. Being from the IOL industry, I can say that as you say, one IOL cannot fit to the everybody probably, but then having feedback, timely feedback from you guys can make a product better, which can suits to all probably.
And on behalf of YOSI, I think we will like to be collaborated more with industry, because as young surgeons and young ophthalmologists, the problem we face and the innovative ideas that come to us, when we become senior, we sort of, the tendency sets in that this is the way the industry works and you can't have new ideas, or it's very difficult to do that. But as young ophthalmologists, YOSI or YOSI members will have more free time and more time to discuss with better ideas and faster turnaround time. So if the industry is willing to work, then YOSI can have a collaboration with innovation cells of each company.
I think that's the way forward. I mean, we're already doing that. We call either doctors or a group of doctors to our R&D lab. We have brainstorming sessions with them after signing an NDA. And then we really kind of try and figure out what is needed in the market and whether it's feasible. We do feasibility studies to figure out if it's possible in the market. So I think that's the way forward. In fact, a lot of our new innovations have come through that process. So we know it's working for us. So I think that's the way forward for the industry. We all have to work together.
Yeah, agreed from Raina's side. We have advisory boards in many countries, and that's something we can absolutely set up in India as well, where we work together with surgeons. I think it's not only new products, but it's further developing what we already have. We have a Ray Pro platform, which is a digital health platform which measures patient satisfaction, and that has evolved significantly over the last 24 months, and it's 100% been driven by surgeon input. So it's absolutely the strategy for us.
Great. So
I think Zen is going to now organize a Shark Tank, and you guys are going to be the sharks.
Yeah, if YOSI agrees. As Nilesh said, if YOSI agrees, we are definitely looking forward to more such sessions. They are really helpful for doctors. So on that note, I think we've run out of time. I sincerely thank all the panelists for removing time and coming, especially Mr. Dave, coming all the way from Australia for this session. It really means a lot to us. We've learned a lot. Big thanks to YOSI Governing Council for allowing this session to happen. And hopefully we've got it recorded, so we'll put it up on YOTube. Okay, it's live on YouTube. Great. So thank you, panelists. I think we can have one group photo. Yeah, one sec, doctor.
So, couple of this entire session was Zen's idea. And the thing is, we can all come for a group photo in that time. So this is all Zen's idea, and it was such a wonderful session. I think we have to do this. Zen, you also be on the stage. No? Yeah. So we had to do this session, and I got a lot of feedback from the senior team from AIOS and DOS as well, who were really intrigued as to how does YOSI plan such sessions. And I was like, because we have a good team. So this is Zen's idea, and thank you so much. At the same time, I would say all young ophthalmologists here, there is a family benefit scheme from AIOS that is happening. There's a stall there. It's a very good scheme in insurance policy, which you know, a lot of insurance companies don't give. The stall is there, and I would request all of you to please visit that stall. So thank you.
So moving on to the next session, without much delay, we'll have the YOS deferred live surgery or live energy, we should label it, part 2. So I would like to request the chairperson, Dr. Bhupesh Singh sir. Bhupesh sir, please come to the dais. Our panelists, Dr. Kartikeya Singh and Jofi Phillips, do come to the dais, and myself, I'll be moderating along with Dr. Raghav Malik. Do we have Dr. Urvija Chaudhary? Yeah. To go first on Silken Touch, lenticule made easy. Jofi. Karthik. Nikunj and Zain, if you can, yeah. Panel. You're free? Free now? Can it's okay. I know you're a speaker. Panel. It's okay for you. I'll go before Nikunj. No, you want to panel? The session is free. I'll take discussions. Yeah. I understood. But you be on the panel also. I would also request Dr. Jain and Dr. Nikunj to be on the panel. Zain? Yeah. Can we have Dr. Urvija? Yeah. Photo. This one. Again. Can we have the slides? You can start once you're ready. AV team, can we have the slides of Dr. Urvija? Okay.
Good morning, everyone. And this is going to be a deferred live surgery session from YOSI. And I welcome Dr. Zain, Dr. Nikunj, and Dr. Philip here with me. And the first presentation will be, or the first talk will be by Dr. Urvija Chaudhary, and she's a cataract and refractive surgeon, as well as cornea. And she's going to speak on Silken Touch, the lenticule made easy.
Thank you, YOSI, for this wonderful opportunity. I would like to present a small video of the silk surgery. Can we play the video? This is a wall.
Here we are using a bubble marker. Anyone can use a slit lamp machine also for the marking. After the marking is done, patient is shifted for the procedure. This is the interface of the machine, which is quite simple and intuitive and makes the treatment planning very easy. Here we are planning a -2.75 sphere with 0.5 cylinder. A nomogram adjustment has been done. It also gives you the complete picture of the biconvex lenticule, the thickness of the lenticule, residual bed thickness, the side cut, the diameter of the lenticule, and the estimated time of the surgery. Now we install the applanation cone and scan the PI. System checks for any tilt or variation in the cone glass. This is a very important step as this will account for any variation in the glass and can ultimately affect the result or the dissection of the surgery. We can use the joystick to adjust the machine, and this is the second part of the PI, the suction ring, which is being placed on the eye. It is connected to the system port from where it generates the vacuum. The suction ring here is used to fixate on the eye, and once the centration is fine, the vacuum is instantly achieved. Now you use the joystick to lower down the applanation cone onto the ring. Once the cone fixes onto the ring, you check for the optic position indicator on the right side as it comes on the green zone. Somewhere in the middle, not very low, not very high. Now you pinch the suction ring and the cone applanates the cornea. The meniscus should go beyond 10 millimeters to give you a wider area for adjustment. Now you lock in this position and go for the centration and the cyclotorsion adjustment. It has got a very good touchscreen mode, so you can do it by yourself. Now the laser treatment is started by moving a raster scan line in a radial pattern. It resects the posterior surface of the lenticule first, then the side cut, and then the anterior surface of the lenticule is cut. At last it creates the cap cut, and within seconds the treatment is completed. Now you undock the patient and shift it under the microscope. Here we are using a separate microscope. The microscope from the examiner machine can also be used. Wetting the surface improves the visibility a lot. Then we enter the cap. Try to find the anterior and the posterior plane. This is the tricky part. If you find the anterior and the posterior plane, your surgery becomes quite easy. So the trick here is to tent up a dissector a bit and enter the anterior plane, and while entering the posterior plane, dip in a little because it's a biconvex lenticule. When you enter the posterior side of the plane, you will see that due to the opaque bubble layer, the clarity is slightly reduced, and when you are entering the anterior surface, the clarity of the instrument is quite good. In a windshield wiper manner, you dissect the complete lenticule till the edges. Then you try to enter the posterior plane, and in the similar windshield wiper manner, the posterior lenticule part is also cut. You may find little resistant at the 3 o'clock and the 9 o'clock position, as it helps in preventing the rolling over of the lenticule. Once we are sure that the lenticule is completely dissected, with the help of a forceps, we grip the lenticule and pull it out. Just check for the complete integrity of the lenticule, and at the end we just iron the surface of the bed so that the post-operative recovery is quite fast. This interface OBL clears up within minutes, and you get a very good visual recovery by 24 hours.
Thank you, Dr. Vijay.
Thank you.
Excellent
Thank you so much.
surgery. And as most of us have learned lenticle on a smile platform, and you must have also done on a smile. So what difference you found on this machine versus smile?
So the dissection part is similar with both. I had used the smile the first generation smile, so which has now developed quite, it's a second generation femtosecond that they are using. So the cyclotorsion and all is the newer developments that we are getting in the lenticule procedure nowadays. So astigmatism management has improved from the first to second generation.
And dissection, easiness of the dissection is...
Dissection is also very easy, sir. Here we did find a little resistance, but it again depends from patient to patient. Like with the same parameters, you can get a good dissection in one patient, and with the same parameter, the dissection can be little tough. So it all depends on the humidity, temperature of the room, also the biomechanical strength of the cornea, which Dr. Rohit Shetty has been talking recently, that it's the biomechanical strength of the cornea which gives you that ease of the dissection with the same parameters. So like I found a little resistance in this one, so I went back and checked the Corvus values, the biomechanical strength also. So it was like very good. It was like 0.1 in this case. So that maybe was the answer to a little resistance which I found, and that's why I wanted to put this video here.
What are your experiences on the cases of astigmatism cases, the high astigmatism with the smile?
High astigmatism, like I have gone up to 3 cylinder, not beyond. So with minus...
You mark in all cases of...
I am marking it with or without astigmatism,
Without
every
astigmatism
case.
also?
Without astigmatism, like made a protocol only so that nobody misses it. And whatever minor...
Marking then, okay.
Mm-hmm.
Fine.
Like even with high cylinders, even if you do contour treatment or anything, you sometimes do get residual cylinders there also, no, with high cylinders. So that is explained before only for the patient, that if they have a high astigmatism, they may need a bit of repolishing.
Thank you so much.
Thank you. Thank you so much.
I invite Dr. Gautam Yadav to speak on life begins at 33 centimeters. Is your PCIOL ready?
Good morning, everyone. And at the outset, I want to thank YOSI for giving this platform to present my talk. Topic of my talk is life begins at 33 centimeter. Is your PCIOL ready? This talk is sponsored by Johnson & Johnson, and this is a data from the Western study of patients of age 55 to 64 years. And you can see that a lot of the patients were using digital devices. And we may say that it's from Western world, but all of us who are seeing patients, Indian patients, urban and rural, I think all of us will agree that more of our patients are on digital devices. And because of this, the visual demands of our patients is increasing. And to meet these visual demands, we need something that that gives these patients good vision from far to near. And to tackle that, we have different IOL technologies. We have multifocal IOLs that give good distance and near vision, but there is a gap in between. And also in the trifocal IOLs, although they promise to give good distance, intermediate and near vision, there are certain gaps. So the patients do have good vision for distance near and intermediate, but there are certain gaps, and that may kind of dissatisfy some of the patients. To meet up to their expectation, there is a breakthrough innovation with Technis Synergy IOL that provides presbyopia solution by giving continuous vision across the range that empowers patient to see at all their distances. And it has superior low light contrast that delivers high quality in a day as well as in the night. So coming to the design, the Technis Synergy is a combination of diffractive technology from Technis Multifocal and Technis Symphony. All these two lenses are already doing great, and it's a combination technology. From Technis Multifocal technology, it delivers good distance and near visual acuity, and it gives the pupil independence. And the Technis Symphony technology delivers chrome aligned technology that corrects chromatic aberration, and also it gives continuous vision across the entire range, and also it's a pupil independent design. So it's the combination of these two. So if we go to the if we understand the continuous vision across the range, so this is the defocus curve of Technis Synergy lens, and you can see from here up from 33 centimeter up to very far. The kind of vision that is provided by Technis Synergy is ranging from 2020 to 2025. So it's a very high quality vision that is given to the patients, and this gives patients the freedom to see at all the distances. And if we compare with the other trifocal IOLs, we can see some dips in the some IOL designs, but Technis Synergy promises to give the good zone of visual performance. And now if we see how this lens does in low light contrast conditions, so these are the MTF 50 curves, and you can see that Technis Synergy intraocular lens really does good in the daylight as well as in the dim light in terms of contrast. And with the help of spherical aberration and chromatic aberration correction, patient gets the clear and crisp vision. And the chrome aligned technology, as was discussed previously, it compacts the spectrum of the colors that is seen by the patient. So the patient sees all colors very focused and very sharp. And that violet light filtration that is being a major cause of the scatter, and the violet light is quite common in the artificial lights, the LEDs, which we are exposed to day and night in our offices and in our household. So these violet light cause lot of scatter, and the IOL design gives the violet light filtration blockage, and that removes all the scatters. And this you can see in the form of ease of driving, as you can see with the clear as well as in the violet filtering. The daytime and nighttime driving becomes very easy, and also it reduces the visual symptoms in the form of halos. And the pupil independence of Technis Synergy IOL contributes to the best low light performance. The MTF loss when pupil opens from 3 millimeter to 5 millimeter in mesopic and low light condition, the MTF loss is very less as compared to the other trifocals. So in conclusion, Technis Synergy is a breakthrough innovation in the presbyopia solution that delivers continuous high contrast vision, and it empowers patients to see at all the distances, and it has low light contrast, superior low light contrast that delivers high quality in day and the dim lights. Thank you.
Thank you, Dr. Gautam. And so we all, one challenge we all face while counseling for trifocal lenses is the driving, because almost every person, at least male, they are drivers. Occasional driver, sometimes regular driving. So do you implant these lenses in occasional drivers?
For occasional drivers, I do give them the option of going for this, and I let them judge what the price they need to pay for the kind of spectacle independence they are expecting. If they are okay for little bit of discomfort, then I advise them. But if they are like night drivers, they are very frequently driving on highways day and night, then I probably suggest not to go for these and better go for something that don't go have the diffractive technology.
What are your experiences in your patients? How they are? What are their main complaints or any issues that all the patients complain that I have this issue with this lens? Any such problem or
about this Technis Synergy?
Technis Synergy.
Like patients, they do have sometimes they have more of expectation that they will see absolutely clear for the distance and near in all the lighting conditions. Somehow they don't get some patients, they don't get that kind of the experience. So it takes little time for them to get adapted with this kind of technology. Some patients do complain of glare and some halos, but I think most of patients are quite satisfied.
So in my experience, I feel that patients are very happy with the Synergy lenses if compared to the older technology. The
Yes.
lens works very well, and especially younger patients. I've implanted few lenses in younger patients, 50 years of age, 55 years of age, and they are very happy.
Yes.
They should not be a drivers.
Yes.
Other work, they are very happy. Any experience there?
No, I don't use Synergy lens, but I just feel that any lens with a diffractive design will definitely have limitations over a lens with non-diffractive design
Right.
in terms of photopsia.
So I absolutely agree with Zen. So there is always a debate, and we all have that question that will you implant this lens in your own eye if you have cataract, supposedly. Then of course we would think and explore our options which are non-diffractive technology and try to avoid any ring-based lens, not for the Synergy part, for any brand ring-based lens we would avoid that. Because anybody who has active lifestyle, they are going to have problems. So we choose our patients according to what they want and give them accordingly. So customization is always important. I would want to avoid a diffractive technology for a young patient with active lifestyle.
Thank you so
Thank
much,
you.
Sridhar. And the next speaker is Dr. Aman Khanna, and good friend of ours, and he's going to speak on phacoemulsification with CRV IOL, which offers continuous vision from 33 centimeters and beyond. Aman.
So a very thank you to the UC Governing Council to give me this opportunity. This is a deferred life surgery. So this was a patient in her early mid 30s, and she underwent IPCL surgery 6-7 years back and developed cataract. So the main the patient was really apprehensive, and she wanted a spectacle, complete spectacle independence. So she was taken for surgery. We calculated the IL power, and I counseled the patient to undergo a Synergy implantation. I've tried to keep the video as unedited as possible and just forwarded at certain points. So the routine phaco steps were performed. IPCL was removed out, as it's a very soft lens. You don't need to explant the incision to take it out, and it came out very smoothly through the 2.2 mm incision. And after that, a hydro was done. Irrigation was done to aspirate the visco, and then we started with the phacoemulsification. So this was a young patient, so my challenge was to make a very adequate size of rexus. Probably this was a little smaller than I usually go for, and as I was continuing the case, the pupil has also started coming down. This was a very soft nucleus, not a very hard one. Only the center part was a little hard. So I normally do modified chop, but in this, as soon as I try to do the modified chop, the nucleus got split into half, and it was prolapsed into the AC, and I continued with the direct chop. You can see as soon as I try to rotate the nucleus, the core of the nucleus just came into the AC, and it was quite easy to emulsify it. And after doing the pupil has started coming down in this, so irrigation was a little challenging. So so the most important point in implanting any trifocal lens or any premium lens is the centration of the lens, which is extremely important. So you can see the lens was well centered, and the patient was quite happy after the surgery. Thank you.
Thank you, Aman, and I think you are a retina surgeon, but doing cataracts also very well. So, Dr. John, any comments?
Excellent presentation. I've also seen post-op cases of multifocals, and it's nice to see their reaction and how they say that, you know, after surgery how happy they are and about their satisfaction.
So, I'm using Rainer EMVs from quite some time and very happy with the results. At least none of the patients are complaining. So that is the most important thing in the multifocal or EDOF category. If patient don't complain, that means patient is happy. So that is the advantage of Rainer EMV lenses, and I'm really happy. Any experiences?
Synergy, yeah. So this one is we are talking about synergy.
Okay.
So pardon for that. So yeah, synergy has been giving good results. So I think Dr. Jofi is, I think he is also a VR surgeon. So I would want to know, have you experienced any difficulties in posterior segment examination after any trifocal lenses when patient comes to you for any retina evaluation?
Not really. I think we do indirect ophthalmoscopy if there's any difficulty. So
Yeah, but in case in some patients, if later on I have to do a PRP, in those cases, the peripheral part that might be a little.
So it hampers your peripheral retinal examination.
When you're doing PRP, the beam you are that might.
Patient may be happy, but that is what I'm asking for when we have.
Yeah, not very much, but yeah, a little more challenging than what we do in routine cases.
Next is Dr. Jain. Dr. Jain Khatib, and he's speaking on new design, new standard, Rainer Ray-1 hydrophobic lenses.
So this is a sponsored talk by Rainer, and we are going to now move to the EMV, which is a very popular lens among all of us. I was going to use this presentation to explain a little bit about aberration, since this lens is based on spherical aberration. But you know, due to lack of time, I'll just skip this first part on aberrations, and we'll just directly move to the lens itself. Right. So we all understand spherical aberration. I hope so. So just to get a few basics on this, when light enters a convex surface, you have the marginal rays and the peripheral rays. Peripheral rays are shown in yellow. And when they all focus at a single point, this is called as zero spherical aberration. And this surface is called a defocus surface. It doesn't have any other components of aberration. So defocus is your lower order aberration, which is Z20. But the moment the surface is slightly more curved at the periphery as compared to the center, what happens is your marginal rays focus at one point, but your peripheral rays focus in front of it. And this leads to an elongated point of focus rather than a single point of focus. And when the marginal rays focus in front of the peripheral rays, this is called as positive spherical aberration. Now, if we dissect this surface, which induces positive spherical aberration, in terms of mathematics, it is broken up into its individual components. And its individual components are two. That is, the first part is your defocus. So defocus has only two slopes, which focuses at a single point, but now because it's focusing at multiple points, you have a second component, and this component is Z40, which is primary spherical aberration. The number 4 comes from the number of slopes. So there are 4 slopes here. And if you see, the two bulging parts are in the periphery, so the rays focus in front. So this is called as primary spherical aberration, and any surface which induces primary spherical aberration will increase some amount of depth of focus. How do you measure these aberrations? The measurement is done in terms of microns. And in a very simple way to explain how this measurement of the surface is done, if you look at this red surface with 4 slopes, you just draw a line. You draw a line connecting the two ends, and you measure each of the elevations from that line. Let's say, for example, both these elevations are 0.3 microns. Now, if you want to sum up the total, you square each of these and add them and do a square root, and then you get the sum total, which is RMS, root mean square, because you've squared and done a square root. So this is the total spherical aberration this surface is inducing. So now the question is, to induce depth of focus, how much amount of spherical aberration is needed?
okay, before it can worsen. So we all know this, that when we've been doing LASIK for so many years, we change your prolate cornea to an oblate cornea, you make the periphery more curved. So you in fact are inducing Z40, you're inducing primary spherical aberration. And we are all very happy with our LASIK results. The reason is because the eye can tolerate certain amount of spherical aberration without losing contrast. And how much is that? This study was conducted by Reinstein et al. Many years back, and they said while doing LASIK, 0.56 microns of spherical aberration up to inducing that much doesn't lose any contrast in the human eye. And this study by Rocha et al. Actually verified it. If you look at this graph, you can see positive or negative spherical aberration on either side induces depth of focus, and beyond 0.6 on either side, there is no depth of focus induced. It's actually reaching a plateau. And this is another study which shows how much is the actual vision. This is done in a simulated model, how much vision is induced by spherical aberration. So even this is telling us that up to 0.6 you can induce. And this chart tells us that more than 0.6 is called as toxic depth of focus. So you can only go up to 0.6, not more. So the Rayner EMV, it has a central part which induces positive spherical aberration, but only 0.15. We know we can go up to 0.6. Then why is it only 0.15? It's because the human cornea already has a positive spherical aberration. And if you look at the graph below, most of the population has a spherical aberration in the range of 0.25 to 0.3. So this 0.25 to 0.3, if you add it with the Rayner EMV 0.15, you are in the range of around 0.35 to 0.5, which is the ideal amount you can go to. And if a patient has, say that 0.3, EMV 0.15 is beneficial. If there's a slightly more positive spherical aberration on the cornea, it is still beneficial. If you have a low spherical aberration of the cornea, then you are not going to induce depth of focus, but at least you are not worsening it. So these patients will not have adverse outcome, but they won't be benefited. But if you have a post-LASIK eye where there's already high spherical aberration induced and you put in EMV, then these patients are not going to benefit. So ideally you should target mini monovision, where you do slight amount of monovision if you want that near with Rayner EMV, and that is the best way. To summarize this lens, the disadvantages are that it doesn't give too much depth of focus, but combined with mini monovision, it gives a decent depth of focus. Ideally, you should always measure corneal spherical aberration prior, because otherwise the results can be unpredictable. But the advantages, it has zero photopic phenomena, it has zero loss of contrast sensitivity independent of pupil size. So as compared to other IOLs where you can't say much about the safety, this is an extensively studied technology, and there's a reason why speakers like Briarett and all over the world are talking about this lens, because it may not give depth of focus always, but it will never compromise on the safety. That is the loss of contrast in the patient. So that's about. Thank you.
So when Zen speaks about optics, he makes it so easy to understand that all of us now understand what is spherical aberration and how to modify, how it has been modified in the Rayner EMV lenses and how it is implemented to increase the depth of focus without losing the contrast. So Zen, we all have been using, you and me, we keep discussing about Rayner EMV outcomes. So initially when I also started using, I had a bit of resistance in my head that it is a hydrophilic lens, and traditional thought process is that any hydrophilic lens will have very early PCO and more chances of PCO and stuff like that. So what is your experience about the material which is hydrophilic, and yet how was your experience about PCO rates in your
yeah, so even I haven't used that high a number, but I have not got a single PCO, but from experienced surgeons who have spoken to, have used a lot, they've said the PCO rate is really low. So it is something to do with the square edge that is not allowing the PCO to happen in these lenses.
Have you used these cases in any cases which I'm going to discuss, like any retinal pathology or any post-LASIK cornea, because I'm yet to use in post-LASIK cases?
Yeah, so theoretically, I don't think it should make that much of an impact because it induces such a small amount of optical change. But still, we should be wary in terms of other things in the eye that reduce contrast. But if you measure corneal spherical aberration and do it, I think you can be quite okay. So if you do it in a post-LASIK eye where, say, 0.6 microns of spherical aberration is already there, and you add on this, it's definitely going to reduce the optical quality.
Absolutely. So yeah, I think I would request
at the end.
At the end, yeah, fine. So next speaker is Dr. Samant Shetty. Is he here? Yeah. He'll be talking about his deferred life surgery on Renner EMV. Over to you.
A very good morning to everyone. I thank Yosi and I thank everyone for the opportunity here. So I'll start off. I have no financial interest, and I need to acknowledge Dr. Barrett for collaborating with Rainer for this lens. So what happens here is, like, normally our eye has a positive spherical aberration. So almost around totally we have around 0.3 microns. But as we age because of cataract, so the lens loses its spherical aberration, and now all the IOL which are there, which try to give you a clear vision, uncompromised, very clear vision, less everything which is there. So they all try to hit a target, like, to give us to match the positive spherical aberration of the cornea. So everything what's there right now is like I've just marked it just in case, like I'm using their toric EMV here. So I marked just as a precautionary plan B. We go ahead with the rexus here. Here again, for these kind of lenses, your rexus, even if you defer it by a little here and there, it's not going to make much of a difference, as it's not pupil dependent. And like coming to the cataract part, like since it's almost around NS3 part, I'm going ahead with like a vertical chop. So yeah, I try to do a vertical. I've done a vertical chop. I try to cut it into pieces. So ideally when you're thinking of an ideal monofocal, we need to have an uncompromised vision for your distance. It should be like minimally invasive, less of your PCO rate, less inflammation, and all that thing. But there is no such thing as like an ideal IOL. Each has like a mix and match thing. So that's to compensate now in the era right now what we are targeting, presbyopia. To achieve the gold standard, everything like we are trying to to match up to it. There is certain, like when this EDOF have come into the market, there are two things which are there in the EDOF. One is the diffractive and the refractive, as we know. The diffractive, which has the ring, like your Lara and Symphony. The refractive, like the Technis, iHands, the EMV, all fall into this category. So there is like this American National Standard Institute which given the guideline, like there are three more important guidelines. One is to maintain your depth of focus, which has to be more than 0.5 diopters, better than your monofocal control at 0.2 logmar, and the distance correction has to be better than your monofocal control, and the best corrected vision should not be inferior to your monofocal control. So coming back to the cataract part here, yeah, I use a coaxial preferably. So once we have got the cataract part, like especially in the last, I've used a sharp chopper initially, and I've changed to blunt because in the last piece, I wouldn't want the sharp chopper to have cause me a problem. So once everything is cleared off, I usually again try to do a saline wash just in case for any of the epithelial cells which are there to remove it, and I wouldn't want those cells to cause another factor for PCO here. The lens part, like for this EMV, the basically means it's your enhanced monovision lenses. So these lenses come into your EDOF, like enhancing your monovision criteria. So these lenses, when you inject it, you are not going to see any kind of rings, zones, or any aperture what you would see even microscopically to see if it's not possible. Basically, this lens has an aspheric anterior surface with your center having your positive spherical aberration. As it goes down, it reduces, and the last, your periphery is aberration neutral. So this is with the Callisto. I'm rotating it, and I've got it into place. So yeah, I'll just skip this parts. So coming to the, yeah, So what is it, the design? As we said, like we spoke about it, it has an anterior surface and a unique optic edge. So as it comes back, it blends and gives you a smoother transition from distant to near. And since it's a diffractive platform, there is no going to be like any chance of your dysphotopsia. So it has a unique spherical patented positive aberration. So basically it elongates, stretches your focal point, and therefore it gives you an increased depth of focus. And since it doesn't have any rings, it doesn't give you any dysphotopsia. Basically the design is tend to give you a minimized decentration and to reduce your aberrations. Coming to the PCO, I think this picture sums it up. Once you put the lens, after a while the optics, it tends to contract with the haptic. The haptics tend to contract with your optics, so therefore it doesn't allow your lens to again move into the center. So that is why it reduces your PCO rates. And the glistening is less because it has a vacuole free, it is made up of vacuole free material. So that is why there is hardly any chance of any glistening there. Technical to see, it's got a good Abbe number, so that decreases your chromatic aberrations. Coming to the injector part, it has an easy two-step system. Basically, it is again already inside a saline, and you just need to take it out, put visco inside the set place there. I think I'll just show you with this. So this lenses are very soft. It's actually comes in like a rollable format, and it's 2.2. It's suitable for a 2.2 millimeter incision. And it doesn't, you don't need to worry much to handle it. You don't need to take something or put or to do for inject visco from front, back and all that, or you have anything of that. So just inject visco inside the hole there and you're good to go. And the ease of implantation is very smooth. So you don't, it goes very smooth. It doesn't have that thrush or like that sudden jerk movement which you'll see with some of the IOLs which are there. See, that's it, that's about it. So that is how smoothly the lens go. And when this is my personal experience when we are comparing about the 3 EDOF IOLs which are there in the market, mainly your iHands, your Biotech or the Rayner. See, this is mainly even the only lens which is optimized for a monovision treatment. So basically you can correct your dominant eye for a distance and the non-dominant eye with your monovision by 0.5 to 1. So which gives you an extended depth for your focus, and it gives you a very good intermediate. And we have done almost around 200 eyes with EMV. All have been doing very good, almost more than 98% having a 6.9 and a good intermediate, and almost for a very fine print we are giving that. So conclusion is you need to market these lenses as a premium monofocal lenses. They anyways give you a good intermediate, no halos, starburst or anything which is there, and the toric platform is something which is really looking forward to. Thank you.
Thank you, Dr. Shaman. So my question is, you've done so many EMVs and you've studied the refractive outcomes.
Yeah.
What is the A constant used? Because a lot of EMV users have also said that because of that central aberration, it causes a little bit of a myopic shift, or you see a little bit of myopia post-op.
See, we use IOL Master 700, so we are using the Barrett's formula there. So when you're targeting for emmetropia for your distance eye, you can keep it the same. But if you're targeting for a monovision, it's better you do the non-dominant eye slightly myopic. You can, it's again a personal experience. Some have done for 0.75, some have done for 1. We have done majorly for 0.5, and we have got a very good result. Our patients are very, very happy, and they've almost only for a very hardly some patients we have given for a very fine print. And as they have mentioned there, in their product, SRKT formula, all that things, 118.6, that's how it is. But
do you take the first hyperopic shift, because that is what they suggest, not to take a myopic shift, but you take the first hyperopic power as compared to the myopic power. This is what the company recommends.
How it comes, the slight hyperopic, plus 0.13 something. So that's how we take it for the emmetropic, but non-dominant, we try to make it like a 0.5.
Any experience where the best corrected vision doesn't go to 6/6?
See, it goes if you're trying for a proper monovision, but they are comfortable. They come till 6/6 parts, but when you're promising for an intermediate and this thing, it's very thing which they don't get it in any of the thing. And especially if you're getting patients who are like, dry and software, like compared to your trifocals, this is something which is like you're giving something little better.
True.
So
True.
that's
True.
Yeah.
Any experiences in cases of early RMD or any?
Sir, till now, almost like 6 months, we have done so many numbers and still counting. We have not got any problem. And even in the PCO rate, I think we have hardly got one out of now who's got it. And that I think like, we do try to give it a wash again sometimes like before we clean it. So, and as I said, like the lens even contracts it with the aptic and optic. So that we have not seen, even the results in any of the studies, it hardly shows 1% of the patients have got YAG cap. So there's not much of a thing which we have seen. Especially in case of your early ERM, also these lenses have been doing great. We have used for 1 to 2 patients, so they are good.
Thank you so much. Thank you. So the next is Dr. Nikunj Tang, and he's going to speak on extending range without compromise, a bouquet of special cases of EMV.
Thank you, sir. And I would like to thank Team YOSI and Renner for inviting me to share my experience about Renner EMV and EMV toric in special cases. So Renner is one of the gold sponsor for the YOSICon, and we are all grateful to them for their generous help with this wonderful conference. So what I'm going to show is my personal experience. It is not an RCT based data. So Renner, in collaboration with Professor Graham Barrett, they have designed this EMV lens, which is a truly non-diffractive optic lens, which gives a 1.5 diopter of depth of focus without compromising the quality. That is what the their trademark line for the lens. And as Zain has explained in a very nice way how the spherical aberration works. And so everybody, we all normal corneas have plus 0.27 microns of spherical aberration, and when the EMV is implanted, it adds 0.15 micron, and it is a beneficial, and it increases the depth of focus without compromising on the quality. So it is not always the same case. So there will be corneas which has a little bit of higher corneal aberration, but less than 0.4, that will be still beneficial, and corneas with the lower spherical aberration, the spherical aberration will be increased, and it will also increase the depth of focus for them. But what about the cases like post LASIK, where the spherical aberration pre-existing is a bit on a higher side? Would you add more spherical aberration to that cornea? And this area needs to be explored. Theoretically speaking, it should not work. So in my practice, I use more Renner EMV as a mini monovision, as Zen also agreed with that. So we target 0.5 diopter of myopia for the non-dominant eye, and binocularly patients are happy for the distance and intermediate and near vision also. We only promise them functional near vision. So Renner EMV, coming to the Renner EMV toric, it has been evaluated worldwide across the 9 countries, and the data was promising with a good distance, intermediate and near. And when it comes to cylindrical outcomes, it was also satisfactory in most of the cases. So what about the few different cases where you would not want to use any diffractive IOL? And those 3 of the cases I'm going to share. So these are the 3 cases. The first one is a patient with a history of retinal detachment. For second is post-RK patient with a high aberrated cornea, and a case of macular edema due to BRVO. Under management for the macular edema. So when in a post-RD cases, we have different challenges starting from IOL calculation, if it is silicone oil filled eye and stuff like that, the condition of the retina and visual prognosis, and if it is a post-wet eye, there is a high chance of lens iris diaphragm movement, and you can get a PCR or a pre-existing PCR can be there. So this gentleman who was 67-year-old, history of retinal detachment surgery 4 years back, you can see there is a demarcation line which is actually sparing the fovea of 70 to 80%, but still involving a little bit of inferior part of the fovea. You can see in the OCT. So he was a myope, and he wanted to get spectacle independence. So obviously the trifocal would not be the choice here. So this was these biometry data, and you can see there was a cylinder. So I decided to implant a toric EMV lens. So for toric calculation, they have this wonderful platform, Ray Trace. It is a very user-friendly interface, and you just enter the data, all the biometric data, and gives what I love about it is that it gives 3 options of even your EMV lenses, and expected spherical as well as cylindrical outcome, and you have to decide which one you want to choose. So for this patient, I intended to target a 0.5 of myopia. He was pre-existing myope, so I went ahead with the 14.5 diopter toric lens and got a good outcome. Case of post-RK. So post-RK cases have a different challenges from IL calculation to surgical planning. So this lady was a 57-year-old, underwent RK for before 30 years. She was already operated for the right eye, which was a monofocal lens, and she was happy for the distance with that eye. But she wanted something better for the other eye, which she came to me to get operated for. Fortunately, in this case, you can see the RK cuts were so many, like around 20 RK cuts, very near to each other, but they were not very deep. And the central cornea, which is clear, at least 3 to 4 millimeter of the cornea should be clear, then only you think about any premium lenses in such cases. And the topography, I always look at in these cases, and you can see there is a not very flat cornea as we see in normal other RK cases. And there was a predictable astigmatism on holiday EKR map. I look at the 4 and 4.5 millimeter zone as well. And compare it with the biometry data from the IOL master. It was showing blank report when it comes to IOL power, but the biometry was showing 1 diopter of cylinder, which was matching with the topography. So for these cases, you need to use ASCRS calculator for post-RK cases. It will give a range of IOL. So if it was a monofocal IOL, I would have targeted myopia, and I would have chosen a little bit of myopic target. But Renner has the spherical aberration, which gives a little bit of myopic shift. So I decided to implant a 21 diopter lens in this case. If it was a simple monofocal lens, I would have chosen 21.5. So it was a toric lens. So this was the calculation, and you can see the target for the IOL plane, it was only 0.75 cylinder. This is a short video of same patient undergoing surgery. In the interest of time, I'll just skip that because already we have been seeing how the injector works and all. So post-operatively, even to my surprise, this is the slit lamp video post-op day 1. You can see multiple RK cuts, the cornea is crystal clear, and the vision patient was reading 6.6 and N8. I had to cross-check again because I was not able to believe that this is what she is reading. And she was extremely happy for this eye. And you will be able to see the post-RK incision superiorly, which was started from the scleral side. That's what we do in the post-RK cases. So coming to the case of BRVO, which was under the management, she was a young lady, 45-year-old, wanted a better lens because younger patients have higher demands, and you can see the OCT here. After management of macular edema, there was still a cyst there. It was post-Ozurdex, and she developed cataract. So obviously, we would not give a trifocal lens to this patient. So I discussed all the pros and cons and decided to implant an EMV with a 0.5 diopter of myopia, and was able to deliver the patient when and implanted a 20 diopter lens. Patient got a 6.9 with N8 near vision, and she is happy with her vision. She had a phakic lens, phakic in the other eye. So this eye I wanted to keep a bit of myopic, so she can use it for the near vision as well. So Renner EMV and EMV toric gives a broad range of vision without compromising on the quality. And mini monovision is the go-to technique for our routine cases. And it works really well when trifocal would not be the choice, but it also depends on your other parameters of the case, and you have to select the case whether to implant or not. Thank you so much.
Thank you, Dr. Nikunj. And I think Dr. Nikunj is a very bold surgeon. The basic understanding of EDOF or EMV lenses is that we should go in a absolutely normal cornea, normal retina, and everything should be normal. Even the astigmatism should be less than 0.75. But with the results, I think it's time we should think in some challenging cases also we should try these lenses. And I think in next conference he'll come with more challenging scenarios with EMV lenses. Thank you so much. Thank you.
Thank you, sir.
So next is our dear friend Dr. Priyank, who came from Bangalore, and he is going to speak on when expectation and outcome align, a personal experience with Raymond trifocal. So from EMV, we are going to trifocals now.
Right, so good morning, everyone. It's nice to be here with this room with all the young ophthalmologists who are going to be the future of our country. So I'll be talking about the Ray-1 trifocal IOL. So in this modern day, we have seen that we have come from a long way from being just a cataract surgery with an improved vision to a refractive surgery with a better lens and a more spectacle independent life. So we see our patients coming on in this today's OPD who they ask us for, I want to have a spectral independence life, I want to do a night driving, I want to do trekking, hiking, kitchen work, and as much as possible, live free life. So from monofocal, we have to go forward to multifocal, and now we have a better technology lenses, which are the trifocal. Now we have known Arena from a very long time. It's been in our country for more than a decade, and we have been, my personal experience with this, with them is about more than 8 years plus. We have been using right from monofocal to torics, and now I am using their trifocals also. So to just give a small brief on their design, three more important points which I would say is, one, because of their specific square edge, the apple moon square edge, the PCO rates are minimal. They have a zero glistening. I'll show you why they have a zero glistening also, but the one main thing in a trifocal lens which they use is an aberration neutral aspheric optic, which is their patented design. So what they have done is, they have combined both a typical asymmetrical with a symmetrical one to give a better outcome in a diffractive pattern. So what it gives you a better near zone, which starts from 37 centimeters up to a far one. Now this gives you a continuous zone of vision, which gives a 3.5 at near, 1.5 to 1.75 for intermediate zone also. Now when combined with the bifocality of your eyes, it becomes an excellent depth of focus for vision. So it has a 16-step diffractive rings. The central 4.5 mm is the one which is a trifocal zone. Now this design which is done is to decrease the photo of visual disturbances which we see generally specifically in a scotopic zone. The peripheral 4.5 beyond that zone helps you to see the distance vision. That is why you would be surprised on first post-op day or third post-op day, when you do an AR in these patients, you will see a minus 1.5 in your AR. So you should not get scared that post-operative when pre-operative when I try to do a 0.2 or 0.3 or 0 emmetropic zone, but when the AR reading is showing 1.5 or 1.25, 1.75, be happy that you've gone an emmetropic zone, because the central one is the 1.5 mm which is going to be targeted. So when you see this design of the lens is such beautiful that it will give you a equal distribution, distributed light zone. The loss of light is just about 11% when compared to others for 15 to 18% in Physiol and Zeiss. The splitting in the 3 to 4 mm zone because of the design of the lens is 52% for distance and about 28 and 22% for intermediate and near. So they have, of course, because of the preponderance for the near it gives you a better near. The intermediate also improves with the bifocality. Now, when you go for a scotopic pupil, when the size of the pupil is a bit larger, the light distribution is mainly given for your peripheral zone, which is what is required for distance one. So this is one of the proprietary margin material which is used, called as a ray acryl. This is a homogeneous material which is made by themselves, which is free of microbacterial. Hence, this is a glistening free IOL, and hardly you get any glare in these lenses. So comparing with the markets, what we have popular lenses in that is a fine vision Physiol, 80 Lisa, Tri, and Icon Panoptics and Ray1. So I would just finish in 2 slides because this is what is more important. This graph shows it all. When you see the Zeiss, it is like just a bank of river appearance where it just divides into 3/4 and that's it. Physiol does better, but because it's mainly far dominant, so your intermediate and near actually comes on with larger pupillary size. Alcon and Rayner does well, but when you see the Rayner part, when you go beyond 4.5 to 5 mm, specifically in the scotopic pupil, the distant dominance picks up much better. So to highlight the differences, the light loss is just 11%. It is an aberration neutral when compared to others which are positive. It is a closed loop, hence the stability of these lenses are excellent. Even a small degree of tolerance can be done in these lenses. It is a fully preloaded platform ranging from +10 to +30, and I have personally used a +28 and a +30 in a teacher who has got a post-operatively 6, and 6, and she's been happy, and she's in fact referred 2 more patients from her who are also teachers. They're also doing well, and it is a 2.2 mm external incision, and internal is just 1.6Y. So there are 2 peer-reviewed studies which I will share here. One is by Feria, who has, they have compared between the trifocal and the Physiol. Both have a similar outcome, but the statistical significance is not much. But when the patient's experience was asked, the depth perception, according to the patients, were much better and comfortable in a trifocal lens. Similarly, when compared with Panoptix, all 3 did well, but Rayner trifocal had a better depth perception because of the central 4.5 mm. This is what it is. This has been already explained. The beautiful thing is it is just 2 steps. Just inject the visco, close, rotate to a the cartridge has to just go to a right angle, 90 degrees, and inject. The injection is so superior, so soft, it's effortless, and within about 2 to 3 seconds, the lens is in the bag, and it opens so smoothly that you don't have to even rotate also. And the stability in these toric lenses are also done. I have done quite a few of toric trifocals also. Here and there are 0.5 residual here, but then because of this pupil independency, it does very well. Okay, thank you.
Thank you, Dr. Priyank. Dr. Priyank, how different you find these EMV lenses, trifocal lenses from the other company lenses, trifocal lenses?
So first
Any
thing
major
is,
difference you found, or?
in post-operative not much, but yes, the depth of vision, it does do well. As a surgeon in the OT, I really feel these are better because the injection system is just superb. There are only 2 companies which do this fully preloaded. One is this and the Hoya. The other one you have to either load it or semi-preload it. Sometimes if you don't load it well, or your assistant don't load it well, you have the trailing haptic getting stuck and all. So here there is absolutely nothing in that part.
I think the other advantage with the trifocals of Rayner is the cost factor also.
Yeah, I think.
It's very well suited to
So
our
even though this is hydrophilic, I've been using their lenses for almost 8 to 10 years. Hardly there is anything you see, and even though they are hydrophilic lenses, you hardly see any PCOs. So otherwise, the lenses are excellent. Yeah, cost factor, I think you cannot talk to the company guys. They will help you out with the best possible rates. Now you have to be busy with them.
better cost than others. So moving to the deferred light surgery from Dr.
Thank you.
Parth Shah, he'll be showing you the video of Ray-1 trifocal.
Good morning, everyone. Thank you, Yosi, for giving me this wonderful opportunity. Today I am going to present deferred light surgery for a Rayner trifocal lens. So without wasting much time, we will direct move to the surgery part. Here the patient is 62-year-old male patient, non-diabetic, nuclear sclerosis grade 3, and patient wants spectacle-free life. So I have decided Rayner trifocal lens. As you are seeing initial cataract steps, generally I do CCC of around 5 to 5.5 millimeter zone, and make sure that the last part of CCC will cover the initial part overlapping the initial zone. So it will give a huge stability. And after putting visco, I am generally doing biplanar 2.2 or 2.8 millimeter main wound incision, and then hydro dissection and hydro delineation is done. And after putting visco, I make sure that nucleus is freely rotating, so that the later it will not do any trouble. Now comes to the phaco part. I generally do bevel down phaco emulsification. The advantage of bevel down is that less energy pass to the corneal endothelium, and I am doing direct chop. You can also do divide and conquer or stop and chop. Here you can see that I am trying to make a cut, initial cut, but the attempt was not successful. So I am rotating the nucleus, and again I am burying my phaco probe, and just I am doing direct vertical chop. Here initial crack is done, but you can see that nucleus is not divided. So again I am going deeper and deeper, and then I will do the deeper cut and now you can see that the nucleus is divided. Yes. So now the part is very much easy. Now I will just divide the rest of the nucleus and phaco-emulsify and then sucking up the nucleus. I am using the Utley Catrax easy machine, and my parameters are 50 power, 300 vacuum, and around 300 vacuum and 30 flow rates. So just cleaning up all the materials, Catrax. My phaco probe is, you can see that it is in central zone, and I am trying to get the nucleus towards the phaco and try to emulsify the nucleus. And you can see here I have moved my chopper during the phaco emulsification of last piece so that the AC will remain stable. And after all this emulsification, I will do my irrigation bimanual irrigation aspiration, and during that I will generally hold swipe movement, bring it to center, and then suck. And usually I follow a clock or anti-clockwise in a fashion manner. I will do the bimanual irrigation aspiration, and after cleaning of all the cortex, I will just directly move towards the implantation of Raynaud trifocal IOL. Here you are very much saying that the lens is come with the saline because it is a pure hydrophilic lens. The injector is in the tray. This is a Raynaud lens. You are very much aware. So this is a very doctor friendly injector system. Just only 2 steps injector system. Yes, you have to push some visco, yes, and then close the flap and you are ready. And the nozzle size is just 1.8 millimeter, so you don't have to enlarge your incision. You can easily do a wound assisted from 1.8 or 2.2 or 2.8 millimeter zone. Generally I do all my IOL implantation during hydro. So you can see this is a hydro implantation. The lens is coming so smoothly, and you can notice that I don't have to move my hands or injector to clock or anti-clockwise direction. Just leading haptic goes inside the bag and the trailing haptic, yes, very smoothly opening. And you can also see that even though it is a hydro implantation, the lens is so stable that it cannot wobbles up. It is very much stable. And with the irrigation cannula, just I am tapping 2 or 3 times over the IOL and all the viscose are coming out. So here it is done. This is a hydrophilic lens. Previously Dr. Priyank has nicely elaborated the specification of trifocal lens. The 4.5 millimeter zone has a 16 rings, and the central 0.9 millimeter is ring free. This is a well centered in the bag IOL. Okay. So my implantation tip is, after closing the flap, you should see that the flap is on the right side. So with this flap on the right side, the bevel is down, and you are all done with the injection. No rotation of injector is required, and during the trailing haptic, you also don't need to rotate the trailing haptic. Just tuck in and the thing is done. And please do not use cold OVD. So this is now with implanting so many trifocal lens, this is my personal result that 98% of my patients are within plus or minus 0.5 spherical aberration, spherical equivalent. Rotationally it is very stable lens, though it is a trifocal and the rings are there, so the patients are complaining halos and glare, but all are get adjusted within 2 to 3 months. So it is a very reliable reflective choice of lens. These are few professionals who are enjoying Raynaud trifocal. Doctor, bank manager, lawyer, one table tennis player is also using, teacher and photographer. So Walt Disney rightly said, the way to get started is to quit talking and begin doing. Thank you. Thank you so much.
Thank you, Dr. Parth. It was excellent surgery. The case was really challenging and a lot of fibrosis was there, and you did very well. one important factor that we have seen in this video was the hydroimplantation. It's a really a wonderful technique that we all should learn of doing hydroimplantation because it saves time, saves money, and saves inadvertent post-op complication like raised IOP.
Basically, we are very much hurry during the last steps of surgery. So the visco removal is the main challenging stuff.
In the high volume practice, it's really you feel very boring while removing visco. How much time you have to.
So it will next day it will cause the raised IOP and all the things. So hydroimplantation will all cut off all the things.
Another thing is the centration also. In trifocal centration is a very important.
Yeah, and for that.
Look for the Purkinje images. It should be bang on center to get the best result.
And for that, the Rexis is the main crucial step.
And I think, as all competent surgeons, we are all doing good Rexis.
Yeah, thank you so much.
And just the last comment that Rainer, I will raise some trophies for Rainer speakers. So just we'll do that thing also. Okay. Okay. So next is the. Okay.
Why Yoshi?
A very good morning, everyone. So we just like to start with this, leaders are made, they are not born. They are made by hard effort, which is a price which all of us must pay to achieve any goal that is worthwhile. And mentoring is about, motivation, advice, success, direction, coaching, support, goal, training. So a warm welcome to everyone to the AIOS session of how the mentors did it. And it gives us extreme pleasure, and we are highly honored and privileged to have our top leaders of AIOS with us, and we are going to have a candid rendezvous with them on how they did it. So let me start by welcoming our panel of mentors and leaders. Dr. Samar Basak sir, please join us on the dais. Dr. Namrata Sharma ma'am, Dr. Vanati ma'am. So we are going to have our mentors talk to us in this segment about their residency and training, a small snippet of their family life or a family bite, a turning point in their life or one of their achievements and their role as a mentor. So now I would like to invite Dr. Sonal Kalia, our YOSI president, who is the associate professor at SMS Medical College and Hospitals, Jaipur, to start the rendezvous with Dr. Samar Basak sir. So over to you. So let me start by introducing Dr. Samar Basak sir. Sir is the current AIS president. He's done his MBBS from RRS Medical College. He's an RPC alumnus. He has the Disha Hospital setup has now 18 branches and is doing a phenomenal job. He received his FRCS degree in 2007, and he has been serving as an examiner for further FRCS examinations for 14 years. He's published 8 textbooks in various diverse angles. He's been on the review board for 11 international and national peer review journals, and he's received numerous awards for his video presentations, papers, and work in the field of cornea. He's received 15 international awards, including 6 Best of Show Video Awards at the AAO over the years and 25 national awards. He's also received the Dr. P. Sivareddy Award from AIS in 2021 and has received the Achievement Award by AAO in 2008 and by APO in 2011. He received the Senior Achievement Award by AAO in 2015 and Senior Scholar Award by AAO in 2017. He travels all around India in Southeast Asian region with organizations like Orbis, and he, in his free time, indulges in hobby of collecting postage stamps with the unique theme of ophthalmology, ophthalmology plus philately. I'm pronouncing that right. He has more than 650 stamps in his collections, and he also has written a book pertaining to the same. So over to you, Dr. Sonal.
In a very small way, with the help and support of our mentors, today the tables have turned. Till last year we had the AIOS YOSI forum, and today we have the AIOS session at YOSICon. So it's my proud privilege to have Samar Basak sir, Namrata Sharma ma'am and Vanati ma'am for our rendezvous, how the mentors did it in the AIOS session today. And to just show you, sir wanted to be very candid, but also wanted to be on the point in each and every answer. So we've divided his questions into segments. First pertaining to the residency and training, thereafter something related to his family, and then related to his achievements, and then his role as a mentor. So sir would like to answer them in his own way, and I would now hand over the podium to him. Instead of just starting with the questions, sir will like to come. So would you like to connect? Ma'am has received the question.
Anati has not received the question. Bite, family bite. Okay. Okay, okay. It is just a different way of thinking. Daldo. So I thank you, Sonal, and all the leaders of YOSI. Actually, Sonal called me and said about this. I said that I am not a very good in talk as an extempore. It is very difficult for me. And better send me the question. I will answer in my own way. Some of the things you may or may not like. And also I disagree with the family bite. Conflict of interest. So that is personal. So now, these are the questions for all, as I could understand.
The first few questions are for all, definitely.
Okay,
sir.
for all panelists, yes.
Yes. But now we've divided them into segments, sir. So
Segments, segments, yes.
Yes, yes.
Four
So
segments, yes,
four
yes.
segments. So the first question to you was, how was it being a young ophthalmologist?
That's fine. So I have put it in slides because it is better understand. And great journey in RP Center as a junior resident, shy Bengali guy from semi-urban area with poor English and Hindi. But I was popular among co-resident and teacher because of my some skill, very good handwriting and very good line diagram on those days, and my expertise in ICCC. There are only two people in the RP Center at that time. They knew how to give a phone graphist knife section. I was one of them, and another person is Chief Madan Mohan. So I learned that in my 5 months house job in Kolkata. So I also being preferred by the those days great teachers, they are great teachers for line diagram for their, right now I was discussing those days there was no like PowerPoint presentation. We used to draw something or write something in a card, and the photographs was taken, and then Gansing was the person he used to in the photography, and he used to make slide format. So only you get one chance to make a slide. You cannot share with others. And I used to make the slide for Prem Prakash, Madan Mohan, Dada, Tiwari, and of course Professor Anita Panda, who was my chief guide for my thesis for modified MK medium for eye banking with animal study, dog's cornea. So that was my first love in eye banking, actually, so to say. And because of this, I was privileged to have better mentor-mentee relationship during my residency, not with others. I enjoyed those. In fact, Dr. Anita Panda gave me 3 cases in 4th and 5th semester. It used to happen at dead night, 3 to 4 a.m. in the morning, usually at night duty, MK medium preserved cornea, and you have to use it on the same day. So first case she assisted me, second and third case I did myself. हम बताया मैडम सो जाओ, रात हो गया सो जाओ, हम कर लेंगे, आप इधर देखते रहो. And no video that time. That video से देखे, so you have to see through assistant scope. That way she, and those were very rare for senior resident even, because whole year only 40 cases or 60 cases was used to happen at RP Center. And that was my only training with eye banking, and Mr. Beast was there as an eye banker. I learned a lot from him. So residency, fellowship, no formal training for me. Learned mostly self-learning by observing others, and learned by mistake. And lately I always observe YouTube videos, and I do a lot of wet labs. So I resigned from SRship from RP Center on 11th January 1988. Only 11 days senior residency. I will come to that story later. This is your second question. how is it different now and shortcoming of today's yo's life? I think I was discussing that today's yo's are well ahead than ours. Now I think there are more mentors than mentee. If you find everywhere, there are some kind of mentors. Right now I was sitting in IGO workshop or research. This thing I said, this is terrific. It was not there in our time. सर देख लूंगे थोड़ा लिखा है, अरे रख दो यार, हम देख लेंगे, अरे ये लिखा हुआ है, जाओ दोबारा लिखो. No critical analysis that time. This is the difference of today's. You are that way very much fortunate and very much blessed. And you have multiple conferences, webinars, so many. And you are getting chance as a PG. Podium presence. Namrata was telling after 10 years. I suppose after PG, maybe after 8-10 years, you got a podium. And that too yourself only. After a lot of struggle, one abstract just accepted, excited. So those are the other thing. So, and above all, I was just telling, we were discussing that you are doing your own YOSICon, on your own way, own design. Karan wrote me and sent me the program. I said, so that's a nice program, so much diversification of your things, like not only academics, but other things are there, which is very much required for any young budding ophthalmologist. So I love this, and what is called, admired also your way of going the things. So any shortcomings of today's year's life? I don't think there are any shortcomings in academics of today's year's life. There are plenty. But as you are getting everything ready-made in your hand. I feel the ready-made. First time the razor blade of twin razor blade when we are in PG days, ready-made. Initially used to make all these blade and those things. So things has changed. But which I feel that when you think of as a total life, there are three things I feel some of you, or many of you, I do not know, the patience is not there. Patience, probably you are following Moore's law. You know what is Moore's law. Many of you probably know the Moore's law. It is the law of computing. So how small, how fast, and how powerful it is. So small is a different part here, but how powerful. So every time every 18 months, 24 months, in computing world, it gets doubled. So in your life, you try to grab it very fast. I talk to many people used to come to our hospital for my suggestion, what we said, no, patience. And second thing is attitude towards profession and personal life. Something somewhere is missing. There is a huge generation gap between you and ourselves. So we are at a different, in between there is another generation. I was just discussing who are thinking, those who are between 40 to 50. No one was there. You are up to 40. 40 to 50, no one was there. They are in a serious crisis. Then other people, they are already family and everything, they are ahead. So, and also probably you are not thinking of long-term perspective in some situation. Maybe in family life, maybe in personal life, maybe your professional life. These are the three things which will take you further and forward. So these are the first segment is like this. Second segment, family bite, asked for video. I said nobody will agree for video. So I am getting little bit telling my family and everything, because I am the eldest person in this room probably. So 66. So early life, the budding thing, 30 to 35 years of my age, total family yo in a rural hospital, yo family in a rural hospital. So GDMO posting, government job, snake bite, poisoning, delivery. My wife, Dr. Bani, she is also ophthalmologist from Sitapur. Dual posting by government rule in the same place, in a rural place where electricity was not there. I'm talking about 88. A kind of honeymooning without ophthalmology for both for 5 years. Learned cooking, gardening, fishing, everything, other parts of life at that time, and started my, how I started my writing books. How do I spend time? So my first book in Bengali for layman, Chokhe Rasuko microsurgery. Because microsurgery in those days is a terminology like FECO today's or FEMTO today. Those days microsurgery sir apni करें, माने आपको microsurgery आता है, तो हमको cataract में microsurgery करना है. So that book was for about microscope, about cataract, about IOL, all these things. Completed my family, 2 members added, हम दो हमारा दो, उस दिन का slogan था, वो भी हो गया. And enjoyed early days of my fatherhood, including taking care of those kids. So actually it is not a waste, it is an opportunity to fulfill one part of life. So this is the book. You see that book? Again I have rewritten last year only, after 30 years almost. So how do you spend quality time with your family? Quality time, I think the term is little vague for me. It is different for every individual, every family, unless the wavelength matches with every member of your family. So quality time for Karan is different, for me is different. So wavelength, and it should be mutually matched. My personal life, 8 a.m. to 5 p.m., 6 days a week, since 97 when we built up the hospital. So no Sunday, we do not work on Sunday. So plenty of time to spend with family, children, wife. I stayed just 256 steps, literally. I used to have this thing, 256 steps from my hospital, my house, every day. So I save 2 hours every day compared to others while you are traveling and you are tired. My wife, though an ophthalmologist, she never practiced ophthalmology. She preferred a government job for the children because the job is fixed 9 to 3 p.m. and half an hour from home. And for children, for quality time and for their early growth, education, etc. And 11, she took VRS and joined our hospital as an eye banker, as our hospital admin, honorary. By that time, her dream fulfilled by the children. So she is happy. Many people thought she has done great sacrifice, that not doing ophthalmology. She said, I don't like to hear from the patient. I will do some admin work. So she was in admin in government job with tuberculosis control program as a district medical head. So she was happy. So many people do not like ophthalmology after doing ophthalmology. That is also true. So no regret from her side. Then my son Shoham, many of you know him, that cornea surgeon, budding, working with us, joined with us, growing on his own way. He is more on gaming and stock market also. I also used to, that is the quality time we spend with, no ophthalmology discussion, but we talk on stock market, we talk on gaming. I also have little time for just game. So you have to pass time, sometimes it is required. My daughter, 3 years younger than son, she is more brighter, but she never liked medicine. Being 3% in the family in medicine, she never liked medicine. Rather, she chose English and to express herself to the outer world. That too in poetry. Stephanian, MA in creative writing and poetry from UK, all done by herself because my family background doesn't say anything about English. I learned my English in class 7. So, but I supported her strongly and against other because lot of obstacle for our own career. I used to spend a different kind of quality time with her as she is my best friend when we talk about poetry and everything. So quality time for each person is different and you have to fulfill your wavelengths and her thoughts, my thoughts should go and we go together. And she wrote first book, this title she gave, We Live in the Newness of Small Difference, is the internationally award-winning book, first debut collection, and the title, I love this title, and I strongly believe that whatever we do, we are not great people, we are very small people. So I do this way or that way, my way of doing thing, all basically we are twisting one point or other. When we go from dissect to demake, it is just a newer thing. We have not done huge thing. That thing was done by one person, that is Millis, not by us. So I believe that we are living in this world. We try to find out something changes. When you see the program of different, try to little bit change and we feel happy. So to me, everyone is different in his own space. It is advised to you that spend quality time with your family for at least 2 hours a day. I used to spend, so I have plenty of time that way. Definition of quality time also changes with time. Today your quality time changes 5 years after. So with time the definition will also change. When more members are added into the family, again the quality definition will change. But my sincere advice, keep time for yourself, at least 1 to 2 hours a day. Absolutely your own time, your own space to speak to yourself. Look back and then forward. Try to analyze yourself at the end of the day, whatever you find. Enjoy your hobby, passion for inner satisfaction. And go as you like without harming the other sentiments. Those are very important terminology. The next question is turning point in your life, is it? So it is to be shared by all panelists. Now, your biggest accomplishment according to you and turning points in your life. So biggest accomplishment to take part to build Disha Eye Hospital, the largest private eye care provider in Eastern India. This time probably many of you know our latest hospital in Kolkata, just beside the convention center. But turning points, there cannot be one turning point. There may be multiple turning points. I always take the life easy in all positive notes. I failed in gynae in my final exam. Actually, that gives me opportunity to sit for AIMS. Our days PG entrance was sit for AIMS PG entrance, because in our days you have to complete 1 year house job in your state, then you have to. I was lagging behind supply, so 3 months lagging, so I was 1.5 years behind my regular batch. So I was trying for, because that was the internship was the criteria, like those days same criteria was there, though separate exam. So that was actually one turning point, because I joined RP Center. I learned a lot. My total learning is from RP Center, from mentors, from the style, from all kind of things. And second turning point is resignation from SRship, that is on after 10 days of just joining for health reason. So, maro to ghar pe aake maro. I said statement tha from my family members. I will come to that point, last slide. So from both families, I am married that time, just newly married. maybe 7 months, and both family member, both side, and they are pressing hard and आ जाओ इधर कुछ होना है तो इधर ही होने दो ठीक है. So my posting in GDOMO as a rural hospital for 5 years, that is also a turning, because I love opportunity to become a family person that time and also learn the microeconomics of the rural Bengal. So every place has a different economics. In terms of money, I am talking about in terms of finance. So microeconomics in a rural Rajasthan, rural Bengal is totally different. So if you know the microeconomics of that particular area, you could plan your practice, or that way our hospital is built on that perspective only. It is very much friendly to the middle class and lower middle class, not for rich. So this kind of thinking process we have gathered from those mixing the people for 5 years. And posting in NRS Medical College as an RMO clinical tutor, that means senior residency, opportunity to do lot of PK independently, because there was an eye bank, nobody was there as a keratoplasty surgeon, so I took, after 6 years, okay, open karo, medical college, so no issue, no supervision, learn by mistake. So I did lot of, in 5 years probably I have done 300 or 400 keratoplasty, only penetrating keratoplasty. So I have developed my skill in NRS. And at that time I wrote 2 books which are popular to you, Essentials and Oral Practical. And also resigned from that is also 1st May 97. These are 2 books. Now the Essential is going for 8th edition. A book is surviving for 28 years. It's good. And both the books is surviving for 28, 29 years. That is actually a very good thing, and it gave me indirect money also. You know that this is tax-free money. 80CQQB. 80CQQB is the code for income tax people. So every time I submit 80CQQB, and this is totally white money, I don't have to pay any income tax, The first book sold over more than 1.5 lakhs. You see that how much I have earned from writing a book. And second book almost 80,000. It is almost 2 lakhs. You can calculate the how much I have earned. This is indirect, this is just, and the love from you, that is a byproduct. Money is a byproduct, but I have probably won the election because of you only. Those who have read my book, they have taken on against me also. I believe that very much. I told Namrata also. A role as a mentor. So next, advise the young to start professional journey, private practice. This is, choose a fellowship program. This is very important, which you like, and if you think you can pursue it later on. So that is very important. You choose a fellowship and then you come back and again go back to cataract, then your whole exercise. I know there are 6 people from LVPI cornea fellow, they are sitting in Kolkata not doing cornea. दादा आपका पास भेज दो, अरे तुम करो हम कॉर्निया देते हैं. नहीं सर, वो इतना हेडेक कैसे लेंगे, हम रिफ्रैक्टिव कर लेंगे, कैटरेक्ट कर ले, बट नॉट डूइंग सीरियस कॉर्निया लाइक ocular surface or keratoplasty, which they have learned after LV Prasad is more time they have spent. So that is the sad part. So many people are doing oculoplasty, they are coming back and doing cataract only. So money is there. So you have to have passion for that subject. The possible pathways, all you know, that more academic, less clinical work, choose an institute, only clinical work, all possible form. There are many opportunities are there to join 2nd or 3rd generation of your own practice. Maharashtra is a typical example of that. Then absolutely independent practice, that is very serious issue. If you start thinking of absolutely independent, then you have to go to semi-urban and little less developed area. I know there are 2 places in West Bengal, anybody go and he is little bit honest and little bit skilled, who will be in 5 years like double, triple, anything can go. I know one guy I have advised far away from Kolkata, 240 kilometers, and he's the only person, he does 6,000 cataract surgery. He's a cataract guy. Nothing wrong, 6,000. Much more than any individual than average cataract surgeon. So choose a place. Now he is planning for a bigger multi-speciality. He is very popular among whole district. So you have to choose. But if you are in a city or like NCR region, then individual practices. You should not think, unless you have a huge monetary support from your family. And also you can think about leadership, think about admin. I know some of the ophthalmologists, they have passed PG from Chandigarh PGI, then MBA, top notch in a pharmaceutical, like CEO or sub-CEO level. That kind you can choose also. There are different pathways. Or pharma, many people has joined pharma company because they give more fixed salary, income, incentives, everything is there. So, but no ophthalmology direct with the patients. So there is a problem in job versus career. A job is just go to work and earn. NRS posting was just a job for me. Every moment you feel obstacle. When you do a job, every moment you are feeling obstacle, and sometimes it is boring. You cannot think of yourself, how you will go forward. You have certain things in your mind when you think, no scope for further growth. Then politics, oiling for next posting, etc., is there. These are truth, nothing but truth. But a career is a journey that includes your job, your experience, learning, training, teaching, and towards your attitude to fulfill your long-term dreams and goals. So long-term is a very, very important word. You are thinking at this age of, say, 35, 38. So you have to think about 20 years horizon, how I like to see myself at that age. It may be at any direction, but it should be clear in your mind. No hopping from here and there, and there. Then you will be nowhere actually. So remember I always advise that remember 2 most important words. Count, number. So always count your number. Surgery, success, failure, complication, anything. That will actually think and rethink for future growth. Then for learning, improvement, innovation, important for personal and also professional growth, and important for an institution also, important for an individual also. So all are important, we always are pivoting around this number game. We play with number game in our Disha hospital. So I say, I am giving you this number, you play with it. Oh, I am giving you the patient. You see 80 patients a day and do 20 surgery a day. That's your job is over. And then it is your own time. So that kind of thinking. And also other favorite things are that better, I said in the better, don't try to be best. Best, that means you are stopped. Try to be better, that means every day you will be better and better and better. Then you must respect to your time, that is very important. Time, then attitude. Attitude is one of the important points. If you take the number of the letter, attitude means 100. So give your 100% towards whatever you think, towards your attitude. And lastly, the long term. As I said, that long term is very, and it is close to my heart. Still, I have disclosed now after so many years. I have never disclosed. I have disclosed in AIOS So I have to share that. So November 87 is a very, very important day for me. January I joined as senior resident. That time I was a pool officer at RP Center in WHO project. I was covered that Jammu Kashmir and Ladakh NPCB, that time the project WHO conducted. And then I come back and I had a problem of vasovagal syncope, and I used to have malignant vasovagal. That means my heart stopped during vasovagal syncope. That's why I didn't took gynecology, or I cannot see blood. So I was in RP Center at that time. Behind our hostel, you know that Dhanantari hostel, and behind there is CTVS. That building was built up, and at that day an apple cut leads to this hole at night. Severe vasovagal. I was pulseless for 1.5 minutes. They took me to emergency. Then I go to Professor, those who are in Delhi, you know that Professor Upendra Kaul. Those days he was very famous, junior faculty. He said that तुमको ophthalmologist तुमको pulse देखना आता नहीं, ऐसा होता नहीं है. होता नहीं है ऐसा, ठीक है, but मेरा right eye तो blind हो गया था for 30 seconds. I that can amaurosis fugax for 30-40 seconds, and it came as described in the book in a reverse order. I say, how can you explain that? कुछ तो हुआ है सर, आप investigate करो. तो ठीक है, आ जाओ, इन्वेस्टिगेट कर लेते. कहता है सो ओपीडी से हम चला गया, इन्वेस्टिगेट करा, 14 दिन निकाल गया हम कैथ लैब से. आफ्टर 14 days I came back from the cath lab. So that is the story, and I was reported as a first case report from India. So malignant vasovagal, and they did CPR on me and fractured my 2 ribs and put a temporary pacemaker immediately on my thighs, and they called my wife from Sitapur, emergency, and those days travel was so difficult. She came, she gave consent, and I underwent permanent pacemaker. When that was, I was 29 years old, just bubbling with my knowledge and skill, everything, so shattered. So this is my heart at present. There are 3 wires in it. You see that one wire is going for 37 years, the first 87 wire. This wire is made of silicon. I read everything. I know many things about pacemaker and wire and everything than other people. For 37 years, it didn't give me any problem, but if you know the problem of wires, at any point it could create an embolus, and any time I could have severe catastrophe. And these 2 wires, that was a, that company vanished. Then new company pacemaker, you see that is the battery going for 3rd battery, 17, and going for 7 years. These 2 wires are actually for 17 years, 2000, already 3 underwent 3 surgeries. But the best part of this, all these things are long term, except battery. These wire I asked Dr. Kaul, last month I went, he said that you are going fine, so nothing will happen, probably nothing will happen. So he said, next operation probably by this time, by 27, you must be ready. I said, I am ready. So I always say that do it under GA, don't do it under LA. So any prick can precipitate. Now it is, protection is there. So this is what I called a long term. When you implant an implant for a cataract in a child, think that child will grow and give service to the nation, to his or her own capability. When do you give, someone is giving hydrophilic IOL in a child, and so what nonsense you are doing, should not do. Ask, you reduce yourself, ask, jomi jama, kuch bhi बेच दो, अभी जो standard है वो दे दो, लगाओ hydrophobic, best standard quality, because it will go for next 35, 40 or even more. So you have to think about that. Whenever, like cat transplant, now DMEC is there. So we know that DMAC is surviving longer, we are feeling much, much better. But PK, it is not going. So sometimes I look back this plate and think about 37 of extra years, and life is beautiful. So this is the very true for any young patient on any discipline. So you must respect this. Thank you very much. So your career is a journey, not a job. Enjoy the climb. Thank you very much. This is my saying whatever I want to say. Any question you can ask.
Thank you so much, sir, for giving so much thought and time to designing each and every answer, so that we get those in-depth answers from you rather than just something that comes to your mind at the spur of the moment. Thank you so much for that.
Thank you.
And in the interest of time, I would like to invite Namrata ma'am. So if we can ask you the questions there itself.
I think YOs are so accomplished, and they are far ahead of us. They know the answers of all the questions that you are asking us, and that's why they have reached this stage anyway.
So, ma'am, the first question is that what was it for you as a young ophthalmologist during your time? What was, during your residency and training, what were things like?
So it was absolutely different, like Dr. Basak sir said. Some of the things I may just share his points, and that was everything. There was no internet, there was no way you could get knowledge, so you had to go to conferences physically everywhere, and it was a challenge to get material, to be able to read, to be able to translate. And of course, like I said, we never got podium so easily and so quickly. We would be making slides for our seniors, with due respect to all the seniors, and we would be making their videos, and we would be carrying them till the conference room, and then waiting for them, and then those were carousels, so actually click, 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 and they were double projection, so we had to ensure, that they are in the synchrony and everything is prim and proper. The only time we did get at that time to present was when our senior professors or seniors were not well. So we did more like a Stepney kind of a job. So if they did not come, they would say, okay, today I'm not coming, you can present. So at that time also we used to feel so happy that, okay, my name was not there in the program, but I just got an opportunity at the podium. So I think YOs have changed it all. And I would like to congratulate you for that, that podium presence or pedestal or podium pedestal is being given to younger ophthalmologists now at a very young age, which is required. And I think speed is the way of life, and that speed has changed this entire thing completely. Regarding publications as well, we would never be first authors, we would never be last authors, we would be somewhere in between. But then of course it was our seniors' idea which we were implementing, and that was it. But now I think again it has changed. The first authors are primarily, the younger ophthalmologists who've done it all, and the senior author now tends to be at the end. So this is, regarding research. Again, that is something that has changed. Fellowship was not the way of life at that time. There were only two ways you wanted to look at. Either you'd become professors, assistant professors, because you're so inspired by them, or you go into practice. That used to be solo. So I think now, again, that has taken a complete change has occurred over there, because now you have so many options where, you can go. Corporate has come in a big way, which is good, because it gives opportunities to everybody. You all don't have to invest all the time, each time, and you can get experience therein and then move out separately, or can be a part of the institute. So again, that has, changed completely. So I think all the changes have been really positive, and I don't think you put the second one as shortcomings of today's YOS life. I think there are none. And YOS also, there was a generation where when you thought of other things, or other hobbies, it was, considered to be a crime. You just had to be focused. You had to pretend to be focused, to be just doing ophthalmology and nothing else. But I think now it's become a trend, and it has become a style that your work-life balance is important. You're giving equal time to your hobbies, or maybe less time to your hobbies, but your focus, you are less focused too focused for your work and focus on your personal front also. And I think that is the way it should be. Like I always say, there's nothing like balance. It is like you have to give your 100% when you're at a professional place and 100% when you're at home. The balance never happens, you know, it can never be simultaneous. It has to be sequential. And I think that is the way of life now.
Thank you so much, ma'am. Just to brief the audience here, that we'd earlier planned this session as a sort of a panel where we are going to ask questions one by one. Like this first question was to first go to each of the panelists. Then we changed the order a little bit, and we had also designed the session in a way that there was supposed to be a family bite section where we would request the honorable speakers who are joining us today to share some quotes, some video, pre-recorded video.
So if you have the video, you can share that.
Yes,
it's a 1 minute video.
Next, the question.
Although it's made in a hurry, and anyway, but you can still.
Ma'am, it's a beautiful thing if you could help
Yeah,
you out in
please
that
go
way.
ahead.
So our question to ma'am's husband was that behind every successful man is a woman, but who is behind this successful lady? And so we wanted to hear what he has to say, and let's hear it from him.
Count करना.
1, 2, start.
Behind every successful
He's always in a
woman
hurry.
is the woman herself and her hard work. It would be humbling to give a credit to her husband, father or brother, but the truth is that every family member of hers is privileged in the sense that a part of credit of her success is coming to them. I being her husband, I truly am privileged that I have been witness to her journey into both as a clinical expert and in the field of research. You see, there's a overt or a subconscious gender bias in society where females are suppressed, they're not given their due. And it is here that I could put in my best to support her and give her her freedom and space where she could pursue her dream for research. You know, the ladies have this multitasking ability gifted from God, and it was here that Namrata too had the instinctive feelings for her daughter, the only daughter, where I felt privileged that I could spend more and more time with my daughter when Namrata was busy pursuing her work at RP Center or in various societies. Joining these societies was a kind of icing on the cake, because when she had accomplished a lot on the field of research and in the clinical domain, she could spare some time to nurture these societies and evolve as a leader, where being a great organizer, she could organize academic feast in these societies, and she tries to do her best with full honesty and dedication. So I'm truly privileged that this credit is coming to me being her husband, but the entire credit of her success lies in her, and I think she is a role model for a lot of working women, especially in the field of ophthalmology, who can emulate her as an example that if you have dedication, devotion, determination, you can achieve a lot in life, and you could be generous enough to give a part of credit to your spouse in their journey. Thank you so much.
Thank you so much, ma'am and sir, both. And I think any of the female audience would, really want to hear this from their family members down the line.
I'm sure all of them will go back and tell their spouses the same.
So, ma'am, if you would like to share your biggest accomplishment according to you in your life.
So I think, like sir said, you can't say it is one. Getting into RP Center was one, especially when I didn't get post-graduation for 1 year, and I actually wrote the RPC exam and got it. Then getting into doing a Commonwealth Fellowship in UK was again a game changer, because that just showed another perspective. And then I think there have been accomplishments in research, publications, etc., etc. But I think even AIO's platform has been an accomplishment in this entire journey. I think many of you here have been a part of my journey, Vanati, Rohit Saxena sitting here, Kaushik Tripathi, Praful, who is a junior colleague, Dr. Basak from remote control has been a part of the journey, who's known me for, quite some time, ever since I've been in ophthalmology. So thank you everybody who's here for being, I'm happy to share my journey with everybody.
Thank you, ma'am.
Ma'am, huge thanks from YOSI because we are all here because of a lot of support from you.
Yes, ma'am.
That is I don't think you should give that much credit to me, I think. But leadership advice for yours, I would say that you've really done it well. From the AIOS YOSI forum to have your first YOSICon. Today, I'm really happy for all of you. And I would like to applaud you, congratulate you for doing this better than us, better than any, I won't say better than AIOS, but better than any other, set of people who've done conference. I'm sure, I hope you continue to do this, evolve, and climb higher and higher in the years to come.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am, for being so candid. And Dr. Vanati, ma'am, over to you, ma'am. So, ma'am, same question. How was it being a young ophthalmologist for you? How is it different now, and shortcomings that you find today?
I think Dr. Namrata almost echoed all my thoughts here. And I was just speaking to her. I was her junior resident on her last day of senior residency and assisted her for her last keratoplasty as a senior resident. So it was like almost we evolved together. But back in our days, there was no YOSI. I think Dr. Basak also said that there was no YOSI. There were no young ophthalmologists. We were just postgraduates, and we were just senior residents all the time, and we were always meant to do the lesser jobs and not the greater jobs. But today, I think our residents, be it both postgraduates or senior residents, are more demanding. We cannot see them as just residents, and I think they've all evolved, and they've all come to seek their position in whatever they are doing or saying or executing here. And that claim to the right to what you are doing was something which did not exist in our days. We had to be submissive all the time. And that's something I think ma'am will agree we still do to a lot of our seniors still. And being women, we are expected to be submissive most of the time. And if a woman is not as submissive, and if a woman evolves into a role of leadership, it is not taken very kindly in the community, even today. But then that is changing, and I'm happy to see that changing. And I'm happy to see that we are afforded more place and time in most of the happenings of today here. And kudos to the YOSI here to have probably made it happen. So that's how it was in our days, and that's how it is in days today.
Ma'am, any shortcomings? Thank you, ma'am. Any shortcomings you feel that, we can improve on? Or
I think in every aspect of life, nothing can be perfect. You look about people who have accomplished, people who are accomplishing, people who are yet to accomplish, or people who do not bother about accomplishing. So these are the categories in life which can happen, and we all would probably fall into one of these here. So everything has a good and a bad to it here. So, and I think it's just learning to convert every negativity or every weakness which you feel in one's life into a positivity and make it your strength. Identify what your weaknesses are, identify and remove the negative aspects, and convert every negativity into positivity into life. And that's how you would probably move on. I do find a lot of the young people here, they are far more accomplished than what we were at our age, because our opportunities were very few. We didn't live in a digital world. We did not have all the fantastic, luxuries of academics, and we had to spend a day. We had to take time out, permission to go out to the National Library to pull out our articles. We didn't have the net to look at our searches, and we had to line up a books, this many pile of books, and give it to the photostat person there and tell him, please give me all the photocopies. And that's when you find your money is not enough to get the photostats here. So we lived from an era of adversity, and today we know what you are all experiencing is absolute luxury in academics. And it's a request that you would probably convert this luxury and make it show. India is the largest populated country today. India has probably one of the highest number of ophthalmologists today. Again, India should be more accomplishing, and that can happen only through the young ophthalmologists. Don't let speed cover your life. You cover speed. Nothing should happen chatpata. Everybody today, I find it in my own family, and all the younger people in my family, they want everything to happen fast, everything happen quickly, everything should be today and not tomorrow. But never happens that way. I think there is no shortcut to success. You will have to walk the path the way you have to walk it if you want to be on the top in the right way you want to be.
Ma'am, you're absolutely right. Patience is a virtue and we all need to learn it more. Also, regarding the point that you said about, women in leadership positions are also supposed to be submissive, it is in a similar format now also. And if I am also saying it, then you would realize that it is that it is there, and its form has changed. Its form has changed, but it is still there.
The struggle exists. You
Yes,
will have to struggle to get
It
there.
exists in very subtle forms, and it will take time for it to, come to that level where we all feel very comfortable about it being actual 50-50. So, moving on to the next question, ma'am. How do you balance your professional time, travel, leadership responsibilities, and personal time with your family?
I think in our days, we never had this work-life balance concept, or even if it existed, it was very subtle and nobody would speak about it. So when you're residents, there is no life. Your work is your life all the time. So we all grew that way. So probably that's one aspect why we sort of became workaholics most of the time, and we are, if we don't have work, we feel that, we are empty-handed all the time. So that's one way of looking at life. Whereas I do find our younger generations are very different. They have clear-cut categories of what they have to do with different times of the day here, but that's good as well here. And so I would say that it's not the quantity of time you give to your family, but it's the quality of the time you have to give here. For me, RP Center has always been my second home, and I spend more time in RP Center than I would spend back at home. I live in Gurgaon, so I've been driving up from Gurgaon to my workplace way back from 2005. So I almost spend 2 hours on the road, or 2 to 3 hours every day on the road. And like Sir said, that 2 to 3 hours is my me time. I do whatever I think, I retrospect, I think what I did right, what I did wrong, what I said wrong, what I could have done differently. I plan my surgeries. I also look at and contemplate how better I could have done my surgeries. So those 2.5 to 3 hours per day is something which I use as my me time. I talk to my mom at that time. I talk to my friends at that time when I'm driving. So that's how you learn to balance your time, because I had to stay in Gurgaon because my husband worked there, and my early days of my daughter's schooling was there. So I sort of put myself behind and put them in front of me. And as women, we always do that all the time. We've done it right from being kids, from being daughters, from being sisters, from being a mother, and from being a wife, and from being a friend. We've always put ourselves behind here, but I do not regret it. And I think that was a strength. And that strength evolves in making you mentally strong. It improves your mental stamina. It also improves your physical stamina. So you have the stamina to keep yourself going for long hours of the day without needing any boost.
Thank you so much, ma'am, for sharing that candid, nugget of your life. Next, we have your biggest accomplishment according to you in your life.
I think the greatest accomplishment was becoming an ophthalmologist. So way back our days, we only had medicine or engineering as career options. So we never looked at anything, though I did get an option of becoming a computer engineer in my day. My batch was the one when computer engineering got introduced. But I still wanted to become a doctor because my dad was my role model. He was also an ophthalmologist who was in the Regional Institute of Ophthalmology in Chennai. So I wanted to step into his shoes, and I became a doctor because of him as a doctor. And today I'm happy to say probably I mentored my daughter, or I appealed more as a mentor to my daughter, who has also become an ophthalmologist, though I wanted her and I pushed her to become a financial person, but she said no. I wanted her to follow my husband, so I said, okay, I have lesser things to do with you, and it won't be my responsibility. But I think that's how we evolve, and that's how probably the younger generation, when they look at us and they do see us, and they probably want to become. So my greatest accomplishment is that I'm sitting here today. I'm being part of all your lives, and you are here wanting to listen to what I'm saying. I think I'm a very, very simple person, and I have evolved all the way, and it is a great honor to me that you are sitting here listening to what I'm saying. That is the greatest accomplishment in my life.
Thank you so much, ma'am. For us, it's also an honor to, be here and have this opportunity to listen to you. If you're saying that young ophthalmologists don't have that opportunity, it's kind of true, because this is a subset of young ophthalmologists who are slightly more privileged than others. That is something that we all need to accept. And there are a lot of young ophthalmologists who are doing work as MOs for several years, then they get selected, and they already have kids, they have responsibilities, they cannot even spend for coming to conferences, they don't even take membership, they don't even take AIOS membership, which is the premier, the society where you should be a member if you're a part of the country, and those people, they are not getting an opportunity to listen to you. We hope that in coming years we are able to reach out to them also and have your words reach them as well. So ma'am, the last question to you is your publication advice for young ophthalmologists.
I think we publish more when we think we want to share what we enjoyed in ophthalmology as seeing a patient or as operating a case, and we want to share what we saw with the rest of the world. So rather than it being a pressure, it should be a pleasure, that you want to do it because you want others to know what you know. And that comes when your knowledge level in academics is good. So you work towards it. That's number one here. And number two, you just can't sit out and start writing. It's something like learning English. It's something like learning any language here. You have to start from your basics. And that's something which I do find, sadly, because of the digital revolution which has come in, that people want everything very fast. And I think you need to do more reading. And as you read more, it sort of subconsciously embeds in your mind as how you have to go about writing. And that's very important here. So spend most time. It's something like akin to doing a journal club here. As you read more, you understand more, and it will make you a better writer, putting your things into publication. And again, it's publish and flourish, because if you want to make your presence felt in academics, that's something which is going to be staying there for posterity. So all the best to you all, and I would really love to see all the young ophthalmologists making India proud in the arena of international academics.
Thank you so much, ma'am. Thank you, sir, Samal Basak sir, Namrata ma'am, and Vanati ma'am, for sharing your personal and, all. So for this candid rendezvous, we are so honored to have you here, and it was such a wonderful time for all young ophthalmologists to listen to you. And with this, we call this session a wrap, and we would hand over the podium to Dr. Karan Bhatia, the YOSI secretary for the inaugural. Thank you. Yeah, we can take a quick group photo before we move on to the next.
Madhu sir.
So, good afternoon, everybody. Thank you to all of you for making YOSICon a big success. And this event wouldn't have been possible without the support of our mentors from the AIOS and from DOS. So at the outset, I would like Dr. Digvijay Singh, our immediate past president, to welcome the president of AIOS, that is Dr. Samar Basak, with a token or memento or plant. Digvijay sir? इधर है sir, इधर है. Thank you, sir. I would request Dr. Devakant Mishra to please welcome Dr. Namrata Sharma ma'am, who is the Chairman Scientific Committee of AIOS. Thank you, ma'am, for being there for us always. I would ask Dr. Sonu Kalia, our president, to please welcome Dr. M. Vanathi, the editor of the Indian Journal of Ophthalmology. I would ask Dr. Sonu Kalia again to please stay back and welcome the president of Delhi Ophthalmological Society, Dr. Rohit Saxena, sir. I would request Dr. Avanish Upadhyay, who is our treasurer of YOSI, to welcome Dr. Jatinder Bhalla, sir, the secretary of Delhi Ophthalmological Society. And I would request Dr. Devakant again to please welcome Dr. Prafulla Maharana, sir, the incoming secretary of Delhi Ophthalmological Society. Devakant. And lastly, I would request Dr. Nilesh Kumar to welcome Dr. Kirti Singh, the incoming treasurer of Delhi Ophthalmological Society. Achha, ma'am isn't here. I would request Dr. Nilesh Kumar to please welcome Mr. Sandeep Saxena, also who is the country director of the Eye Foundation of America. So with these words, I would request our president, Dr. Sonal Kalia, to please address this meeting. This inauguration ceremony is live on the YouTube channel of YOSI, that is YOTube. So please share the link with your friends as well.
A very good afternoon. Namaskar, as in Hindi. Namaskar is the divinity in me salutes the divinity in you. And since it's the Young Ophthalmologist Society of India, it's more apt to begin with Namaskar rather than just with a good afternoon. So I'm starting off the YOSICon 2024 welcome address. If I can get the AV support, please. फुल स्क्रीन कर दीजिए. So I welcome you all to this inauguration ceremony of YOSICon 2024. I wish to extend my deepest gratitude to all the dignitaries who are here and all the audience, because without these audience who are here, the dignitaries and all of us on the podium would not have anything to look forward to. So a huge round of applause for all the people who are here today, taking out time for young ophthalmologists for building the future of ophthalmology in India. So we missed out on welcoming Dr. Kirti Singh ma'am. If I could request Dr. Karan Bhatia, our secretary, to hand over a welcome plant to ma'am. So we wanted to do away with the bouquets and we wanted to bring the greenery of the plant to this particular conference. Thank you so much, ma'am, for joining us. So for me personally, the journey has been YOSICon to YOSICon. In Hindi, con means who. And when 2014, Dr. Tarun started this Young Ophthalmology Society of India, a lot of people used to speak and ask us, what, YOSI? What does YOSI mean? Tomorrow we'll make one MOSI, we'll make middle-aged ophthalmology society, we'll do this, we'll do that. Why do you need a separate society? Why should this be there? Why should that be there? And slowly, in each and every conference, there has been one dedicated session, and thereafter, YOSI Forum was started with the support of Namrata ma'am, Rajesh Sinha sir, and a lot of other people who helped YOSI become what it is in today's form. And today we are proud to have the very first Young Ophthalmology Society of India conference. And what exactly does Young Ophthalmology Society of India actually stand for? The young ophthalmologists in training. I know you are all aware, but I just wanted to revise this because those in residency and those in their training years, be it fellowship, SRship, and those in the first few years of their practice, those who are less than 40 years of age. But who are all those people? There are diverse backgrounds. Many of them are coming from families where people are walking for miles for just, getting water. And many of them are coming from very privileged backgrounds. They're coming from ophthalmology parivars, so-called. And we have to bridge that gap. That is what the aim is for YOSI, to act as a platform. And YOSI has to be the great equalizer, where if there is a panelist who can guide somebody who is coming from a background where maybe even English has been difficult to learn and understand the concepts, when they are practicing presenting a free paper, they can present and move forward. And for me, this teamwork in my tenure has been helped through these presidential working groups, the medico-legal group, the socio-cultural, the journal club, and the recently started IGO YOSI Livewire, surfing the anterior segment, ocular trauma, the late-night retina, and the fellowship help desk. These were few of the endeavors that we started in our tenure, and they have worked pretty hard this entire 2 years, and they have done multitude of webinars, and all those multitude of webinars have been done because of sheer teamwork. And I am grateful to each of the members who have taken out time for attending them and for presenting in them. The YO Times team will be coming forward very soon with their latest issue. And this particular YOSI has been showing its presence at various places. And the AIS YOSI Forum recently saw, last year and this year at YO Pavilion, we changed the format to making it something which was, instead of being didactic totally, we made it more and more space where people could be involved in networking and learning from each other, and more discussion based rather than having, just somebody is listening and somebody is speaking. So it has been a space for growth and learning, for making collaborations. And I welcome you all to YOSICon 2024 at its formal inauguration. And once again, thank you to each one of you for coming and making this program a great success. Thank you so much. I hand over the podium to Dr. Karan Bhatia for, yes, and Karan Bhatia will be taking over the proceedings just after the lamp lighting for inauguration. The lamp lighting, I invite all the dignitaries, starting with Dr. Samar Basak sir, our chief guest, Namrata ma'am, Vanati ma'am, Rohit Saxena sir, Dr. Bhalla sir, Kirti ma'am, Dr. Praful, Mr. Sandeep sir, please come forward for the lamp lighting, along with the Governing Council of YOSI.
Laptop. मुझे वो देना, मेरा पेपर रखा था वहाँ पे लिखा हुआ हाथ से, प्लीज़ डोंट लूज दिस, लग जाएगी नहीं तो। हाँ again at the outset for making YOSICon a big success. Let's give another round of applause for Team YOSI. So this is to brief our members and new members. So this, as Sonal had said, it started off YOSI under the leadership of the founder, Dr. Tarun Arora, and Dr. Vijay Sharma, who couldn't join us today. In January 2014, we are a registered society with the ICO and a member of the All India Ophthalmological Society. We cater exclusively to the needs of ophthalmologists in training or the under the age of 40, and we want to act as a bridge between senior leaders and young ophthalmologists and positively impact the lives
of these young ophthalmologists. So it initially started as a Facebook group. The new team took over in 2018. This was that time team, and then elections took place, and we are going to have our elections again in the end of June, as Dr. Sonal has announced in the yesterday's GBM. This is the current governing council with Dr. Sonal Kalia, the president, Dr. Devvijay Singh as the immediate past president, Dr. Devakant Mishra, the vice president, and the incoming president, Dr. Karan Bhatti, that's myself, I am the secretary, and Dr. Avnish is the treasurer, and Dr. Nilesh Kumar is the joint secretary. We have 20 executive members, and then various presidential groups that Dr. Sonal played a key role, and actually she founded all of these groups. This was last year with the help of AIS. We did the AIS YOSI Forum, which was a very successful event. These are some pictures of the event. We had about 114 participants with 6 international participants as well. This was the Vayu Pavilion. We are very grateful to AIOS for having a Vayu Pavilion at every year since 2018 at the All India Ophthalmological Meeting, especially to Dr. Namrata ma'am, who has made it all possible, and we have had, YOSI has had the opportunity because of ma'am to conduct sessions individually, different sessions for YOS at this area. This was the pictures of the Vayu Pavilion 2024, which was again a grand success. We had some impromptu sessions there, some fun event. This was a fun event which we did called Coffee with Karan, where we made our seniors a little bit awkward and asked them some awkward questions about their personal life. This is yesterday's pictures. The left one is from the hall, and the other one is when the Vayu night started exactly at the same place. These pictures were taken where the dignitaries are sitting. So we are a member society of ICO. We have a Facebook group, an Instagram page, we have a Vayu Times, we have a YouTube channel. All the videos of ours are available on YouTube. We have a flash notes, we have a late night retina program that we've been doing, we have an anterior segment case discussion, we have a YOSI legal cell which handles all the medical legal type of discussions of YOSI. We have a slides where ready-made content is made. These slides are peer reviewed and available for anybody to read from and study from. We have a journal club. We have an ocular emergency team. Now this is a small 2-3 minute videos or short videos or 5-minute videos that are prepared. These are also peer reviewed and they are on our YouTube channel. We have a fellowship help desk for that. A person can email the YOSI secretariat and we guide them about fellowship and training programs. Or we connect them with a senior or a senior YOSI member. We have a job portal that we are working on. We have a residence network which we are planning of expanding even more. We have a social cultural group. So yesterday's big success was, one of the biggest success was the Bio Night, where everybody had a lot of fun, and 12 o'clock we had to make people go. Okay, we have to close the DJ now, and the entire success with so many 21 performances or so was organized by Dr. Nupur Goyal and her team. A big round of applause to Dr. Nupur. This was supported by Entourage Pharmaceuticals, and we had an amazing time. And again, I would request everybody to give another big round of applause to Nupur and her team for making this a really, really fun event. A process of inclusion in YOSI activities is we send a Google form or something like this to all our members, and you have to fill the form. If you don't fill the form, we try to include you, but we don't promise it. But if you fill the form, we try to involve you in all our activities or whatever session that we have planned. So why YOSI? We want you to become a part of the largest young ophthalmologist group of the world. I repeat, the largest young ophthalmologist group of the world. Get access to all the YOSI material that is there, submit and get content, and become eligible for the annual YOSI Young Ophthalmologist Award, which we will be giving out today as well. So you get to network not only with national people, but internationally. Internationally you have options as well, and there's so much more. So we give you opportunities, we give you chance to connect, and we also give you guidance. So come and become a part of Young Ophthalmologist Society of India. Thank you.
So it's a very bittersweet moment for me today. 2014, when the first issue of YO Times came, I had submitted my article of my first phaco surgery, and now when I'm an associate professor, the penultimate of my term, YO Times, will be released today, and I would invite Dr. Nupur to do the honors of bringing the YO Times and the YOSI socio-cultural calendar also for release. So I would invite the dignitaries onto the dais so that they can release the cover page of the next YO Times, which is special issue, which is going to focus only on the oculoplasty training, pertaining to Indian subcontinent. Yeah, sure.
I would request the entire YO Times, the 19th issue, the team, 1920, the current issue to 19th issue, to please come on the dais, the entire editorial team as well. Please. Nupur, please.
Dr. Akshay Nair, Dr. Puneet Jain, Dr. Rituja Thomas, Dr. Ayushi Agarwal. Times 19th issue. So we have the calendar release. So this was, the YOSI Socio-Cultural Group has conducted a lot of webinars. We had a lot of contests, right from Rangoli contest to the World Side Day Creativity contest. So we handpicked those, beautiful artworks by our talented young ophthalmologists, and it was Dr. Sonal Kalia's Dr. Sonal's idea to put it up as a calendar. So you can see the beautiful artwork and the creativity of the young ophthalmologists, and we're so happy to have it as a calendar.
What I want to tell about this calendar is that this is not like LBO, it's not life beyond ophthalmology. All this artwork is related to ophthalmology in some way or the other. So the images of the Rangoli also have to depict the eye. Sandeep? Sandeep?
So presenting to you the YO Times 19th issue. This we have focused on the oculoplastic training and let me quickly give you a glimpse of this issue. So this is an oculoplastic training special issue, and so the cover page is, there is an artwork by a young ophthalmologist. She calls it, we've titled the entire cover page as the beauty of oculoplasty in the hands and the eyes of the beholder. So the centered artwork that you see, the author has styled it the Pandora's box of oculoplasty. So she sees that this Pandora's box consists of various lesions, right from a salmon fish to the tears that are flowing. So that's the Pandora's box of oculoplasty, and the bottom panel are the posterized images of the various oculoplasty surgeries, the eyelid, lacrimal, and the orbit. So that's the cover page, and we're thankful to the entire YOSI Governing Council, the executive team, for giving us the opportunity to have the release of this oculoplasty issue, Wire Times, and the editorial team, Chief Editor Dr. Karan Bhatia. I'm extremely thankful for giving me the opportunity to take in charge of this issue, and the editorial team, Dr. Akshay Nair, Dr. Rituja, Dr. Ayushi, Dr. Puneet, have worked extremely hard on this issue. We were on a very tight deadline, and we've had numerous Zoom calls. The WhatsApp group has been buzzing, and we worked very hard, and I hope. So today we are releasing the cover issue. The whole issue will be uploaded on the website and will be circulated in a couple of days in the coming week. So just a quick issue at the glance. So we have Dr. Sonal Kalia, who's given a president's message to encourage the YOs, and she's pointed out that this is the 10th year of YO Times running. So again, we're extremely honored and privileged to be a part of this 10th issue of the YO Times, 10th year of the YO Times. These are the contents. I'll give a quick glance. So we have the guest editorial by Dr. Ashok Grover sir on the evolution of oculoplastic surgery. Then we have an in-depth interview conducted by Dr. Akshay Nair over Zoom meeting by Dr. Richard Allen, who has shared his nuggets of his oculoplasty journey and what it holds for young ophthalmologists. We have words of wisdoms from different mentors from all across India. Dr. Santosh Unawar has contributed, Dr. Milind Nayak, Dr. Mukesh Sharma sir, on how to become a good surgeon by Dr. Roshmi, Dr. Savri, Dr. Usha Singh ma'am, and we have mapping mentors mind. So all the institute heads, we grill them and what they look out for as a fellowship in the prospective candidates and how fellowship should be taken ahead. We have compiled training opportunities both in India and abroad for oculoplastic. Dr. Akshay Nair has compiled beautifully all the oculoplasty opportunities, long-term fellowship opportunities available in India. Then we have the maximizing training session, wherein the people who have actually gone through training, how you can maximally utilize as a senior resident, as a fellowship, the various educational resources about the FICO exams. And once you are out of training, then what next? You're out in the field. So with that, we have different perspectives. You have a peek into different practice patterns as an oculoplastic surgeon. People have shared their journey, right from freelancing to practice in an institute, in a government setup, in the corporate world, and the government medical college. So we also have a section on upskilling yourselves. You're out of training, how you can keep upgrading yourself through various hands-on courses, and passion-driven practice in niche specialties. There are experts in various fields of lacrimal oncology, aesthetics, socket, orbit, who have shared their nuggets, what it holds for young ophthalmology. We have the extra edge, which is very important for young ophthalmologists from oculoplasty point of view, which are probably never spoken about during residency, about documentation and photography, imaging, ophthalmic pathology, and prosthesis, and back to basics and research. So we also have a beyond section wherein we have an article on work-life balance. We have fun fitters where we ask young ophthalmologists to, create some memes and, just to add a fun content. We have crosswords, we have quizzes. Then the YO Times, we had invited cover page images from all the young ophthalmologists. So the ones did not get selected, we have published them and we have labeled that as Oculo YO art. And I'm sure that was going to be a treat for all your eyes, for all the readers. And this is the back page cover by Dr. Anuradha Iyer. She calls it the making of an eye surgeon. Beautiful back page. And thank you so much. And I would also like to extend, thanks to the Sun Pharma for sponsoring the online and the designing of this issue. Thank you so much.
So thank you, Nupur. Now let's move on to the awards ceremony. At the outset, I would request the President of All India Ophthalmological Society, Dr. Samar Basak sir, and the President of YOSI, that is Dr. Sonal Kalia, to start off with the first segment of awards that we have, the YOSI Mentor Awards. So the first award goes to none other than Dr. Sabyasachi Sengupta sir, who has guided us a lot, who has helped us a lot in a lot of YOSI activities, particularly related to research and publication. So thank you, sir, for being a part of YOSI. The next award goes to Dr. Nilootpanna Devriya, ma'am. So Sunny sir has just come. He has come here for the for a session in the morning, and he's leaving for a flight now. So I would thank you, sir, for sparing that time. Nimat ma'am has come all the way from Assam. She was a very active member of YOSI, has participated so many times in this, and now she created a chapter in Assam, and now she's motivating others to become more part of YOSI activities. Thank you, ma'am. Now the next is on Dr. Neha Goyal. Ma'am isn't here. Ah, there she is. So Dr. Neha ma'am was also there from the inception of YOSI and has really helped us in every possible way, along with Dr. Vinod Agarwal. Whenever we've asked them to come and help us out, they've always been available. And lastly, we have Dr. Akshay Nair, who has just graduated to become a mentor. Okay. Next, Abhi, we will. Yes, sir. So now I would request Dr. Digvijay Singh, sir, to please come here and hand gratitude awards to our seniors, our chief guests, and a guest of honor at this YOSICon. Dr. Samar Basak, sir, you have to come again, sir. Dr. Namrata Sharma, ma'am, please. And I will say this again, this YOSICon would not have been possible without the support of Samar sir and Namrata ma'am. They have really helped us in every possible way. Thank you, ma'am. Dr. Vanatha, ma'am. Thank you, ma'am, for the continuous support. So we recently started the IGR Live Wire, and ma'am is the editor of the Indian Journal of Ophthalmology, and our journal club is working very closely with ma'am for that. Thank you, ma'am. Dr. Vinod Saxena, the president of Delhi Ophthalmological Society. Now, what better can it be? A mentee is standing right there on the stage, and his mentor is giving the award to them. Next, I request Dr. Sonal Kalia to please come and give the award to Dr. Bhalla sir, who is the secretary of Delhi Ophthalmological Society. Sir has always been a part, and very keen and very encouraging towards in our yoga activities, and we've got a lot of space in Delhi because of that as well. Thank you, sir. Prafulla sir. Let me invite to the stage Dr. Prafulla Maharana sir. So sir is the youngest secretary of Delhi Ophthalmological Society. He is still a YOSI member. So that shows the ascendancy that we can get to. We have to get into the state borders now. We have to work our way up and help other young ophthalmologists. Lastly, I will invite Dr. Kirti Singh ma'am to please come on the stage. So ma'am is also really helpful for us. We are doing a lot of things on the background which I cannot reveal, but ma'am was really helpful in those things as well.
Thank you, ma'am. So next set of awards, I would again request Basak sir to please come again. हाँ हाँ सर ये लास्ट है सर ये 2 awards हैं बस. So the YOSI Leader Award, so that goes to our founding president, Dr. Vijay Sharma, who couldn't be here, but somebody else, can you come and please take the award on behalf of sir. So the story of actually YOSI started in RP Center. It was a small meeting, it started from there and it has grown. The first meeting that took was the YES meeting, the YES Eye Surgeons meeting, Young Eye Surgeons meeting. And Dr. Vijay Sharma, Dr. Digvijay sir, all of these guys were a very important part of it. The next awards, the big ones. So we had awards for the Young Ophthalmologist of the Year awards, the big awards. So this award, we could not give 2 awards in 2020. One was for the under 35 category and the other was the less than 40 category. So the less than 40 category Young Ophthalmologist of the Year 2020 goes to Dr. Kaushik Tripathi. Devakant? The next, I will invite Dr. Devakant also onto the stage. The next award for the Young Ophthalmologist of the Year, less than 40, 2020, who is now not less than 40, goes to Dr. Akshay Dahal. So next we have the big one. So we have received about 28 entries for this year's award, but there was one standout guy. Okay, how many publications has he got? More than 100 in the last 2 years?
The limit of Google form was exceeded, so he had to send his CV in email, and we had to like manually screen. That was the amount of work he has done in the last 2 years. It is just 2 years contribution, but it was not filling the Google form limit has exceeded. So that's why he is going to win this award.
And the winner is Dr. Prasanna Venkatesh Ramesh. Our very own Rajnikant. Thank you so much, sir. Thank you, sir. Dr. Devakant, I'll request you to stay on the stage for a while. And I invite Dr. Sonal also to come at the same time. So what we have over here is the president, current president and the incoming president. So these are the next set of awards are the appreciation awards. And that goes to first award, and I would invite Dr. Namrata ma'am to please come on the stage. And the first award goes to Dr. Apurva Ayachit. She has been part of the core team of YOSI since the new guard, now the old guard, took over in 2018. The next award goes to Dr. Dipanshu Agrawal, an executive active member of YOSI. I would request the awardees to come a little bit earlier, you know your names already. Yeah, thank you. Dr. Dipanshu Agrawal. Then we have Dr. Anujit Paul. Followed by Dr. Aditya Sethi. Dr. Rakhi De Cruz. Dr. Madanagopalan Viji. And Dr. Puneet Jain. The next, I would request Dr. Puneet Jain to please come up. I think the next set of awards are the contributor awards. I would request the three of you to please stay on the stage. The first goes to Dr. Aarti Heda. She couldn't make it. Is somebody collecting the award on behalf of Dr. Aarti? Dipanshu, please come up. The next is Dr. Nupur Goyal, followed by Dr. Zain Khatib, Dr. Kaushik Tripathi, Dr. Prasanna V. Ramesh, so another award for this guy, and Dr. Sahiban Sethi. Big round of applause, guys. Why are you so silent? These are the people who have worked for YOSI, who have made this conference possible. Late night meetings. So many awards are getting confused which one to pick up, huh? So thank you, man. Thank you, Dr. Devagaran and Dr. Sonal. So for the next set of awards, I would request Mr. Sandeep Saxena, the Country Director of Eye Foundation of America, to please come up on the stage. And at the same time, I would request Dr. Avanish Upadhyay to please come up. So we had a meeting in Rajamundry on anybody can research and innovate. So it was a session where we had free paper sessions, talks on how to do research, and then on innovation as well. It was a very successful meeting with Dr. Raju, who planned the whole event at Gautami Eye Institute. And so we had different prizes, again sponsored by Eye Foundation of America. The third prize goes to Dr. Anjali Maheshwari, who received a cash prize of about 10,000 rupees. The second prize went to Dr. Kavya Chandran, a cash prize of about 20,000 rupees. And the first prize went to Dr. Devansh Virdi for winning the free paper session there. And this, he received the Rotary Club Travel Host Project, which I was the recipient in 2022. So this includes a to and fro travel to the United States of America, including attending the American Academy of Ophthalmology meeting, stay at the AO site, or hotel at the city of AO, along with observership and mentorship in the United States of America under Dr. Raju. It's a huge award, and very grateful to EFO, Eye Foundation of America, for collaborating with YOSI for this award. A big round of applause for this guy. I would request Mr. Sandeep to just say a few words on what EFO is doing to eradicate blindness.
I want to thank YOSI for this opportunity of me joining here on behalf of the Eye Foundation of America and the Gautami Eye Institute. And I congratulate all of you for this wonderful show. I'm very pleased to see this. And on behalf of the Eye Foundation of America and the Gautami, we will promise all support extended to the young ophthalmologists. Also, I'm a trustee on one of the newspapers which is published in the US, UK, Middle East. We will support YOSI's activities being covered in the newspaper as well. Also, in addition to this, what we are trying to do, we don't have a footprint in the North India, so Gautami Eye Institute and the Eye Foundation are looking forward to setting up a footprint here along with the Rotary International, the District 3011. I'm the president this year for the Rotary Club, which is going to do this work. And I request all of you to support us in this. The first on priority for us is setting up a ROP center in Delhi, the retinopathy of prematurity, which is very close to the heart of Dr. V.K. Raju. We are looking at setting up the center and announcing the opening of it in this year itself, on the 1st of July. I think I'll stop here. Thank you so much. Congratulations to all of you again.
Thank you, Mr. Sandeep. So let's move on to the next set of awards. I would request Vanati ma'am to please come on stage for these. So what better to give the awards than the editor of the journal? So we have the AIS Yosi Forum Free Paper Winners Awards. The third prize goes to Dr. Priyadarshini K. Nilesh Kumar, I would request you to please come on stage for this. The second prize goes to Dr. Anand Nayak. Can somebody come and collect the awards on their behalf if they aren't here? And the first prize goes to Dr. Ayush Mazumdar. Ayush Mazumdar. Okay. Moving on to the next set of awards. We have for the Young Ophthalmologist Retina Case Competition at the YOSI Yosi Forum 2023, which goes, third prize goes to Dr. Manisha Apte. I only have to, okay, you give it. The second prize goes to Dr. Aditi K. Murthy. Dr. Aditi K. Murthy. And the first prize goes to Dr. Dipanshu Agrawal. Dipanshu Agrawal for the first prize winner. यही दे दो आ गया ये रहा आ गया. Then we have the winner of the anterior segment surgical video competition, which goes at the AIS Yosi Forum 2023, which goes to Dr. Nikunj Tank. And the last award was the Surfing the Anterior Segment Case Competition at AIS Yosi Forum to Dr. Karthikeyan Mahalingam. Can somebody from RP Center come and collect the award? Karthikeyan. Karthikeyan. Okay. We move on to the next.
I would now like to invite the Yo Pearl awardees. Ma'am, please stay. Acha. So the International Joke Day, which was held on 1st July 2023, the first prize went to Dr. Bhavya Gokani. Thank you so much, ma'am and Dr. Nilesh. May I now request Dr. Rohit Saxena, sir, to please come on stage, and Dr. Karan Bhatia to please accompany him. The next YOSI International Joke Day Award went to Dr. Vineet Mutha. Second prize. Third prize went to Dr. Deepak Bhojwani, if he's there in the audience. Audience Choice Award went again to Dr. Bhavya Gokani. Winners of the YOSI ICI Everywhere Photography contest are next. First prize went to Dr. Nishi Prasad. Yeah, she's coming. Second prize went to Dr. John Davis and Dr. Saurabh Deshmukh. Third prize went to Dr. Megha G. The Judges Special Appreciation Award went to Dr. Prasanna V. Ramesh, who I think is now going to be booking a special extra luggage in his flight back. Winner of YOSI Word Side Day Creativity Contest. First prize went to Dr. Kshitij Raizada. Thank you so much, sir and Karan. I would now request Dr. Bhalla sir to please come on the dais along with Dr. Nilesh. Dr. Nilesh, please come on the dais. The second prize for YOSI Word Side Day Creativity Contest, which was held on 10th of October, goes to Dr. Ketki Tushar Bhatt. Third prize went to Dr. Aishwarya Sasi. Aishwarya. Next, I would request the winners of the Young Retina Case Competition at YO Pavilion, Kochi, to be here, please. The first prize went to Dr. Anjana S. Second prize, Dr. Aishwarya Sasi, please come on the stage. First name is Dr. Anjana, second is Dr. Aishwarya Sasi again. Third prize went to Dr. Nikita Gupta and Dr. Chinmay Mahatme. Thank you so much, sir. Next, I would like to invite Dr. Prafulla along with Dr. Avnish. The winner of the 6-minute video competition, which was held at YO Pavilion, AIOC, Kochi, is Dr. Saiban Sethi. Congratulations for the second prize of the day. Next are the winners of the Surfing the Interior segment at YO Pavilion, Kochi 2023. First prize went to Dr. Saloni Joshi. Saloni Joshi. Second prize went to Dr. Ajinkya Deshmukh. Third prize went to Dr. Subhav Parshad. So next are the winners of the YOSI Journal Club Award. The first prize went to Dr. Bharat Mittal. Dr. Lipi Mittal got the second prize. Okay, Dr. Bhavya is collecting on her behalf. So next are the winners of the Glauco Bio Reels at YOSI Glaucoma Week contest. The first prize went to Dr. Khushbu Shah. Second prize went to Dr. Sharika Menon. Please. Winner of the Glaucoma Awareness Through Art at the YOSI Glaucoma Week contest is Dr. Kavya Priya. Is Dr. Kavya Priya here? Thank you so much, Dr. Praful and Dr. Avnish. Next, I would like to invite on stage Dr. Kirti Singh ma'am. Dr. Karan Bhatia, if you can please accompany ma'am. So we had a AIOS YOSI writing competition. This time it was held live. The topic was given on the spot, and our judges were Dr. Vetheswaran LG from New York, Dr. Shikha Gupta ma'am from RP Center, and Dr. Digvijay Singh sir. Please, if you can hand over the plaque to sir. Thank you so much, sir. So if you will collect for Dr. Shikha as well. वैथिस्वरन का भी दे दूं. Is Dr. Chandra Devi here? So winners of the AIOS YOSI writing competition 2024, the first prize went to Dr. Sai Tejasvi, and I suppose Dr. Prasanna is going to be collecting her award. So these awards were for ophthalmology, for furthering ophthalmology, and they were sponsored by Dr. Nirmal Frederick, Dr. Sai Tejasvi. Second prize went to Dr. Ayush Majumdar. Third prize went to Dr. Apurva Ayachit. Welcome Apurva, welcome Kaushiki on the stage once again. Consolation prizes went to Dr. Bhavya Gokani and Dr. Moshmi Banerjee. Moshmi Banerjee, Bhavya Gokani and Moshmi Banerjee. She's not there.
So I would now request all the dignitaries to please come on the stage for one final set of awards. These are the International Appreciation Awards to our international guests. I would welcome Dr. Tetsum Singh Mahla to please come up, followed by Dr. Tetsum Singh Mahla is from Nepal. He is the current treasurer of the Nepal Ophthalmological Society and also an important part of the YO team of Nepal. I will invite the YOSI Governing Council to also be on stage for this. Next, I would also invite Dr. Chris Zana Akluba Aroa. She is from the Philippines. Next is Dr. Chris. followed by Dr. Neeti from Thailand. Dr. Neeti R from Thailand. Next we have Dr. Saminda from Sri Lanka. Followed by Dr. Azam from the Maldives. Saminda, come. Azam. Dr. Saminda is from Sri Lanka. So Dr. Azam is from the Maldives. Pleasure to have you here. He is one of the very few ophthalmologists in Maldives. He is a vitreoretinal surgeon who is also doing cataract surgeries there. Yes, he organized the SAO conference that took place in the Maldives as well. Thank you. Sonal.
So now I want to call upon stage some very special awardees, those who have worked hard for making YOSICon a grand success. The LOC chairman, Dr. Digvijay sir, is already here, and I would request Samar Basak sir to please hand him over a token of gratitude from my side.
मैं बाद में बताऊंगा। ठीक है, जिनके पास टोकन है वो स्टार्ट कर ले, बाकी मैं बताऊंगा, बाद में बताऊंगा। So I'd just say from the last award session, the Dr. Ashraful Haq was also supposed to join us. He couldn't join us because he couldn't get visa from Bangladesh. So his visa will come maybe in 2 days. He had applied 1.5 months back though.
The organizing secretary, Dr. Karan Bhatia.
Oh, okay.
Dona, Sandeep. Organizing Joint Secretary Dr. Nilesh.
अवार्ड आइडेंटिफाई करना पड़ रहा है वहाँ पे।
ये सब हो गया ना? इसके बाद ट्रेड।
Vice President YOSI, Dr. Divakant Mishra. So basically this was my ploy to have one person less on the stage perhaps to give them President's Appreciation Award. Treasurer Dr. Avnish Upadhyay, without whose signatures none of these plaques could have been ordered. Last but not the least, the ophthalmic wars was held yesterday.
And the winning team was the INC. That it was a political theme, completely political theme with the current collections in this. So the innovative neutralizers of cataract, INC. They won this.
So the team names were the best Zazzers of pseudo exfoliation, that is BJP, Then there were innovative neutralizers of cataract who won it. It was INC. And then there were Descemet's membrane knights, that is DMK. And then there was active against panophthalmitis, that is AAP.
Aditya Sethi, Vaibhav Sethi, Saida Sethi, and Baba Zakani.
Total INC team.
So we can have the, we also have a lucky draw which everybody did. So what we did this time is we had in all the registrations, we had a page, and all these pages what was there, the trade pictures were there. For all the stars that we have, 21 stars that we have, and out of this, you have to visit each of the stalls to get a stamp from each of the stalls. And then when you get those stamps, you have to submit this for lucky draw. So now the lucky draw winners. So we are getting what, third prize? Third prize first. First third prize is, give me a mic please. Third prize is headphones. ये ना पांच है. Third. ये second है, ये So the fourth prize is a nice smartwatch. So they are ma'am, they are participants. So the children can, no, they can do that. So let's take out, ma'am, please. Take out one each. We need 4. एक और. So fourth prize is a noise smartwatch. Namrata ma'am, who is the winner, please?
So the winner is related to the person who is just next to me, Dr. Arshi Singh.
मैडम आपको ही लेना पड़ेगा.
The third prize, Dr. Kirti ma'am,
is Dr. Alok Singh.
If the person isn't here, it will move on to the next one.
Yes, it should.
Another one. He's not here, so
Next one? Okay. Dr. Aman Khanna.
Dr. Arshi is here. So the first prize is a Redmi Note 5G, and Dr. Savar Prasad sir is going to announce the winner.
Dr. Ritika Gaur. Dr. Ritika Gaur. Kushdeep Abhaipal.
देखो उन्होंने काम तो पूरा कर लिया, ट्रीट तो कर लिया.
Akanksha Gupta. Dr. Akanksha Gupta. Yay! Because she is the luckiest one.
Dr. Kavya Chandran. Kavya Chandran, yeah.
So, please, any? So, at the outset, sir, one last set, please. We would like to thank our sponsors for this wonderful event, and our platinum sponsor, Cipla. Cipla, can anybody from Cipla come and take this set of awards? Followed by our gold sponsors, Entod Pharmaceuticals and Rayner. Followed by a silver sponsor, Hoya. Mr. Anuj, थोड़ा जल्दी. Followed by our bronze sponsors, Johnson & Johnson, Care Group, Zeiss, Carl Zeiss India, Care Group. Anybody from Johnson & Johnson here? Zeiss, Carl Zeiss. So Carl Zeiss India. So Carl Zeiss took care of the wet lab as well, which was in the basement that is in front of Casarina Hall. Ajanta Pharma and Intas. Intas. At the outset, thank you for these sponsors. Along with this, I would also thank Centaur Group, Mankind, AbbVie, Ipca, Zydus, Sun Pharma, Neomedics, Ben Franklin, Jaggi Brothers, Remedio, Microvision and Lupin for their continuous support. Thank you very much. I would request the dignitaries to please take the dais.
Thank you so much, sir. Thank you so much.
And Dr. Nilesh to please give the vote of thanks. The lunch is being served for everybody in this store only. So the lunch is on. Everybody can go for lunch.
So, yeah. So,
after the vote of thanks.
So, I would like to thank the AIS dignitaries. Yosi is that bacha of the family who wants to grow up very fast. And thank you for being the parents who indulge into all the activities and always support us to make us grow without any hiccup. So I would like to thank our AIS President Dr. Samar Basak sir, the Chairman Scientific Committee AIS Dr. Namrata Sharma ma'am, Editor IGO Dr. M. Vanati ma'am, the President of DOS Dr. Rohit Saxena sir, Secretary of DOS Dr. J.S. Bhalla sir, and the upcoming Secretary of DOS Prafulla Maharana sir, along with Mr. Sanjeev, to come all the way and help us to inaugurate. So apart from this, I would like to also congratulate all the award winners and thank you for being here to collect the awards, my seniors, my friends, my colleagues, and to all the international faculty. Dr. Teshu, Dr. Saminda, Dr. Mohammad Azam, Dr. Krish, and Dr. Niti, everybody, thank you for being here. I also like to thank Dr. Kriti ma'am for being here, and she is also a very strong support. She helped us all the way along. And I would also like to thank the Governing Council, the Executive, the Organizing Committee for this event. And big thanks to the India Habitat Center, the Grover Audiovisual Aids, Mr. Varun, and his team for all the ushering they are providing, and Trade for all their support. I would like to invite everybody for the lunch. Thank you so much.
So thank you so much. Lunch is served, and along with this, we get back to the practice management session. We are on time. We are only about 15 minutes late from schedule. So 2 p.m. we have the practice management session here. In the Gulmohar Hall, we have the refractive session, and the free paper 3 session is going to happen in Kasarina Hall from 2 p.m. onwards. Okay, my laptop, my bag, मैं अपना अपना उठा लूँ। करंट भाटे करके कुछ रखा था यहाँ पे, मैंने ऐसे रख दिया। लेता हूँ, ये रख दे। मैंने यही निकाल के रखा था, एक करंट भाटिया करके कुछ था लास्ट वाला। नहीं नहीं, इस तरह ये अलग है, ये अलग है। इनको अलग अलग करनी है, इनके नाम के हिसाब से इसे डब्बे में डाल के मुझे देना है। ठीक है? ये
सर कह रहे करण भाटिया करके
क्लियर हो गया। इसके नीचे तो नहीं है। मैं अपना लैपटॉप बैग उठाऊँ, लैपटॉप लैपटॉप देना मेरा। उठा दूँगी, ये जगह काम ऐसा ही है, ऐसा है। स्टेज पे देखो ना ऊपर।
इधर देखो। सर यहाँ पे नहीं है।
इधर कहीं पड़ा होगा, देख लेंगे। अभी लास्ट में है, सबसे लास्ट वाला वो। ये देखो यहाँ पे पड़ा था, वो समय बाद दिखाया था मैंने। सर कहाँ पे हो? आपने अपना मोमेंटा उठा लिया? अच्छा आपका आपका यहाँ पे मेरा और आपके पास है ना?
जाके पूछ के लंच कर लो ना, फिर स्टार्ट हो जाएगा। किसी भी करती है भाई बोल दिया क्या आ रहे हैं कौन?
अरे यार ये चेयर टेबल लगाने हैं ना। अच्छा
अरे उधर जाओ ना, इधर लास्ट में जाओ। हाँ वहीं ले आता है।
संदीप बोल के आइए यार। अभी करो ना, स्टार्ट होने वाला है। वो आ रहे, मैंने बोल दिया।
इन पौधों को क्या करना है?
उनके बैग भी तो नहीं है, इसके ऊपर रखते हैं। नहीं कोई नहीं, एक और उधर रख दे। अरे वो ना उसके अंदर रख देते हैं। तुम अकेले उठा दो।
उठ जाएगा कोई बात नहीं।
Let's start the afternoon session now. This is a session on practice management. Come, Akshay. So I have with me Dr. Tushar, Akshay, Kapoor, and Tisha is not coming. ठीक है. And Puneet Jain on the dais. Is Devakant here? Devakant. Okay. Quick, give him a call. Let's start. So we have Dr. Neelam Katwani for the first talk on practice management. Come. So this is on practice aspirations of a young ophthalmologist.
Good afternoon, everyone. So, I am going to share my views on practice aspirations of a young ophthalmologist. According to me, a budding ophthalmologist initially should concentrate in the PG degree acquisition, whether it is MS, DNB or DO, and then go for the skill development and further proceed for the super specialty fellowship, which is the growing trend these days. Because of the rapid growth in the medical education and opening of many new institutes and new medical colleges, there is disparity and lack of standardization in the clinical and surgical exposure in the residency programs, in the residency programs. So, few residents might get adequate clinical and surgical exposure in their residency, but many of them have to give certain years after acquiring the degree for the skill development and further go for the super specialty fellowship to start their own practice. Now, before starting the practice, one should ask certain questions to oneself. Like, where are you going to settle? This is important because whether you are going to settle in a small town or in a two-tier city or in a metropolitan city, your practice will vary depending on the place where you are going to settle. And also you have to identify your personality type, whether you are a go-getter kind of personality, a risk-taker kind of personality, so you would be more suited for a private practice, or you want a little less tension and you are a happy-go-lucky person, so institutional or academic practice would be more suitable for you. Even your familial and financial background also plays a role, and you have to identify and know the difference between the academic and private practice and choose accordingly. So the employment status options for us are whether you want to be an employee for someone and do a fixed job, or you want to be self-employed and open your own basic setup, or you want to be an entrepreneur and open certain corporate chains of ophthalmological setup, or you want to be an investor and hire ophthalmologists to work for you. So you have to decide all these things. So coming to academic versus private practice, so many people have spent their entire career in academic institutes, and they like the departmental collaboration, the research and teaching. There is stability, there is job security, they have fixed working hours, fixed remuneration, but the growth is hierarchical. And compared to the private practice, it involves a lot of management and there's scope of business development. Good communication skills are required for it. Your attitude towards your center and the patient matters, and it involves a little risk taking also. So you have to identify these both areas of practice and choose for yourself. Then the real game begins when you finish your residency or fellowship and come into the actual private practice. The actual private practice is very much different from the residency. You actually learn a lot more in the actual practice than your residency training. Residency training is just a foundation building block. Nobody learns everything in the residency. Gradually in the practice, you get to learn so many things. So this transition phase from the fellowship or residency to the actual practice is actually very vulnerable phase where you intend to do many mistakes and you learn from it, and then you have to get up from those downfalls and start in a new way and get going. So anticipation, planning, analyzation and implementation is very important. Surgical skills, nobody learns surgical skills in the complete surgical skills in the residency or the fellowship. It is a continuous learning process which we develop through the time and through our age, and it requires courage and perseverance. So if you are planning to setting up your own setup or planning your infrastructure, so that time you have to decide your location, the area of your establishment, whether you whether you have to rent the place or you can own the place, and accordingly you have to decide the budget. Whether the budget allotment should be budget for the infrastructure and how much you have to allot for the equipment. So you have to plan accordingly, and you have to decide what all things are very much essential for you, and they are must-haves for you, and certain things which are optional, that is you should have, or certain things which you can have according to your budget. So for a general ophthalmological OPD setup, these are certain must-haves for OPD, like basic AR machine, tonometry, optometry setup, the trial set and the frames, the chair unit setup, the slit lamp, and indirect ophthalmoscopy with fundus lenses. So the entire cost of the basic OPD setup is around 20 to 25 lakhs in a two-tier city. And must-haves for the OT setup are an autoclave machine, a biometer, a good quality microscope, surgical recording system, a good phaco machine, a YAG laser. So this is the approximate cost for a basic OT setup. And can-haves in OPD are like your EMR or OCT angiography machine or a wide field fundus camera or a perimeter B scan. These are not necessary, but you can have these if your budget permits. So it also varies according to the speciality you have you want to practice. This is just for the general ophthalmological practice. And the core requirements is the foundation should be solid, and the technical expertise should be there. You should have good communication skills. Social skills are important. Financial planning should be there. And if an advisor is there, then it is like cherry on the top. So it's never too early to start planning, and it's never too late to start something new if you haven't started planning yet. It's like we are never going to give ourselves an examination date. We have to search our own opportunity, perform accordingly, and be the examiner by ourselves and judge our own work which we have done. So that's the way to go through. Thank you.
So excellent points, Dr. Neelam. You covered a lot of things in such a short presentation. One thing I would just like to add is, of course, the investment that you need to set up a center, but you also need to take into account that you'll be burning money for quite some time. It takes about 3 years at least, or maybe more, to break even. So you need that working capital also and the money to break even. And like you said, there's no one way of doing it. Everybody's personality is different. Often you get into something and then you realize maybe it's not for you, and that's how you figure it out. So it's a process that you have.
Yes, sir.
Any questions or any comments from the audience? So I think, and of course, though I suppose it's always a dream for everyone to have their own practice and to, that's kind of the ultimate thing that we look for when we're getting into medical science. It's the one advantage that we have over a lot of other professions that are there. But as you rightly pointed out, so there is the aspect of being in a public health practice or a private practice, and both of them are quite different. So thank you for your
Thank you,
points.
sir.
So next, I'd like to introduce the keynote speaker. Dr. Nilesh will be talking about Quattro Pump, the new kid in phacoemulsification. The new big daddy in phacoemulsification.
Okay, sir. So this is a keynote address that is sponsored by Zeiss. So I'm Dr. Nilesh Kumar, and why I'm giving this talk is we are the first private center in the entire country to have the entire cataract workflow, starting from IL Master to Callisto to Lumira microscope and a Zeiss Quattro 700. That was the first commercial installation that happened. And this is the machine that it works. It's the Zeiss patented Quattro pump. It's the Zeiss patented Quattro pump that has synchronized fluid exchange. So what it does is it has 4 infusion pumps and 4 pumps. So 2 are for the inflow and 2 are for aspiration. So it's not like a gravity driven or a forced infusion. It's a pump driven syringe like infusion. And what it happens is when a plunger is going in, a synchronized action is happening and the plunger is coming out, as you can see in this animation. So this way, it is in real time, it is measuring the amount of fluid that is going into your eye and coming out of your eye. So if any leak is happening, immediately it is getting compensated. So there is virtually no surge. The surge amount is very, very, very less. So any incisional leakage is automatically compensated. We'll see in the video that is accompanying. And you can see this is a goat's eye video that happened into the preclinical trials. You can see the amount of they are making incisional, they are making incisions that are deliberate, increasing the number of keratotomies, and you can see the amount of leak that is happening, but you see the iris is not fluttering at all. I'll just play the video again. So one side port, there's little amount of fluid that is leaking, then second side port, then there is third side port, and you can see there is so much amount of fluid that is leaking, but the entire AC is completely stable. And this is replicated in human eyes as well. So this is my experience. I had to implant a 3-piece IOL in this case because there was a leak, a rent that had happened, and I was doing an IOL scaffold using a multi-piece, and you can see the iris is prolapsing. There is such a big incision, but the entire nucleus is getting aspirated within 20-25 seconds. So that is the amount of stability that it gives. So comparing the different systems, you can see it's a study done by Dr. Sri Ganesh. He used Signature Pro Centurion and the Quattro 700 that uses the Quattro flow, and you can see the aspiration flow rate is 90. I operate on around 80 right now. The vacuum we can go is up to 700, 750. The phaco power is as much as we want to keep. For grade 2 to 4 also almost similar setting. There's hardly till brown cataract I use the same setting that I use for my soft cataract. So there is virtually no difference. I don't have to switch setting for each grade of cataract, and for myopia or for pseudo exfoliation, it has taken away that headache from me to choose the setting. So you can see there was in his study there was significant reduction in the fluid turnover, very minimal amount of fluid, only 36 ml to 40 ml of fluid was being used in each case. Chamber stability score was actually very less, but I'm actually not sure how it was calculated because that calculation has not been given in the study. The total ultrasound time reduced significantly to 25 seconds. That effective phaco time also reduced to around 10 seconds, and total surgical time reduced. So total surgical time, I myself can vouch. I was a surgeon who just started phacoemulsification when I bought this machine, and I was operating for around 15 to 20 minutes, and with this machine now I am operating for, my cases are getting finished in around 7 minutes, and if it is a hard cataract, 8 to 9 minutes. My fluid turnover is around 32. This is an ultrasound time of total time of 18 and an EPT of 8.7. These all are a mean value. The standard deviation I couldn't calculate because of this conference. And this is a real comparison that he has done. You can see a similar grade of cataract. Dr. Sri Ganesh is operating in 3 machines. You can see Quattro on the left hand side, and right hand side top is Signature Pro, and you can see the down one on the left side is the right side is the Centurion. And you can see now how fast the phacoemulsification will happen in Quattro after the primary chop, and the entire nucleus is almost gone, while in Signature Pro we are still chopping, and there is last piece remaining in Centurion. So that's how fast the machine is, and it's not kidding. So you can, I'll just share my video and finish this talk, and you can see in the overlay how what is the parameter that I am operating around. This is a grade 4 plus cataract. The entire surgery took 2.5 minutes for nucleus management, and this has been fast forward 2.5 times, so it's a 1 minute video. So around a vacuum of 700 to do the chopping, and then you just start aspirating. In the quad mode, vacuum of around 60-65 I keep for this. And the entire surgery time, the total phaco time that is given is around 24 seconds. In 24 seconds, a grade 4 plus cataract has been eaten up completely. So this is how beautiful the machine is. You can see IOL scaffold. That is my routine practice for all the hard cataracts and where there is no cortical support. I do IOL scaffolding and then take out the last piece. So thank you for this opportunity.
That's like, kind of learning driving on a Mercedes, S-Class or something. So these machines are right up there. So do you think it's something that, is there going to be a difficulty if you're getting used to this kind of, a perfect fluidics, and then shifting on to any other machine in the future, or do you think that this is a good way to start and build up?
For a beginner surgeon, I think they have to understand the fluidics, so better to start on a lower end machine and then to learn the fluidics and then go on to graduate to these machines, because I myself, my Signature Pro is there lying in my OT, and I reluctantly use it whenever like there is one case, and because the cassette cost is very high, so I don't open it for one patient. So then in that case I use the Signature Pro, and I just feel the difference that I am like waiting for the pieces to come, and in this I have to like stop, and too far the pieces are coming too fast.
Yeah, absolutely.
So that
amazing.
It's like Mercedes is probably not the right car to start learning from.
Yeah.
And it was really nice to see the extremely stable chambers. I was wondering what the tip is like that you use for the cutting. Is it?
It's 2.2. So the beauty of this tip is the sleeve is 2.2. So the internal bore diameter is 2 mm, and then there is a flare at the tip, so it becomes 2.2. So the sleeve and the tip size is same. So you have 2.2 incision.
And you primarily use torsional or rotational phaco, or is it?
It doesn't have a torsional component. It's only longitudinal.
Great. Okay. Excellent presentation. It was really nice to see how stable the chamber was in all your cases.
So next, may I invite Dr. Aditi? She'll be talking about creating your identity in a group practice.
A very good afternoon. Thank you, Team YOSI, for this opportunity. Of course, it's a post-lunch session, so I'll try to keep it short. No, I'll try. So I'll be speaking on creating your own identity in a group practice. I'm Dr. Aiti Gozasidar, and I practice as a cornea and ocular surface consultant in New Delhi, Synergy Eye Care, as well as visiting consultant in Kolkata, Netralayam and Trinetralayam. So group practice. Apart from the, the safety net of an institutional practice or to be very bold and go for an independent practice, many of us opt initially in our initial days of struggle or trying to make our own place for group practice. So now what are the advantages? We do get a security of more experienced seniors there. Financial benefits are there if you don't want to go all in with your financial commitment. And there are multi-speciality services if you want to take multiple opinions. So the advantages, we are stronger together. We have an opportunity to have multi-speciality opinion regarding it. We do have the umbrella similar to an institution, a safety net, and a support system. But there are a few challenges as well. So the challenges can be internal or external. So internal, sometimes there are more than one doctors or practitioners taking the same specialty. So human nature, we can become a little bit complacent. And challenges, as a team, we represent each other. So a team is as strong as the weakest member. So now how to go in for group practice and try to build your identity. First of all, you should know yourself and know what your profession demands, whether you are good able or whether you can be able to do that. First of all, the prerequisite is you should have adequate knowledge, you should be well trained, you should know your skill, you should have ample exposure. There's something called the theory and then practical and then your own practice. So you should be confident enough to practice. It is something that your degrees are not going to take the patient to the OT and not going to give you a successful result. You should know to operate it very independently on your own once you are going for a independent practice or even in a group practice. Work on yourself. You should be you should know your core values, the commitment towards quality of care, compassion, care, competence, communication, and the courage to step outside in the world. So what if you're very talented and you have stepped out in a group practice? What if the others don't refer the patients to you? Talented yet hidden. Your work does speak for yourself, but then you have to open channels of communication. So effective communication among the members of your practice. Teamwork requires communicating. They should know what you have planned for the patient. They should know whether you are updated. If you are sending a referral, it should be very crisp and clear what you want from the other person. So you have to be up to date with the current management, follow the rules of referral, and do not poach patients. Do not badmouth your colleagues. Follow the code. And of course, podium presents publications, your skill upgradation, these are all going to be like building blocks for creating your own identity. Now coming to expanding your patient pool, you should be very well informed, especially in this Google generation and digital generation. You should be very accessible when the patient wants a multiple second opinion. Never say no. Be confident about your own skill and knowledge. Be crisp, confident. Do not promise the patient. Under promise but over deliver. Be very medico-legally secured in today's days. Be open to multi-speciality approach, and of course public relations, they can be organic or payment based, depends on the practitioner. And now in the digital age, Vasudeva Kutumbakam, the whole earth is our own family, so we have access to digital media and we can promote ourselves on our own as well. And we have beautiful, institutional, as well as we have YOSI Forum AIOS, which gives us that platform, to communicate with our fellow practitioners, tell them about our work nationally as well as internationally. So to create your identity in a nutshell, patient safety and professional responsibility. That should be very important. Then, of course, in that circle should come your knowledge acquisition, your skill development, efficacy and efficiency. Be sure, quality assurance, continual improvement of yourself, your skill, adaptability to various private practices, ethical practice is going to take you on a long run, building contacts, expanding your horizon, adding more skills, adding more feathers to your hat, professional growth. But then patient safety and professional responsibility should be the key. I've been lucky enough to be part of group practices and able to do a little bit of my part as an ocular surface and cornea practitioner. I'm really thankful to Team Synergy, Netralayam and Trinatralayam. And last but not the least, the work-life balance should not suffer in the struggle or the rat race of making your own identity in today's world. Thank you so much.
think we'll be having a lot of time to discuss, so we'll pool all the discussion together. So I'd like to invite the next speaker, Dr. Kshitiz Raizada, to speak on frugality versus lavishness.
Good afternoon, everybody. My topic for today is frugality versus lavishness. How to choose while expanding your setup. I am Dr. Kshitij Raizada and I am currently practicing as a vitreoretina, uvea and ROP specialist. And I completed my fellowship in the year 2021. 3 years back, I joined my father, who has been practicing as an anterior segment surgeon for the last 30 years in our hometown, Bareilly. So while jumping into private practice right away from fellowship, I had to choose between frugality and lavishness. So this is what frugality looks like. And this is what lavishness looks like. And what we need to keep in mind while choosing between the two, that the ultimate goal is that we need to deliver quality patient care along with patient satisfaction. So just like me, someone who wasn't good on financial wealth right after fellowship, so you have to bank on your family backing to build up your own practice. So it's more or less like a kid looking to purchase a toy from the toy shop. And the kind of toy that you get to lay your hands on depends on this. So I'll be discussing about the setting up and expansion of the vitreoretina setup, and I have no financial interest to declare. So coming to the vitrectomy unit, the Constellation by Alcon is considered to be the king in this area and is considered the benchmark, but it does come at a price. So the alternative for this is Reticare, which is an indigenously developed product, and it is quite cost effective. It produces excellent surgical outcomes, the service is prompt, and it is compatible with Alcon consumables, and a lot many retina surgeons all over India are currently using Reticare. Coming to imaging, I have a colleague of mine who started off his practice with Mirante. Mirante comes at a whopping cost of around 1.5 to 2 CR, and it is practically not possible for everyone to start at this scale. So we have different options ranging in all the different price ranges manufactured by Appasamy, Remedio, Topcon, Huvids, Idon, Clarus and Forus. One of the most frugal setups includes the DIY smartphone imaging, and the choice that you make depends upon what your needs are. Whether you are seeking for detailed information to help in decision making, or you want the fundus images for documentation purposes or for screening purposes, or you're looking for high quality images to present them in for academia and the conferences. Coming to microscope, Zeiss and Leica are the big players, and they both have German optics, and they are established names in the field of surgical microscopes. And the models range in different price ranges, and what kind of model that you want to go for depends on this. Coming to viewing system, Resight is considered as the benchmark, and it is the most popular viewing system, but it does cost a bomb. So alternative 2 is the disposable biome with Oculus, which comes at a fraction of the cost of Resight, and the image quality is almost as good as Resight. The contact viewing systems developed by Vogue are the cheapest which are available in the market, and many established surgeons in India and all over the world are using these contact systems. They produce excellent view of the posterior pole as well as the periphery, but the downside is that there is a steep learning curve when jumping from non-contact viewing systems to contact viewing systems. Coming to the lasers, again we have a plethora of choices. If you fall under this category, then You can choose from either of these. No questions, hands down, and excellent performances. But if you belong to this category, then probably this is a smart choice for you. Cost effective, it is precise and accurate, prompt service, and it is easily portable from the OPD to the IPD and even to the NICU for ROP purposes. We now have several indigenous companies which are producing excellent products, and we can rely on them, and these companies have made it easier for young practitioners to build and expand their practice. So while expanding our practice, we need to realize that it is like an abyss and there is no end to it, because there are multiple avenues over which you can think of expanding your horizon, and you can feel under the weather. So you need to make your choices smartly and proceed accordingly. And while finalizing any product or any service, always seek a demonstration from the company and seek advice and the feedback from the existing users, which will help you know all the pros and cons of the product or the service that you are looking for. You need to strike a perfect balance while purchasing any product or any service, because it should be value for money. The patient's safety is paramount, and it should be delivering good surgical and medical clinical outcomes. The hallmarks of a great surgeon are adaptability, confidence, and perseverance. The good surgeon always holds the onus of working on any kind of surgical equipments that have been provided to him or her. Once you have all of these, you start building your brand on everyday basis, and once you start doing that, then growth is the inevitable outcome. And what might have been unaffordable for you at one point of time might be well within your reach with time to come. No dream is too big, and sky is the limit. Thank you. Thank you for my.
Thank you so much, Kshitij. What equipments are you using right now?
The vitrectomy unit that I am using is Reticare, and it's been for the last 3 years. I got trained on Constellation, Lumera and Raysight. So initially when I began my practice, I did feel that there is a bridge, but that bridge is not too difficult to jump upon. You take a few number of cases, and I feel that you get the hang of it.
How did you know that I'm going to ask you that question?
I anticipated it.
See, the challenge when I started my practice, in my fellowship, and the hospital that I was working in had Constellation, Raysight, and all the top facilities. So I had that mental block at that time that I need to invest that much money. Now when I'm going in second round of expansion and buying more stuff, then I'm more confident in going for the cheaper options. So you straight away jumped from a very very good equipments to probably not that good
we
equipment.
had the luxury of seeking demonstrations from all the different companies during the course of our fellowship, and our mentors were very proactive in helping us choose them. So it wasn't like that I was taking I wasn't totally unaware of the performances of the machine. So I had operated on few cases during the course of my fellowship. So I had a fair bit of idea what I am going to deal with in my private practice. So it was a calculated decision that I made.
So, Kshitij, just to add, I think even if it's your Pitaji ka paisa, it's important to be frugal. It's important to know that you're making the right investments and getting an ROI on it. Of course, I think things that are important for you to get good clinical surgical outcomes are the most important, and probably it makes sense to spend more on it. But other things which patients don't demand or which are not affecting your outcomes, I think are areas where you can be even more frugal about.
It is, rightly said.
I had a question for Dr. Aditi. So
can we have a mic for her?
Yeah, there's a mic. So you're a part of multiple group practices.
Yeah, 3 as of now.
3 as of now. So also I thought there are different types of group practices. One where you are an investor and a partner, because you mentioned financial stability. I think a certain amount of financial stability from a group practice would come only if you are an investor, whereby you get a share of the overall revenue, etc. But that apart, how do you manage the dynamics of different groups? Because and I assume they are in the same city?
Yeah, so in Delhi it is just... Yeah, so Calcutta it is 2 practices, 2 different setups. that I'm doing. But then again, no cross-sending patients. If you are getting a referral from that particular setup, be sure that they're coming there. So that has to be maintained. Delhi, I don't face that because I'm only with one group practice. And so there are some group practices which give a basic amount. Even if you're not getting a total number of patients, there is a cutoff. And once you start getting your own patients, then you can shift to a percentage-based practice or a basic total package. So just coming from an institution to a new city, so I shifted cities during COVID. So then coming here and rather than going to an institution, then I had to restart my own practice. So that helped me out a bit.
And people have a tough time managing multiple practices in the same city. How are you managing different practices in different cities? And it's not even Gurgaon, Delhi, it's Kolkata, Delhi.
So I'm very thankful because I had my practice via Shankar Nethralaya. I was posted as a consultant in Shankar Nethralaya, Kolkata branch. So for 3 years, I was working there as a consultant. So in 2020, when I shifted, there were many patients whom I had, referred to other cornea practitioners who were working there or in the same institution as well, because I was the only one doing ocular surface. So they used to always tell that they are looking for you. So once I started, they only approached me that maybe once a month you can come and we'll keep the patients for you. So I've been lucky in that way. Thank you, sir.
About freelancing, and we didn't cover that much in the presentations. Why do you see more of oculoplasty people doing so much freelancing? Why is it so much more viable for oculoplasty people than for others? And how do you think others can make it viable?
I think it's because there's so few of us and it's a relatively niche subspecialty and everybody is not trained. Yeah, it's extremely portable. You can just carry your loop, and Akshay can tell better.
No, I think all the options, all the answers that we were hearing make sense. Like you said, there are so few of us. It's less technology dependent. We don't need a Quattro or S-Class. We use our auto and go everywhere. Also, I think in oculoplasty, most cases are surgeries are single intervention where long-term follow-up is not particularly needed, unlike retina or glaucoma or pediatric ophthalmology or even surface. If it's like say if it's a nasolacrimal duct obstruction, it's a DCR and the patient is sorted. Long-term follow-ups are not needed. So it works well for a freelancer to go for a single visit, operate and get that done. Chronic follow-ups is not much of a part of oculoplasty. The nature of the specialty is such that it entails itself to become suitable for freelancers.
I think also from the the point of view that it is niche and it's really unique, and not every general ophthalmologist is able to do the oculoplasty on their own. I mean, it's a bit more general surgery than ophthalmology from our point of view.
Yeah, because like you said, anyone who sits and spends a week in the retina OPD eventually knows which patient needs an anti-VEGF, but that doesn't happen with an oculoplasty.
For somebody starting out, I mean, any suggestions as to how they can increase their revenues to begin with? Do you think it's good to open up the center to more surgeons coming in and operating? Or do you think we can let other people use diagnostics? What are the ways, I think, that maybe Dr. Digvijay, if you can?
Yeah, so I think when I set up my center and my practice a few years ago, I did get a lot of like-minded people to come together. All of us from RP Center were there, but looking after specifically retina or other subspecialties, cornea, oculoplasty, Sorvi Khurana was looking after oculoplasty. So that way it does help to open it up because, and also improves the patient experience of the patient care at your center. When they come to your center, you know that this patient has got this problem, you refer to them, you are trusting that they'll get the right decision or the right treatment as well. But as far as from a revenue point of view, that too helps because then over time, people realize, or at least in the market, the word spreads that, if you go to this center, you'll get sorted no matter what. You won't have to go elsewhere. The flip side, though, is that sometimes it does become an issue because patients who've shown you once now and they're coming to show the other group practitioner, the subspecialists, they don't want to pay again. They feel that, they've done it and everything should happen in one go. So I did get a couple of reviews there where it turned out that, I've already paid for one person, why am I getting to pay for another specialist? So sometimes it works the other way around. But in terms of utilization of all your equipment and machines, if you have more doctors coming in, the equipment is just the same, it definitely helps the revenue.
terms of scaling up the practice. Okay, right. So the practice that I am in right now, we have around 5 doctors that are working. Some of them are part-time, most of them are full-time. I feel what it has worked for us that we have been able to add specialities, right? So a cornea person has come in, an oculoplasty person has come in. So, and as Dr. Digvijay was saying, a lot of patients, when they have that trust in you, they also trust the doctor that you are referring the patient to. So most of our patients, they are very comfortable in our system. They know the staff well. They know the system of the hospital. They know that lootne nahi wale hain log, so they want, you know, things to be taken care of there. So it is working well for us, bringing in more specialities.
So there's another question again coming from the revenue in that standpoint, and now from the perspective of other doctors using your practice. So actually, how do you keep your rates and constant across the city in different places that you would go to, or does it vary based on the center?
I think having uniformity helps, because over time, as you keep visiting different centers, you'd end up going from one place to the other, and I'm sure it happens to a lot of people. The patient goes to a second opinion to a different place, and they end up calling you, and then you are the same person they meet again. And they're like, "Arey, aap hi ko dekh rahe" type. So, in that sense, you know, having uniformity helps. But geographically, that may not always be possible, especially in Mumbai, it's like a north-south divide. South Mumbai is almost a different country GDP-wise, so their prices tend to be a little higher. So, yeah, so we try to maintain uniformity. I think one topic that wasn't touched upon, which also I think now is a very important part of practice building and brand development, is optimal use of social media. But I think the young ophthalmologists are more or less quite adept at it. So, no, I think everybody is, you know, maxing their game as it is. So, it's just making sure. The only thing that I can add is to cover all bases, use all channels of social media optimally, and interlink them, because in 10 years from now, word of mouth is not going to be as powerful as patients referring themselves to you by looking you up online. So it's good to have a positive digital footprint online. Your reviews, your as much as information, or positive information of yours in your own words, in your web page, your visibility on hospital websites, all of that cumulatively is going to help. So just cover all bases.
So, and do you think there's a role of PR as well in terms of media or other things that come about? Should young doctors be investing into that aspect, or do you think if you were on social media, it's probably more reach?
I mean, they can. So in terms of, I am assuming you're asking in terms of search engine optimization, to pay people to get that done and things like that, or to have.
Yeah, a bit of that, and then online blogs and other things that people put up for you, essentially.
Yeah, so that may help, but I'm not sure how much of that reaches the patient who is going to look you up online. And you know, oftentimes patients are smart. I think we shouldn't insult their intelligence. They can see through all of this. Sometimes they know what's a genuine review, what's a genuine blog, what's a genuine article versus something that doesn't, that's sponsored, or, you know, a PR exercise. So keeping yourself genuine also is important.
So the way the patient, as Dr. Akshay was pointing out, the way the patient selects the doctors now has changed drastically. Earlier it used to be, you know, some colleague or some, for all specialties there used to be fixed doctors that the family goes to this person. But now we see that in Lucknow also a lot of new population is coming in who do not have that many contacts, right? So they tend to look up online. And you were asking about PR. I think PR helps in the search engine optimization and those things. So a lot of people do it so that at least if you have the buzz going around on the net,
yeah,
it automatically you know, pushes your profile up.
Yeah, and I think particularly in towns like, I mean, I've seen in Gurgaon, for example, where there's a lot of mobile population that's coming in and going out, corporate people, you know, who are posted there for a few years and they'll move out. kind of helps them find you faster. And here word of mouth doesn't work that much because they're there for 2 years and then they're transferred somewhere else. And but I think Delhi, on the other hand, is a little different. Delhi tends to have a more stable population, people who've been staying here for a long time, and so that word of mouth aspect does happen. But I think even today, while we're all we may all be doing a lot of subspeciality. Even today, for a lot of the towns and cities, still it's the general ophthalmologist or the family ophthalmologist, if I could put it, where people would go for everything, and and then from they can refer on to the subspecialist further on.
Can I ask a question? Yeah. I mean, I just wanted to ask, how do you go about with patients, since you're talking about reviews and PRs? So how do you go about with people who give bad or negative reviews about you? So how do you go on getting it with those, like sometimes even those reviews are also false, and sometimes there is a genuine concern. So not to have those, and how to make it better.
In my main hospital's profile, there are around 800 reviews. So in the past 2 years, we have had 2 negative reviews, and in both cases, we have reached out to the patient. And one patient, we were unable to reach out, so my staff checked the profile. He had left a review for another doctor. We contacted the doctor. He told us which patient this is. Then we reached out to him, and the problem that he had, we were able to solve. And then he changed his reviews. So you really need to reach out to people. They are just angry. You need to pacify them. Most of these issues are really small issues. One was disturbed because the medical representatives were allowed to go in before him. So he wrote a review for that. Somebody was not sure that what kind of lens has been put, so we called and showed him the kind of lens that had been put. We have fortunately not faced any fake reviews or fake bad reviews as such. So I'm not sure how to handle them, but you need to reach out to all these patients and correct what has been.
Yeah, so I think we have had fake reviews, and that does happen, especially with Google, because people can just post a review there. So the only genuine way of getting over it is by getting more and more positive reviews and genuine positive reviews. So we had actually an occasion where we fired a counselor who was kind of misbehaving with patients. And the day the counselor was fired, we got some 21-star reviews done by his friends and relatives. So that was kind of like a wake-up call for us. That's when we realized that we really need to start working on getting our actual patients to review so that we can overcome that. And we did. But that was when we started telling our staff and our coordinators to start working actively on getting positive reviews. And unless the patient, or even if it's not a patient, if it's anybody, unless they've posted something offensive or inappropriate language, Google's not going to take down that review. It is the only way you can do that is by getting more and more positive reviews.
I think Google and I think a lot of these platforms which have reviews allow you to respond to the reviews as well. So you can actually respond to the review in a positive sense, and generally somebody who's looking at reviews to choose you, then we'll also be looking at the responses that you give. So if somebody has given a response, say, I was waiting too long, or I didn't know about the lens, and you're giving a response that we understand your concern, and feel free to connect with us, or there would be a lens sticker on your discharge slip. If you're giving them a response about it, then I think somebody who's looking at that review would also look at that response and then make a an informed decision.
It's good to have some negative reviews also. Recently a patient told us that you do not have any negative reviews, so it looks a bit fake. So
one more thing I think we should need to add to this is getting a testimony from the patient, and better to have it in his own handwriting or his mother tongue, because on Google we do tend to have English written consents or maybe the reviews. So these are some things which will help your institute or your place to grow. So having a good testimony, if you can add in onto your Insta or maybe your Facebook or your Google in the patient's this thing, and secondly, actually having it in the mother tongue of the patient. So that becomes easier, and if it is written in letters also, even that can help.
True.
So, yeah, I was just saying, bad reviews are like complications. You're going to have them sometime or the other, and you have to figure out a way. Yeah, to echo what Digvijay said, I think in TripAdvisor you see that often someone gives a bad review for a hotel and the manager responds with, thank you for your concern and we look into it and this is something we want to work on and blah, blah, blah. So I think giving a positive spin, that really helps.
So let's have a group photograph and we'll wind up this session on practice management. The speakers can come, and we're going to have the free paper, the finals of the free paper session next in this hall just after this.
आप गिर गए डॉक्टर ऋतुजा So we will have the free paper finale, and may I invite our moderator, Dr. Kaushik Tripathi, who will in turn invite us.
Now may I invite Dr. Akshay Nair, Rohit Saxena sir, is he here? Dr. Bhalla sir, Dr. Kirti Singh ma'am, Digvijay sir, Dr.
I will judge alone.
You are a judge. So we have Dr. Mainak and Dr. Ashish Singh who are joining. Dr.
As?
Dilakant, you are a judge. As judge. So
Rohit sir, please join us. So you are going for the talk, no? कितने आते हैं उसको देखते हैं।
अक्षय कहाँ जा रहा है?
4 5 6 लोग जाएंगे।
ये तो यही है।
अकेले लाइमलाइट दी जा रही है सही। कैसे? कौशिक को अकेले वहाँ लाइमलाइट दी जा रही है।
इसमें से ना
प्रेजेंट करें। तुम्हें अवार्ड देना पड़ता है ना? इन्होंने डिवाइड कर दिया प्रेजेंटेशन से।
भल्ला सर नहीं आए।
डॉक्टर भल्ला
चले गए। कुछ ये है?
ये लगा दो फिर ये भी है
कीर्ति सिंह मैम आ रही है?
नहीं, कीर्ति मैम भी नहीं रहेंगे। डॉक्टर अक्षय
अच्छा आ रहा है। अक्षय की तो फ्लाइट है तो टाइम अच्छा ओपी सर्जन भी आ रहे हैं अपना so the OP surgeons behind this release
उनको बुलाना पड़ेगा।
पर टॉक कितना मिनट दे रहे हैं? 5 मिनट 6 मिनट
4 मिनट
4 मिनट
4 मिनट ये 4 मिनट से ज़्यादा होगा तो 5-10 सेकंड में 5 मार्क कट जाएगा।
4:30 बजे हम निकल जाना है।
पहले ही बता देना
कैसे?
वो घड़ी पे दिखेगा ना
क्या?
कितना एक्सीड किया वो बता देना।
वो हाँ वो मैं देख लूँगा।
नहीं तो यही बता देना ना कि भाई
-4 जो भी आप टोटल करो -4
ये तो और तो जजेस नहीं है, मैं बुला के लेके आ जाता हूँ अभी शायद दे मैं कॉल करता हूँ, बताइए डॉक्टर आरशी, डॉक्टर मीना। हाँ?
कौन सा शेड्यूल?
शेड्यूल लास्ट में है, 3 बजे से है जो क्या Good evening all. So this is the pre-paper finale. The 6 finalists are Dr. Khusdeep, Dr. Bhavna, Dr. Shaiban, Dr. Rakshit, Dr. Bhavik, Dr. Shrishti. Do we have all of them here? Yes. So we are waiting for our judges. 2 more judges are coming. So we are privileged to have Akshay sir with us, Rohit sir with us, and Dr. Dibakant who will be judging. So this is 4 minutes talk, and if you make overtime, then it will deduct your marks. So 5 marks will be cut every 10 seconds. So the marks will be given on content and originality 20 marks, presentation 20 marks, use of audiovisual aids 20 marks, relevance 20 marks, judges interaction 20 marks, and there will be negative marking for overtime. So can we have Dr. Arshi here? We'll have to start. So may I call on stage Dr. Khusdeep, please. Dr. Khusdeep, please come on stage. And I'll request everyone to please upload their presentations. Dr. Shaiban, I think your presentation is not, everybody is uploaded, no? Okay. Set the timer to 4 minutes, please. 4 minutes. Yes, timer यहाँ पे दिखेगा आपको 4 मिनट में दिखेगा 4 1 0.
ठीक है. Can I start?
Please start.
Good afternoon everyone. Today I will be presenting my study on long-term efficacy and safety of low-dose atropine in myopia control. As we all know that myopia is a major health burden evolving into an epidemic with 22.9% of the global population being involved. To fight this menace, low-dose topical atropine has emerged as the most effective, safe and promising treatment modality. In a pan-India study, myopia progression significantly decreased to -0.27 diopters at the end of first year and -0.24 diopter at the end of second year with low-dose atropine. In another study comparing low-dose atropine versus control, atropine showed 63% reduction in myopia progression at 1 year. But the existing literature is limited to a maximum follow-up period of just 2 years with lack of data on long-term efficacy of low-dose atropine, leaving a crucial gap in our understanding of the treatment's sustained effectiveness. Hence, we decided to evaluate the long-term efficacy of low-dose atropine in myopia control in terms of change in spherical equivalent and axial length elongation. It was a retrospective longitudinal study done at PGI Chandigarh, including children of 6 to 16 years with a myopia of -1 to -8 diopters, showing a progression of -0.5 diopter with a follow-up of minimum of 3 years. The following details were recorded and mean myopia progression, axial length elongation was calculated at the end of each year, 3 years and at the end of 5 years. Statistical analysis was performed. In this study, we enrolled a total of 54 patients. Over the course of the study, we followed 96 eyes for 3 years, 69 eyes for 4 years, and 40 eyes for 5 years. The average age of our participants was 10.48 years with a slightly higher representation of females. Now let's delve into our baseline measurements. At the start of the study, the average myopia progression stood at 1.32 diopters with a corresponding axial length of 0.57 millimeters. This is a time series plot where we are depicting the spherical equivalent and axial length over 5-year period, where we could appreciate there is a gradual flattening of the mean spherical equivalent, although the axial length is continuously increasing. Change in mean progression every year was not statistically significant over 5 years, but change in axial length elongation was statistically significant. The mean change in spherical equivalent at the end of 5 years was 2 diopters and axial length was 1.90 mm. In comparison to the mean baseline myopia progression, we observed effective control in both myopia progression and axial length elongation every year. However, it's important to note that despite being on low-dose atropine, all patients, they displayed continued myopia progression and axial length elongation, but definitely at a slower rate. So this is the only long-term study available on low-dose atropine, and it has unveiled compelling results. Thank you so much.
So what is your reason for the dichotomy in the refractive error and axial length difference?
Sir, we have done axial length on same machines, but this is what our finding is, so we are giving it as it is.
I'm
so
not saying they're wrong, but I'm just trying to
so
ask.
there is a discrepancy. So
Yes.
axial length elongation, it is showing continuous axial length elongation, but the main progression was not there.
Okay. No, I'm just asking, is there any way you could explain this? And this has been seen in a lot of publications.
Yes, sir.
A lot of all across articles have shown the dichotomy between the refractive error.
We really don't have an answer to it.
Okay. Look it up. A lot of people are talking about the anterior segment change, that is refractive error change that is happening with
Because of the
with atropine.
lenticular thing and because of the cornea.
Because of the lenticular change, basically. Because atropine you expect to have some anterior segment effect. Great, well done study. That's really good to have a good follow-up.
Any more questions?
Thank you.
Thank you, thank you.
Dr. Bhavna?
Good afternoon, esteemed judges. I'll be talking about surgical management of bilateral congenital superior oblique palsy, pearls and pitfalls. So, as per recommended by Jampolsky, superior oblique palsy may be considered bilateral until proven otherwise. However, there are rare cases in which no signs of possible bilateral involvement exist, yet the surgeon is surprised to observe development of SOP in the other eye post-operatively. Incidence of bilateral SOP is said to be around 10%. The diagnostic criteria as per Kushner, the important ones are the reversal of hypertropia with contralateral head tilt, subjective extortion of more than 12 degree, bilateral fundus extortion, large V pattern more than 20 PD, chin up, anomalous head posture, to name a few. These criteria are applicable only in extremely asymmetrical bilateral SO palsy, so 1/4 of patients still manifest mass bilateral SOP post-surgery. So mass bilateral SOP, what is it? It is defined as following surgery for an apparent unilateral esomuscle paresis. The surgeon and the patient occasionally are surprised by the appearance of an apparent esomuscle paresis of the contralateral eye. Though some authors suggest this to be a surgical overcorrection of a unilateral esomuscle paresis rather than an actual bilateral involvement. Coming to a few cases, this first case is a case of bilateral congenital SOP, clinically, no diplopia. Park 3-step test had alternate hypertropia and Bilchowski's head tilt test bilateral positive. Bilateral SO underaction confirmed on Guyton's exaggerated FTT. Bilateral eye overaction confirmed on Hess charting. Significant V pattern of 25 PD. Bilateral fundus extortion grade 4, MRI unremarkable. The patient was treated by bilateral anterior nasal transposition of inferior oblique at 2 years follow-up. OD eye overaction is not there and V pattern has collapsed. The second case is a case of bilateral congenital SOP with exotropia. Eye overaction was more prominent in the left eye, and the right eye unveiled eye overaction only on neutralization of horizontal deviation. There was alternate hypertropia and reversal of hypertropia on tilts, significant V pattern about 25 PD. Bilateral SOP confirmed at fundus extortion, OD grade 4, OS grade 3, and Guyton's exaggerated FDT. This patient was treated by OD anterior transposition of inferior oblique and OS eye recession 10 mm combined with horizontal muscle surgery. At 1 month follow-up, patient is ortho, V pattern has reduced, and there is no over-elevation in adduction. This case 3 is a case of bilateral SOP with esotropia with asymmetric eye overaction. And bilateral SO interaction, again confirmed on guidance test. Alternate hypertropia, bilateral positive Bilchowski's head tilt test, significant V pattern. Fundus extraction on the right, grade 3, left, grade 2. Treated by bilateral horizontal muscle surgery and IO asymmetric surgery, OD 10 millimeter, OS 8 millimeter at post-op 2 weeks. Patient was ortho in primary, and V pattern had collapsed and no IO erection. This fourth case is a case of bilateral congenital SOP, OD grade 3 IO erection, OS grade 4 IO erection with alternate exotropia, large angle. Again, alternate hypertropia and reversal of tints, significant V pattern of 30 PD, bilateral fundus extortion, OS more than OD. It might be noted that 50 to 60% cases of SOP have an associated horizontal deviation. Patient was treated by supramaximal surgery on horizontal recti combined with asymmetric bilateral IO recession, OD10 and OS 80 IO. At post-op 2 years, the patient was ortho, no over-elevation in reduction either eye, and V pattern had reduced. The fifth case is the case of bilateral congenital SOP with esotropia, bilateral IO erection, OD more than OS, alternate hypertropia. SO underaction, OD more than OS, bilateral head tilt test positive, significant V pattern, and bilateral fundus extortion grade 4. Treated by OD anterior nasal transposition of IO and OS anterior transposition of IO. At 3 months follow-up, the patient was shown to have a reduced V pattern and no over-elevation and reduction. To conclude, bilateral congenital SOP is more common than assumed. Careful preoperative workup is imperative. Mass bilateral SOP may become evident later. Asymmetric IO erection cases may be managed by bilateral asymmetric IO weakening in the first sitting. Secondary surgery may be needed to correct the unmasked component of bilateral SO palsy. Horizontal deviations may be found associated with bilateral superior oblique palsy. Meticulous workup and appropriate surgical intervention lead to good surgical success. Thank you.
So, what was the basis of your decision on the amount of inferior oblique surgery you would do? And in any case, did you feel the need to do any superior oblique strengthening procedures?
In none of these cases, I needed to do a superior oblique strengthening cases because the maximum vertical deviation was found in the gaze of the hypertropia was found maximum in the gaze of the over elevation and adduction. So the gaze of inferior oblique. And IO muscle surgery was decided on the basis of the grading of the IO erection and also on the basis of the grading of the fundus extortion and also supplemented by Guyton's exaggerated FDT.
In no case did you feel the need for a Harada-Ito, a modified Harada-Ito, because that is conventionally the surgery of choice for a bilateral SO palsy?
In none of these cases, I have done a bilateral Harada-Ito.
Okay. And you saw a significant improvement in the cyclotorsion?
Yes.
Even with 8 or 10 IO recessions?
Yes. With 10 IO recession onwards and the 80 IO and ANT IO, definitely there was a very significant reduction in the fundus extortion.
Sure. Great.
Thank you, sir.
Good job.
Can we have Dr. Saiban on stage, please?
Presentation, please. Okay. Good afternoon, everyone. Good afternoon, judges. So I'm going to be presenting my study on my initial experiences with clinical outcomes and safety using iStent and iStent inject devices in the Indian population. So iStent device is a glucose company with a device which was introduced in India only in November 2021, and it is a minimally invasive glaucoma surgery device which it can be inserted ab interno that has the advantage of sparing the conjunctiva and rapid recovery in patients. And it works on the principle of trabecular bypass, which means there is direct access of aqueous from the anterior chamber into the Schlemm's canal. The aim of my study was to see if the iStent devices were effective in reducing intraocular pressure, reducing anti-glaucoma medications, whether they were safe, and how does it compare to the first generation G1 iStent. This was a retrospective multicentric study. 15 eyes were taken using G2 implantations, 11 eyes received G1 implantation. All grades of severity of glaucoma were included of primary open angle glaucomas and followed up through 6 months. The baseline characteristics between the G1 and the G2 groups were comparable. Now, when it comes to the reduction of intraocular pressure, G1 stent had a reduction of only about 1 millimeter of mercury by the end of 6 months, whereas the G2 showed a reduction in 8 millimeters of mercury compared to baseline, from the baseline to 6 months post-operatively. As far as the effect of anti-glaucoma medication burden was concerned, both G1 and G2 stents showed significant reductions. While none of the patients preoperatively were without medications, about 66% were rendered medication-free using the G1 implantations and 62% using the G2 implantation. We also did a sub-comparison between mild, moderate and severe groups, and in both these groups, IOP as well as the AGM reduction was insignificant in G1, but AGM reduction with G2 implantations was significant. When comparisons were made between combined phaco and iStent versus only an iStent standalone, G2 stents showed significant reduction in IOP as well as anti-glaucoma medications. And as far as the safety profile was concerned, both the devices showed very high safety profile. We had only transient IOP spikes, we had transient steroid responses, and intraoperative and postoperative hyphemas, which are all managed medically. So we basically want to convey that in iStent inject implantation is more effective in reducing both IOP and medication burden in Indian eyes with primary open angle glaucoma compared to the G1 stents. Both the devices, however, demonstrate very good safety profile. When it also when all the stages of diseases were compared, the G2 stent showed significant AGM reduction in all stages of the disease, whereas G1 failed to do so. And also higher baseline IOP was correlated with larger reductions in intraocular pressure. So we want to conclude by saying that G2 stent is a suitable device for use in patients in whom medicated IOP is controlled and reduction in AGMs is desired. And why the study matters is because it's the first Indian data. There is no published literature on Indian eyes yet, and it will prove as a very good tool for those patients who are suffering from AGM allergies, and also in delaying or eliminating the need for additional filtration surgeries and improve the quality of life of a patient. We, however, do have study limitations. We had a small sample size, no control group, which received phaco alone, and also there is a need for longer follow-up that is required, but we still feel that this adds a lot of value because it will bring a lot of confidence to the surgeons in India to adopt this procedure. Thank you very much. Thank you.
Well presented, Dr. Sahiba. So what was the average number of AGMs that were used in each of the groups? I'm sure you must have shown
there
that
was
in the slides.
Yeah, chart. So
in G1 and G2?
Can we have the slides again?
Slides. Can we have the slides, please?
yeah. So about it's 46% patients were on one
in terms of number of medications, AGM like 2 or 3, what was the average AGM used in each of these groups?
Okay, so overall mean AGMs used in G1 were 1.8, that reduced to about 0.36, and which was statistically significant. And in G2, a preoperative number of medications, mean number of medications were about 3, which came down to less than 1 at the end of 6 months.
Okay, so you mean to say almost a reduction of 1 AGM per average in G1 and 2 AGM in G2. So,
correct.
So that is kind of your takeaway message from the presentation, that in case you want a greater reduction, so an average of 2 to 3 AGM reduction you can achieve in with the G2 stents, right? That's
right.
your
So that
experience in
that is what we expect, but as far as counseling the patient is concerned, we do promise them at least 1 reduction in anti-glaucoma medications. 2 reductions is what will be a bonus, but theoretically speaking, and the evidence that is exhibited from the study also says that it can be compared to the effect of 2 AGMs.
Any difference in the short-term or intermediate complications post-op surgery in these two groups?
Between the two, G2 I think procedurally is an easier surgery to perform. But as far as the complications and post-op side effects are concerned, we usually saw complications only by virtue of the surgery, not by virtue of the stent so much, which was IOP spikes, probably explained by viscoretention, inflammation. We had hyphema, which is actually a desirable sign to know that the stent is in the right place. Reflux blood from the Schlemm's canal is a desirable sign. That goes away by itself without any much interventions.
Thank
you. Well conducted study. Dr. Sahiban, was there any matching done for the G1 and the G2 group at baseline?
Yes.
Because you seem to show that the mean medication was 1.82 for the G1 group at initiation and 3.2 for the G2 group?
Right.
So they were not matched?
So the baseline ocular characteristics were matched as only apart from the AGMs, which were actually preoperatively very high in the G2 group, not so much in the G1 group. All the other characteristics were matched, and they were, yeah, the differences were not significant.
Okay. And was there any blinding done for them?
Sorry?
Was there randomization done?
So this was a retrospective study.
Okay.
Yeah.
All right. Thank you.
Thank you.
Can we have Dr. Raksit, please?
Good afternoon, everyone. I'm going to present my paper on SLED shines, that is enhancing post-SLED cataract surgical outcomes. Till today, there is only just one case report available on post-SLED patients that have undergone cataract surgery. So this is a very new study that I'm going to present. This is a retrospective study of 224 post-SLED patients from April 2019 to February 2024. Here we aim to highlight the preoperative planning, the intraoperative modifications, and the postoperative outcomes of cataract surgery in these eyes who have undergone SLED. So the first picture that you see is the 360-degree Panis and LSED in which SLED was performed. In the second picture, there are limbal biopsies as well as AMG on the cornea, and the third picture is after the cataract surgery has been performed in this patient. So the main cause of the main cause of blindness in this patient or the low vision in these patients is the micropanis, which you can see on higher magnification on the slit lamp. These are the microvascularitures that develop in the central cornea because of the LSED. What are the causes of post-SLED cataract? Mostly it is due to the long-term use of steroid drops. Also the chemical injuries that lead to LSED can also lead to cataract, and the pre-existing trauma, and most commonly these cataracts are posterior subcapsular. Out of the 7 patients that I have, out of the 9 patients that I have, 7 have developed posterior subcapsular cataract. Preoperative nuances. So mostly we should concentrate on the adnexal pathology, as chemical injuries can lead to symblepharon, which can hinder our mobility during the cataract surgery. There is corneal opacities as well as corneal thinning that can be present, and we should look for the signs of failed SLED in these patients, like peripheral vascularization and diffuse opacities. Corneal evaluation preoperatively is very important. There can be thinning and epithelial defects. Also in cases of thinning, you should keep a corneal tissue on standby and avoid phaco in these cases, as high infusion pressure can lead to the perforation of the thinned out portion. Then in corneal irregularities, there is difficulty in calculation of IOL, and intraoperative visualization is difficult. In these cases, you can perform pupilloplasty or optical iridectomy. ASOCT is must for all these cases in suspected corneal thinning to look for what area has been thinned out. In failed SLED, you can do optical PK with ECC as a combined procedure. So intraoperative challenges. Patient must be counseled for adequate duration of surgery, and adequate peribulbar or retrobulbar block is must. The phaco incision must be planned at the site of clear cornea, or you can do a scleral phaco. The rhexis flaps should not be left in the hazy portions of the cornea, and replenish OVD as many times as you can, and over the cornea also, to improvise the visualization during surgery. And ASOCT findings must be considered before every surgery. And to decide the choice of surgery, maybe in thinned out corneas, you should not perform phaco and convert to ECC or SICS. In our cases, we performed the biometry by IOL Master 700, and the central 3 mm K values were taken. In scarred corneas, the average K values, that is 44 diopters, was considered, and we avoided multifocals or toric IOL. And if there is difficulty in visualizing the capsular bag, a multi-piece IOL is placed in the sulcus, and also the refractive surprises should be counseled. These are our results. Most patients had an improvement of 2 or 3 lines of on the Snellen's chart. So it is challenging preoperatively as well as intraoperatively. Steroid hastens the cataractogenesis, specifically PSCs, and IOL calculation is also a challenge. In the irregular astigmatism, we can consider scleral lens, scleral lens, Crow's lens for the post-operative visual rehabilitation. Thank you.
Thank you. You have crossed like 25 seconds after this thing. 25 seconds, so I think 10, minus 10. 5 marks for every 10 seconds.
योशी के पास तो टाइम है यार, मैं कहूँ ये कि मेरे पास टाइम नहीं है, मेरे को जल्दी करना है, तो ठीक बात है, तो तुम्हारा टाइम आ रहा है.
Did you have any cases where you had to combine them?
Yes.
So actually, your results was there for just very short period of time.
Yeah, so because of the time. So there were 2 cases in which we did the optical PK along with ECC and the lens. So actually, I will not consider them in the results, because OPK is a confounding thing in this case. So I'll remove that 2 cases.
Did any case require a secondary intervention later on?
Sir, secondary intervention as in?
As in post cataract, you had to go in again for either. So you mentioned refractive surprise.
So, yeah.
Did you have refractive surprises in your series?
Sir, no, refractive surprises were not there, but some cases developed the LSCD again. So in them, we performed OPK after the cataract surgery. No, sir. So there was, no sir, not for LSCD, sir. There was thinning and post-operatively for that.
Thank you.
Thank you.
I'll call Dr. Bhavik on stage. Dr. Bhavik.
So, good afternoon everyone. This is a study about bleb-like retinal detachment in aggressive retinopathy of prematurity. Some abbreviations. The purpose of the study was to analyze the risk factors, treatment strategies, and more important, the prognosis in such eyes, that is bleb-like retinal detachment in aggressive retinopathy of prematurity. So this was a retrospective case series. We analyzed 10 eyes of 5 infants with bleb-like detachment in the 1-year study period between March 23 to February 24. Demographic data including gestational age, postmenstrual age, birth weight, risk factors were collected. The fundus images were documented at all visits, and the treatment was strategized on as a case-to-case basis, whether they required injection prior to surgery, only surgery, or laser prior to surgery, and so on. The aim of the surgery was relieve the traction, posterior pole attachment, and also an important part was inducing the posterior vitreous, that is posterior vitreous detachment in such eyes. So this will halt the progression into a total retinal detachment. So we had 10 eyes of 5 infants, 20% were males. Mean gestational age was 31.5 weeks. Post-menstrual age at presentation was 34, and we planned the procedure or an intervention immediately. So the post-menstrual age at intervention was also 34 weeks. Birth weight was 1080 grams. Mean NICU stay was around 37 days. Amongst the risk factors, respiratory distress syndrome was the most common, followed by anemia, prematurity, and blood transfusion. PVD induction, a complete PVD induction could be achieved in 60% of the eyes. Intraoperative endolaser could be performed in 7 eyes. Immediately post-operative retina attachment was in 8 eyes, and 5 eyes had post-operative vitreous hemorrhage. So basically, what is a bleb-like detachment? Okay, if you see this image here, the nasal retina tends to mature or develop little faster compared to the temporal retina, and we have this exudation which is from the immature blood vessels along with shearing force which is developed from the area of vascular and avascular retina towards the optic disc, and this tends to roll up the vitreous like a wheel over the disc, and this starts from nasal area and goes on to include the arcades and the temporal retina, eventually goes into a closed funnel detachment. So we have various bleb morphology. We can have reniform shaped, bean shaped, C shaped, mushroom shaped, and so on. You can just name them as per your will. So if you look at the bleb-like retinal detachment, nasally the bleb, all bleb starts nasally. They can flatten out, they can die out, or they can increase and enlarge. And the more traction increases, more vascular it is, more immature the child is, and so on. All the risk factors play a role here. The challenges in management are atypical configuration, disorganized retinal vasculature, a difficulty in inducing the PVD, separating the membranes, crunch phenomena after anti-VEGF, and so on. One such example here, this is of a child who was 28 weeker. This is the right eye post-operative image at 3 months, and the left eye, again the bleb here. So this eyes were complete PVD induced, PVD induction that we achieved it. So good anatomical outcome is something that we achieve with this. This is one such example of the same child who could achieve a good vision along with the refractive error which was managed. And so this is our final outcome. This is what we want. Good anatomical outcome along with good visual acuity as well. Early intervention, quick and rapid combination therapy is what is required for the treatment of such eyes. Thank you so much.
Thank you, Dr. Bhavik. So were you able to run scans through these blebs in any of the cases, OCT scans ever?
So we don't have a optos with Octa, we have a Topcon. It is a little difficult. So we have a Claris through which images are good, but you need a very fast acquisition OCT machine. That we tried with Topcon, we could not do it for such small eyes, but maybe from 4 years, 5 months, 4 months of age, we are getting those scans. However, I am aware of the studies of such children where you can see the vitreous which is covering it, and the retinal vasculature obviously is not yet completely developed. So you have the inner outer retina segmentation is there, but it is multifocal attachments which are present of the vitreous on such scans, but very small sample size, especially from the Narayan Netralaya group.
LVPI, I believe, has a study where they have done scans.
Yes.
On
Not on bleb-like morphology.
On
they have an aggressive ROP. Yes, they have.
That will help us to understand the
Absolutely,
morphology
yes.
better. Well managed cases.
Thank you so much.
Thank you.
Thank you.
We'll have our last contestant, Dr. Shrishti, on stage.
Good afternoon all. I am Dr. Shrishti, a first year ophthalmology resident. In my presentation, Tunneling My Way into the World of SICS, I shall be sharing my experience as a new surgeon. So before we started training, we went through this manual on small incision cataract surgery to be thorough with all the steps of the surgery. We then started out with our wet lab practice. We started with suturing on foam, then on go tie. We then started with steps of SICS on the go tie. Our practice videos were reviewed regularly by our trainers, and after we had practiced on about 50 eyes in the wet lab, we shifted to the OR. At the very outset, I would mention that a trainer was always available throughout the time that we would perform our surgeries. So this is briefly about the first 20 cases. The time duration for the surgery reduced from about 1 hour 30 minutes in the first few cases to about 35 to 40 minutes by the time I reached my 20th case. 65% of the patients had a visual outcome 612 or better. Another 20% had a visual outcome of 624 or better. One patient had a visual outcome less than 660, which was later found out due to be a retinal cause, and 2 patients were lost to follow-up. In my first 20 cases, I had one complication in the form of a PC rent. So personally, the steps in which I faced a lot of difficulties was firstly adjusting the microscope and getting the focus right, then taking the brittle suture, which actually decides the ease with which the rest of the surgery will be conducted, keeping the AC formed while maneuvering with the instruments inside, getting a good and effective hydrodissection, irrigation aspiration while saving the bag. This was actually the step when I got my first PC rent, and placing the IOL inside the bag. So I think this is the older PPT. Anyway, so I had a few videos here. I think it's not playing. So these are some of the suggestions that I have that actually can help us improve our technique. So the first and foremost thing is being very clear with the steps and the intention behind each step of the surgery. Observing the masters perform the surgery in the OR is a great way to learn. Going back to the wet lab if available and practicing the steps which you're facing difficulty in again and again helps us improve. Then shifting our focus a little bit from the surgical technique, keeping our cool and focusing on our mental stability on table, trying to focus on one step at a time is very important. Following our patients in the post-op period gives a lot of clues as to what could be going wrong in intraoperatively and if some techniques need to be changed. And finally, reviewing our surgical videos if available and discussing them with trainers and seniors makes a lot of difference. So these were some of the videos that I had actually included before the recommendations actually. So here we can see that I'm trying to take a brittle suture at such a high magnification that I can hardly see where my instruments are, plus my hand is actually blocking more than half the view of the microscope. Then in this video, I'm actually trying to prolapse the nucleus out of the bag by doing a good hydrodissection, but my plane is wrong, the amount of force I'm applying is probably not adequate, and you can see that there's hardly any change that's happening despite multiple attempts. And this is a video where I'm trying to show that how a bad rhexis can actually have disastrous outcomes. So in this video, we will be able to see that there's a tag left behind which actually got caught in the IA, leading to a PC rent. So those were my experiences, and in the end, I would just like to say that keeping up, by not giving up, however new you are, will actually lead to improvements. That's it. Thank you very much.
So it's around 10 seconds. So it is up to judge.
She has the longest time, so give her the leeway for time. And excellent, I think. It's great to have you among the youngest of the youth that is present here, taking the courage and the confidence to come up here and present, and that too a difficult aspect for all of us. Our first few cases, I think all of us will never forget for the tough times they gave us. But of course, looking back, it's always a pleasure, but good that you had the courage and the confidence to come and present, and what you have learned from it. And that is something that I think all of us must take home from that learn from your mistakes and learn from the errors that you make and go back and look again. So I think all the best to you for your future.
Thank you so much.
By the time we calculate the numbers, I'll request Dr. Karan Bhatia to please come and tell us what he plans for YOSI in the next year.
So, thank you, Kaushik, and thank you, all of you, for being here for this wonderful event. It's a grand success. We've had good registrations. Trade has helped us out a lot as well. Sonal is here. Sonal, can you come up? Okay. So, what plans for this? We're going to do a better and a bigger YOSICon next year. But elections are on the time, and please vote in high numbers for your candidates of your preferred choice. The only one who's fixed is Dr. Devakant, who will become the president after June, and Dr. Sonal will become the immediate past president. So those two members of the governing council are fixed. The rest, including myself, are not sure whether we will be part of the team or not. It depends on you. So no. So the next team will decide when and where we will do this event. At the same time, we will have our online platforms that we are doing by the various presidential groups, like the socio-cultural, medico-legal team, the ocular trauma team, the ocular emergency team, and finance team, and so many things. Those will all continue. Please contribute, become a part, and encourage your friends. We have still not tapped into a bigger chunk of young ophthalmologists. We should make it at least we should get, one person should get 5 people as members. And those 5, one will get 5 and our society will increase. We have to get every young ophthalmologist, every PG as a first year becoming a member of YOSI and AIOS. Okay, thank you. Do we have the results? Huh? So Nilesh? Dr. Devakant, would you like to say something? Dr. Sonal bhi thi yahan pe. Yeah, Sonal, would you like to say something?
Is this the valedictory or the free paper? My first question is that. Okay, so I have to say about the free papers? Okay. So first of all, my apologies. I was to be one of the judges for the free paper. But my 8-month-old son was upset with me. So I had to rush back because I had been here since last 5 hours almost. So giving him time was a little more important right now. And now I want to give a special message to all the ladies out here. We wish to see you in higher numbers in the YOSI leadership. Please apply for the YOSI elections. Come forward, okay? We need more yo-yos. Yesterday I was told that young offspring of young ophthalmologist is a yo-yo, YO square, that's my son. So we need more yo-yos here. And jokes apart, we need more women in leadership. Things change when women step in. I would not say that they change for the positive, but they do change. So let's bring that change. And not saying that I'm not welcoming the males here, but they're already here. Most of them are already here, and they will be here. It's easier for them to travel. They don't have to request someone, please take care of my baby and come along with me. So that's one advantage that they do have, and they don't have to make special arrangements for their travel. And they don't have to ask, will I get a cab at night at 12 o'clock after the YO night is over? So lots of things are there which are already in favor of men. So let's bring women here. This is not Women Ophthalmology Society. This is YOSI, and yet we need more women in leadership over here. So I just hope that I see more faces next year and more female faces. And then once they join, they shouldn't stop working. That's also important. So I was missing in the last 2 events because I was not well, but I did my fair bit of work online as much as I could contribute via sending video messages and by taking care of the things which I could at the back end, getting memento mail, lots of things which do not need your physical presence. So I do hope that I see more females around next year, and also I see more people who are not just ready to win elections but are ready to work for the next 2 years for YOSI, for leaving a legacy behind, because all those who are right now standing here will become mentors, will be moving on to the next post somewhere else. They will no longer be a part of YOSI, but those who will be coming after them will need a place to stand up. You know, like you stand on the shoulders of giants in a way. We have had that privilege of being supported by AIOS, but now further we have to carve our own path. So that's my message to all of you. And thank you so much for making this conference a huge success. Thank you so much. Devakant? Where is Devakant?
So a lot of people are actually who are working are not executive members, they are not elected posts, but they have the interest. So they are working, and that's how the society goes aage.
So we have the results. So
So my marking was very close, and I think all of them marked very close. The totals are very close, and everybody did a wonderful job. It was excellent to see. We had senior among the young ophthalmologists, and we had the youngest among young ophthalmologists. We had all specialities being represented, which is very good, because in my time as a senior resident, if I was presenting my specialty, we had to find places to present. In fact, I've been working on myopia for a very long time, and I would get an invite to a general ophthalmology conference, and I would talk about prevalence and progression of myopia, something like that. And my talk would be bang in the middle of the refractive error correction session. So after LASIK, I would be speaking on prevention of myopia. So that was, you know, the ultimate insult that you could give. But that's why it's very glad to see that, you know, there is this broad interest in all subspecialties among our ophthalmologists, and it actually gives you a USP. You get a niche in this area, besides, of course, the cataract expertise that you are getting. So again, congratulations to each one of you who was here to present, and it was wonderful to listen to the future of ophthalmology, which I can see is very bright. So I'll start with the third. So the third prize goes to Dr. Sahiban. Congratulations. हाथ मिलाना चलो ठीक है all the best. The second prize goes to Dr. Khushdeep. Excellent. अच्छा ठीक है आने दो oh yeah congratulations, lovely study, excellent, all the best. So first किसको देना चाहिए? हाँ? और कोई? तो ऐसे करते हैं एक audience award भी रख लेते हैं. The critics award, as you can call it, no? So yes, of course, as I mentioned, everybody was good and others were good, but the award has to be, the first prize has to go to one person, so it's Dr. Bhavik who got the first prize. And again, a wonderful study, an extremely important, considering the importance of ROP and the issues that are developing and the absence of good quality eye care being provided at the primary level to prevent it, and at the tertiary level to ensure that we can provide some visual rehabilitation to these. So congratulations for a great paper.
For those students here, you don't know Bhavik. Bhavik is the director of LVPI Vizag. For fellowship interviews, so judge मैंने नहीं किया, आपने किया है. But yeah.
इन लोगों के साथ फोटो तो करा लो सर के साथ. Sir, one group photo with all the winners. All the contestants, all the presenters, you're all winners in some way or the other. Please.
Everybody can come.
पहले एक free paper ले लो, then I guess everybody who's taken the effort to remain till the end.
Please.
Sir, एक दो हॉल और चल रहे हैं.
अच्छा नहीं तो एटलीस्ट यहाँ तो बैठे फ्री पेपर पे बैठे वो थैंक यू. आई थिंक सारे आ जाओ, एक बार आ जाओ.
फोटो एक ही बार आ जाओ बाकी अवार्ड्स भी अनाउंस करने हैं.
तुम्हें अगली कॉन्फ्रेंस भी अवार्ड लेने आना पड़ेगा. आ जाओ.
society groups, whoever.
Hashtag YO Society India. That's what Instagram handle you're supposed to tag that. है ना?
The best photograph. The best photograph will get an award.
This year, next year also we are going to have an influencer award. सबसे ज़्यादा post डालते हैं उसी के लिए.
योगा सिंबल का नाम
Congratulations. Lovely. Excellent. Chalo, thank you. Thank you.
Okay, we're going to have announced the rest. अभी पिक्चर बाकी है. Last list of awards सुन लो. बैठ जाओ 2 मिनट.
बेस्ट पेपर ऑफ द सेशन. ये BPOS क्या है? बेस्ट पेपर ऑफ द सेशन ही है ना? बेस्ट पोस्टर ऑफ द सेशन थोड़ी है. पोस्टर है, पेपर है. पोस्टर.
Because is free paper 1 का बेस्ट विनर, free paper 2 का विनर, free paper 3 का विनर.
ठीक है.
ये तो हो ही गया. कहाँ मिलेगा?
So best paper of the session, free paper 1, Dr. Kushdeep Abhepal. Free paper 2, Dr. Saiban Sethi. Free paper 3, Dr. Bhavik Panchal. हाँ.
Same ही जीते हैं. You are the winners of your respective sessions. That's why they are here.
E-poster 1, Dr. Rakhi D. Cruz. Congratulations. E-poster 1, second prize, Dr. Swati Goyal. Third prize, Dr. Kajal S. E-poster 2, first prize, Dr. Afsana. Then second prize, Dr. Saiban Sethi again. And third prize, Dr. Riddhi Shethia. Congratulations to all the winners. Okay, sorry.
So, winner for SAS, the first prize goes to Dr. Prasanna, which will be his last prize for YOSI. For second prize goes to Dr. Shruti RS, and the third goes to Dr. Saloni Sinha. And E-cases SAS, it goes to Dr. Sonam Yangiz, Dr. Kishti Sarupriya, and third will be Dr. Subha Prashad. And coming to York, the winner is.
So for the York session, we had very interesting cases, and we have our winners here. We have Dr. Nikita Gupta, she won the first prize. Dr. Dhwani, she won the second, and Dr. Arjun Arora, he won the third. And York cases, we have the winners as, I'll go the other way around. The third as Dr. Gajashri. The first is tied between Dr. Ritika Gaur and Dr. Divya Nair.
So YOSICon is the video competition, the YOSI video competitions. The first prize goes to Dr. Shruti RS, second to Dr. Subha Prashad, and third to Dr. Nawaresh Sheikh. YOSICon 2 is the retina video competition. YOSICon? No, ulta bol rahe ho. Yeah, so YOSICon 1 was retina, YOSICon 2 was the anterior segment 1. The first prize is Dr. Ronak Solanki. Second prize yahi tha, bhag gaya. Aditya Sethi, pediatric. And third is Sonam Yanges. And e-video competition, no. हटाओ इसका नाम. इसको हटा दो. किसी और को देंगे. No winners for you, man. Prasanna V. Ramesh, first, second, Subhar Prashad, again second video, and Soumya PP as the third. So we have to make a motion here. No more awards for Dr. Prasanna. Banned. So what we do is, okay, we do this. I think we can close the conference for now.
We also have to ban Dr. Kaushik from any more YOSI quizzes.
No. It should be like this. I will not. So Sonal, with your permission, we would like to conclude and close the conference. No, no. Yes, let's have a group photo for everybody. All the halls? Yeah, okay. ठीक है, ठीक है. हाँ हाँ.
I would really want to appreciate our ushers from Hall A, Hall B and Hall C, especially with managing all our mementos, with coordinating everything. And a big thanks to the AV team as well, where we had a flawless relay of the entire program. I think Dr. Karan will give a vote of thanks.
So big round of also this conference would not have been possible without the support of our conference, our sponsors, Cipla, to Entor, Drainer, Hoya, Johnson & Johnson Care Group, Zeiss Group, Ajanta Pharma, Intas, Centaur, Mankind, AbbVie, Ipca, Zydus, Sun Pharma, Numetics, Ben Franklin, Jaggi Brothers, Remedio, Microvision and Lupin. So thank you. We want more sponsors next time. So. And a big thank you to the Grover Media Group, Habitat Center and their team, and AIOS for continuous support, without whom this conference would not have been possible. And a big thanks to also the planning team who made it possible for the YOSI scientific sessions as well as the Bio Night. And a big thank you to our executive team, and I would also thank Dr. Sonal, our president, and the governing council for their exemplary and outstanding work. Thank you so much.
Can you have claps for the organizing team? They have been working, there is no secretariat, they are doctors and they are giving their time for this wonderful conference. Excellent, thank you.